Good morning to one and all present here. I'm Dr. Ankita G. Cheleng, Senior Resident in the Department of Radio Diagnosis, AIIMS Bhubaneswar, and I extended our warmest welcome to our esteemed guests, the pillar of our fraternity, our senior consultants, respected faculty members, members of organizing committee, and residents to AIIMS Bhubaneswar for the 51st State Radiology Conference 2025. So without any further delay, for the first session of drainage and biopsies, I would like to introduce you to the panel of the chair people. Dr. P.K. Dash, Senior Faculty and ORIA President, Dr. Hemant Nayak, Associate Professor, AIIMS, Department of Gastroenterology, AIIMS Bhubaneswar, Dr. Kanhaiya Lal Agarwal, Additional Professor and HOD, Department of Nuclear Medicine, AIIMS Bhubaneswar, Dr. Biswajit, Senior Consultant, Radiodiagnosis, Kalinga Hospital, and Dr. Vivekananda Nayak. Deepak Das, sir, for the session on draining pancreatic collection, evidence techniques, and best practices. Currently, he's working as a consultant in intervention radiologist in Blue Wheel Hospital, Bhubaneswar.
Morning to all. We'll start the sessions. And in the first session, the speaker is Dr. Deepak Das, and he will be speaking on draining pancreatic collections. Over to Dr. Deepak.
Hello, very good morning to everybody. I'll be speaking on draining pancreatic collections. Acute pancreatitis is an inflammatory process, intrinsic inflammatory process of the pancreas. There are two types of pancreatitis. One is interstitial pancreatitis. The other is necrotic pancreatitis. And out of these collections, this acute peripancreatic fluid collection, they occur in interstitial type of pancreatitis. There is absence of necrosis. There is interstitial edematous pancreatitis, which by the end of 4 weeks proceeds to a pseudocyst formation. In acute necrotic collections, there is presence of necrosis, there is necrotic pancreatitis, and by the end of 4 weeks, it progresses to the formation of walled-off necrosis. I would like to show you, this is interstitial pancreatitis. There is peripancreatic fat stranding, pancreas is edematous, there is loss of architecture. This is necrotizing pancreatitis. This yellow head shows enhancing remnant pancreas, and the rest is all necrotic, but it is not walled off. This is not non-walled off acute necrosis. Acute peripancreatic fluid collection we see in interstitial pancreatitis. In most cases, we don't need to do any sort of interventions. They are usually reabsorbed spontaneously. They do not become infected, hence intervention is to be avoided. Only when they are infected do we need to drain it, secondary infection. These acute peripancreatic fluid collections, they transit into something called as a pseudocyst, which is well circumscribed and has a well-defined enhancing wall. Out of these pseudocysts, majority do not need any interventions. 25% of them become symptomatic either because of the pressure effect or they become infected, which necessitates a drainage. This is a acute peripancreatic collection, which is not walled off, which is not limited. There is no pancreatic necrosis, as you can see. This is interstitial pancreatitis. And by the end, it becomes a pseudocyst, which has a thin enhancing wall. These also need not be treated unless and until they create any mass effect or they become infected. This is a pseudocyst. Acute necrotic collections is seen in necrotic pancreatitis, which contains both fluid and necrotic material. They are associated with higher morbidity and mortality. This is where intervention comes into picture. Historically, these were treated by surgical necrosectomies. But in patients where there are indications for drainages these days are, patient is toxic, the situation of the patient is unstable, there is a pressure effect, the patient has a feeling of being unwell. All these are indications where we need to treat them with drainages. These acute necrotic collections, or the ANCs, they may need several drainage catheters, and they need to be rigorously followed up with multiple imaging to know what is the treatment response to drainages. Here we can see that this is the difference between a pseudocyst and a necrotic collection. Here, as you can see, the internal material inside is heterogeneous. It is not homogeneous. There are few solid components. On imaging, as we do an MR, here we are able to see some necrotic material inside the world of cystic. So this is a world of necrosis. This needs to be treated. And this is the second thing where we can see air around the head of the pancreas. And this is air in the necrotic region. This is suggesting infection within the world of necrosis, which needs to be drained. This is acute pancreatic necrosis. And as it progresses to a world of necrosis. Here you can see a thin walled lining around the necrosis. And this is not limited, this is the acute phase, and this is the world of necrosis. Here we can see the remnant enhancing pancreatic parenchyma. As I told you, pseudocysts need not be drained unless and until they create any mass effect or they are infected. They usually do not need to be drained with interstitial pancreatitis. This is a case where you can see that the bowel loop is pushed aside. There's a feeling of uncomfortable in the left flank, so we need to put in a catheter. This is the same thing. Now, what is the protocol for pancreatic fluid collection? The first is that we need to diagnose that where is the collection. Second is localization, and intervention can be based on a location-based approach. Endoscopic cystostomy is done only when the fluid is approachable endoscopically in the lesser sac where it can be treated, or else here you can see that the percutaneous drainage can be done. If after both endoscopic gastrocystostomy and percutaneous drainage still the patient conditions deteriorate, then they can go in for the tract lining or the surgical necrosectomy. So what it is known as is the step-up approach. The step-up approach is initially either after localizing the necrosis, the patient is either subjected to an endoscopic cystogastrostomy or a percutaneous drainage, whichever is feasible at that point of time. If after 72 hours the patient condition does not improve or it deteriorates, we do the other procedure. That if the percutaneous drainage is done, we can put in either another percutaneous drain or a endoscopic cystogastrostomy. If still after 72 hours the patient condition keeps on deteriorating, at that time you can try for a surgical necrosectomy. But in earlier days, surgical necrosectomy was the first choice of treatment. It is now, right now, not the first choice of treatment because of the mortality and the morbidity is associated with a surgical necrosectomy. This is the percutaneous drainage. First we look at the collection, and then if the collection is deep inside and it cannot be visualized on an ultrasound, we can use the CT guidance for deeper collections. A retroperitoneal or a transperitoneal access. We put in a large bore catheter, usually 16 or an 18 French catheter, to drain out a necrosectomy fluid, and even catheter can be upsized. And finally, when the disease has shrunken or the collection is not seen, the catheter can be upsized. Catheter can be removed. Sorry. This is a world of necrosis in the pancreatic region, and here you see that there is an insertion through the anterior pararenal space into the collection, such that the holes are along the line where it can be collected out. The first is the assessment. Now we come to how it can be done for the basics. First is which is the best site where we can insert, and we need to avoid the major vessels, the bowels, and assess for the nature of the fluid. These are the multiple approaches. The most commonly used approaches are the pararenal approaches. CT guided, they can be done. Even we can try transhepatic, transgastric, along the gastrosplenic ligament or the paravertebral space, whichever is accessible and doable. The imaging is we would prefer ultrasound for a dynamic imaging. However, at times when there is bowel air or the collection is deep seated, the patient is obese and we are not able to visualize it well, under such circumstances we can also use CT guidance. It depends on an operator preference. These are our basics. We would prefer to use a Seldinger technique by which we will gain access into the collection either under ultrasound or under CT guidance, then pass a guide wire through it, which should be a stiff wire. Then we can serially dilate it with dilators and then push in the catheter over the stiff wire. These are the multiple sets which we routinely use. This is one of the cases where you can see that there is a necrosectomy, and after a cystogastrostomy we have put in, the patient deteriorated and he had to put in another pigtail into the collection. The advantage of putting in a catheter or drainage pipe there is that through that pipe also video assisted necrosectomy can be done if the patient condition still deteriorates. The complications are, there are two techniques of doing it, Seldinger technique and a direct trocar technique, but for all practical purposes it is best to use the Seldinger technique, not the direct trocar technique. The complications are very few. Sometimes it can cause bleeding or some direct organ injury. This is rare, and thank you very much.
Thank you, Dr. Deepak, and a very nice, excellent talk. If any question from the audience, we will take. Any question from the audience? No?
Okay, Dr. Deepak, if there is associated hemorrhage in the collection, if there is either infected or hemorrhage, they are the complications. So if there is hemorrhage in the collection, what is your approach to the case? Whether it changes or same way will go for drainage?
There are two things. That first of all, in the primary imaging only, we would prefer to do a angio we would rule out a splenic artery aneurysm, because pancreatitis is associated with a splenic artery aneurysm. That is what we would rule out. And if there is hemorrhage, we can also think of any vascular injury as such, if the tract chosen is through or something has happened. After the procedure, we would stabilize the patient, and then if there is a suspicion of a vascular injury, we would repeat a CT angio to look for any vascular injury.
Okay. Thank you.
Thank you so much, sir, for your insightful knowledge. I would like to introduce our next speaker, Dr. Varun Yadav, sir. He is a PDCC fellow from ILBS fellow in Pediatric Interventional Radiology, Tata Memorial Hospital. His areas of interest include interventional oncology and percutaneous interventional procedures. Currently, he is working as an assistant professor in Department of IR, Homi Bhabha Cancer Hospital and Research Center, Chandigarh.
Introduction. Thank you. Good morning to all of you. I'll be talking about image-guided biopsies. We have a lot to cover, so let's begin. So why are we doing these biopsies? Obviously to diagnose conditions, be it infection, inflammation, or a malignancy, but also in this age of molecular typing and new genomic sequences, for genetic analysis of these specimens so that targeted therapies can be given, and obviously in certain parenchymal conditions of the liver and kidney. There are no absolute contraindications as such except for uncorrectable coagulopathies. There are certain situations where you have to avoid it or where you have to first optimize the patient first. For example, if they have significant comorbidities, uncontrolled diabetes, the access is technically difficult, or if they have a history of contrast allergy, compromising renal function, especially if we are doing a CT guided biopsy. If the patient is highly uncooperative, we can do the biopsy under mild to moderate sedation or even general anesthesia. So one thing I would like to stress is you should always have a pre-procedure safety checklist. You should always evaluate the patient first on your own. Look at the clinical history, look at the imaging. Just don't do biopsy because it has been requested. Many times you'll get a biopsy from lung and you'll see on the scan that there are liver lesions as well. So always evaluate yourself first and feel free to discuss with the referring physician what can be best done for the patient. Spend time talking to the patient, counsel them, tell them about the procedure, tell them how they have to cooperate during the procedure and what all things that can happen, the possible complications. Their most common questions are, is it painful? Is there risk of bleeding? Is there risk of tumors spreading? So you should be aware of all these questions and you should have theoretical knowledge of all of them as well. Go over the lab parameters. Make sure they don't have any severe comorbidities. If it is a diabetic patient, try to take them early in the morning. Don't make them fasting for too long. Look at the anticoagulant or antiplatelet history. Most of our elderly population is on aspirin, clopidogrel for some reason. And if it allows, stop it for 5 days. If a coronary or some other stent has been placed within the last 1 year, then obviously you have to check with the person who has put it, or maybe put the patient on some lower molecular weight heparin bridging. So this is this is a European IR Association checklist, a very beautiful checklist. We have made sort of a modified version of it in our department. You should have something in physical form. Always fill it before doing the biopsies. Don't think that you have gone through the checklist in your head. Always put it in writing. It will help you remember things. Let's go region wise. Covering lung lesions first. You'll get these biopsies most of the time. Always look at the imaging. Plan the access route first. You have to take the shortest straightest path. Most of the times it may not, but sometimes it may not be possible, like we would be saying. And you can decide the patient positioning on the basis of imaging. You can do it in supine position, in prone position, in lateral decubitus position. If you're doing, say, a right lung biopsy, it is preferable to make the patient right side down. That helps in reducing the complications. We generally prefer to do these biopsies in under free breathing. Makes it less complex, makes the patient relax. They don't have to follow much commands. You can reduce the cardiac motion by obviously relaxing the patient, taking care of the anxieties. If they're very anxious still, you can give mild sedation. Avoid going through fissures, avoid going through pulla, and obviously avoid going through the chest wall vessels, the posterior intercostal vessels, internal memory vessels. How can you do that? Just go above the superior margin of the rib. So it is a dynamic process when you're doing lung biopsies. Many times you'll plan one way, but the lung lesion will move up or down with the breathing. So you can just manipulate your needles accordingly and you can very well reach the targets most of the times. Very rarely you would require a patient to hold the breath, for example, in supradiaphragmatic small lesions. And so in that cases, you generally prefer to you ask them to hold the breath in end expiration because that is more consistent. So again, avoid chest wall vessels. You locate this post-intercostal groove along the lower margin and go from above the rib. Try to limit the radiation dose. We use coaxial true-cut biopsy needles. Why? Because that way we only have to puncture the pleura once and we can do exchanges multiple times through it. What is an ideal adequate biopsy? 3 cores of at least 2 centimeter. If not 2 centimeter, then 6 cores of 1 centimeter. You get the point. If for whatever reason you are not able to take an adequate sample, mention this on the form. Send the message to the pathologist. It's a precious sample. Please process it carefully. So shortest straightest path, but for a subcentimetric nodule which is in a subpleural location, a shortest straight path might not work. We usually prefer a long oblique tangential path because it gives us more leverage to maneuver our needles. In emphysematous lungs, obviously you have to avoid the bulla, so go through the normal lung. That will reduce your chances of pneumothorax markedly. There are certain situations where you need PET CT and not just a normal contrast CT. For example, in central hiatal tumors, which cause bronchial cutoff and distal lung collapse. So identification of the tumor and collapsed lung may be sometimes be difficult. So a PET really helps in those cases for targeting the lesion properly. Again, for small pleural, subpleural lesions, subpleural nodules, a long tangential oblique path is preferable. Pneumothoraxes are one of the most common complications. The reported prevalence is 20 to 30%, but you require drainages in less than 5% cases. How can we reduce that? Try to be perpendicular to the pleura. It again may not be possible. For example, when you take an oblique path, do not puncture the bullae, avoid fissures, try to take the shorter straightest path as much as possible. Immediately post biopsy, put the patient on the puncture side down. It will reduce air entry on that side, and it will either prevent pneumothorax from developing or it from increasing if there is some mild pneumothorax after biopsy. Ask the patient when you're performing the biopsies, when you're taking covers, not to move, not to cough, not to talk. Also make sure when you're doing those exchanges of the needle, when you're taking a core, getting it out, ask your assistant to put a few drops of saline into the hollow trocar so that there's a continuous water column and air does not get sucked into the lungs or a pulmonary vein unluckily. So that is quite important to avoid air entry into the lungs. Some people prefer patching the tract with gel foam or blood clots, but we generally just pull the needle out. Obviously, before pulling the needle out, do a scan to see if there is some pneumothorax or not, because if there is pneumothorax, you can remove that pneumothorax with that same needle by pulling that needle into the pneumothorax. Immediately post biopsy, close monitoring of vitals for at least 3 to 4 hours. A repeat CT scan after 1 hour. If there is no increase in no new pneumothorax developing or no new complication, we can safely send the patient home. Obviously, explain them the warning signs. If there is increase in chest pain, dyspnea, or significant hemoptysis, please come to the casualty. And obviously, if a pneumothorax has developed, advise him to avoid air travel for 1 to 2 weeks. Mediastinal lesion biopsies. So commonly we get these subcarinal large or even small subcarinal lymph nodes to rule out metastasis, and there's one way you could go through the lung, but there's a simpler way. We just don't puncture the lung and you go through the paravertebral approach. So basically you hydrodissect your way through the in that paravertebral space, and you don't puncture the lung at all, and you can safely reach the lesion. For hydrodissection, you can use just saline, or you can mix saline with 1% lignocaine. And basically, only one structure would be there in between, azygous vein. And if you hydrodissect, if you are advancing your needle while hydrodissecting with the blunt trocar or a blunt tip stillet, you won't puncture it. So some examples of this paravertebral approach. This is again a subcarinal nodule, not a subcarinal but posterior mediastinal nodule, but in this case we could not take an approach from the right side because of the scoliotic deformity and degenerative changes, so we had to take a left paravertebral approach, which is not very common because aorta is there. But if you hydrodissect your way well and you are constantly doing the biopsy under guidance, you can very well do this approach as well. For anterior mediastinal lesions, you can take a parasternal approach or maybe a transternal approach, like in this case, because there is costal cartilage in front of the lesion as well as internal memory vessels. So the sternum is a soft bone. You can pierce through it with your just trocar needle. Make sure while you're drilling through the bone, it should always be inside. You should not drill with just the trocar, otherwise it will bend. So central lesions, hilar lesions, preferably you should do them using an endobronchial ultrasound. However, it may not be possible always, or you may be getting repeated negative biopsies. So you can take this transparent camel path. Obviously, these are central tumors, so there's risk of bleeding or pneumothorax or some other injuries. So what I would suggest is don't puncture that lesion with the sharp stillet. Reach till the lesion, use a 21 gauge Chiba needle to puncture the lesion, and over that just rotate your trocar over that to gain entry into the lesion. That works most of the time for me. And like in this case, there was only a small space between the bronchus and the vessel, but we were able to take this safely. Just an unusual case. This is a case of refractory lymphoma with a persistent uptake in cardiophrenic node. The oncologist wanted a biopsy to confirm, because if it is refractory, then they would have to change the line of chemotherapy. CT guidance seems difficult here because costal cartilages are there. There's constant cardiac motion, which we cannot account for on CT. So what we did, we placed our ultrasound probe below the xiphisternum, asked the patient to inspire, and we could see this node just ahead of the heart. And using ultrasound guidance, we were able to target this. Came out as Hodgkin's lymphoma, and further treatment was changed. So complications, most commonly post-procedure pain can be managed easily with analgesics. Pneumothorax, like we've talked about. Bleeding, some intraparenchymal bleeding may or may not happen. Don't worry about that. Just put the patient puncture side down. It will go away. It will reduce. The patient might experience some hemoptysis in the next 1 or 2 days. Mild is fine. If anything is over 100, 200 mL, they have to come to the hospital. And air embolism, although a very rare complication, but it can be fatal. So let's look at, this is one case where unfortunately we injured the internal mammary vessel and had to embolize it endovascularly. This is one case of subpleural lesion biopsy done. Immediately post biopsy, we see this air in the heart. So it's very important. If at all it happens, you have to detect it. You will see air in the aorta, or air in the coronaries, or air in the heart. Don't make the patient stand up, sit up. Let them be supine. Make them in slightly mild Trendelenburg position, so that the head is down, the air does not enter into the brain vessels. Start high flow oxygen. That will help in dissolving the bubbles. Just a point about endobronchial ultrasound. So basically, this is a long needle which goes through that bronchoscope. This is the ultrasound probe, which transducer which abuts the bronchial wall, and the needle comes through it. So we sort of get an image like this, and these can be used for paratracheal or central hilar nodes. Abdominal lesions, you will get liver biopsies most of the time. What you have to make sure, go through the liver. Be as peripheral as possible, because even if you injure some vessel in the periphery, which you should not, but if you do, the chances of major complication happening are very less. So again, give local anesthesia properly throughout the tract, as well as at the liver capsule. Create a bulge at the liver capsule, and then go through that same tract and try to, go through the liver. Never directly puncture the lesions because of risk of tumor seeding. Even if you have to go deep, just make sure you're not puncturing any major vessels. Calmly just go through in a short straight path. Pancreatic lesions, mostly they would go for an endoscopic biopsy, but if it is negative, or if they are not able to target it, you will have to do them, and you can safely do them under CT or ultrasound guidance. This is a large lesion, solid lesion in the pancreatic body, and since there is a good amount of fat there, we were able to target it very easily, percutaneous. Similar lesion, but here less fat, so we had to hydrodissect our way between the stomach and the large colon here. Sometimes we cannot hydrodissect our way. Sometimes we have to go through the stomach. So like in this case, we have to take a transgastric approach. You can get away with transgastric or trans small bowel approaches. You should avoid it as much as possible, but you can get away with them. Preferably give a 1 shot of antibiotic before these biopsies, and closely monitor them for signs of peritonitis. Again, if the intra-abdominal fat is not so much, you can even target them very easily on ultrasound. Just carefully map your tract to avoid vessels. This is a small lesion in the pancreatic head, looks like a neuroendocrine tumor. However, patient also had a history of right renal cell carcinoma, so a differential of metastasis was also kept. Did a CT guided biopsy, and it did turn out to be metastasis. So periportal node are also quite difficult. Many times you have to transgress something, either liver or small bowel mesentery. Here we did a FNAC, and it turned out to be metastasis. Unusual biopsy, I just go through it very quickly. Sorry for taking too much time. A periurethral deposit in a CS cervix case. incidentally detected at the time of RT planning, so it was sent to us. Difficult to do it under ultrasound or CT guidance, so we just placed a transvaginal probe. We could locate this and we did a FNAC from it. We just placed a transvaginal probe, very superficial. So RP lesions, paracaval approach, para-aortic approach, aortocaval approach, or if aortocaval is not possible, then sometimes anterior approach as well. Again, with abdominal lesions, there is risk of bleeding of 0.5 to 1%, slightly higher in renal tumors, lesser in pancreatic tumors or something like that. But the risk of major bleeding is quite less if you follow these rules properly. This is one case where we did a renal biopsy. There was bleeding immediately after that. Had to embolize the middle and inferior suprarenal arteries. You'll get a lot of cervical lymph node biopsy. Is easy to do. Just they are superficial, anesthetized very well. Take care you're away from the carotid space. Omental nodule biopsies, especially in carcinoma, ovary cases, and adnexal masses, you may have to do omental thickening biopsies or omental nodule biopsy, like in this case. Transrectal biopsies or prostate 12 core biopsies. Nowadays, we are going towards transperineal biopsies because chances of infections are much less. Breast biopsies, make sure that you're using a larger bore needle, like a 14 gauge needle, because the quality of sample is better in that. In head and neck, you can easily do these biopsies with a paramaxillary or a subzygomatic approach. Mostly you'll get these for parapharyngeal masses or lymph nodes. And you can even do this clival lesion biopsies, although they are tricky and you have to plan them very well. You have to do them under general anesthesia because you don't want any blood trickling down and aspirating into the lungs. So in general anesthesia with cuffed endotracheal tubes. In MSK biopsies, I would just ask you to read this, go through this article, wonderful article. It tells you all the approaches, why you need to take the approaches. The basic idea is you do not want to take a track which will not be in the surgical site of incision, because otherwise you'll have to give RT to that or excise that out completely. So for example, in this case, we have to take for a lateral femur condyle, we have to take the lateral approach. We can't go just anteriorly or from the medial side. Vertebral lesion, most commonly transpedicular approach. Most of the times we can do it, and it is the safest thing because we are avoiding spinal canal. Sometimes we might have to take a parapedicular approach if there is paravertebral lesion, or for whatever reason transpedicular approach is not possible. So just go target the pedicle, go through it. These are quite easy to do. Cervical vertebral lesions are a little tricky. Why? Because the pedicles are so thin here, plus you have a vertebral artery just adjacent to it. So usually you prefer anterior lateral approach in this case. For example, this is a case, this is a lady who had neck pain and left shoulder pain, presented, CT scan done, showed the lytic lesion C5, C6, which was PET evid. There was loss of intervening disc space. So we planned anteriorly. We planned to hydrodissect a plane between left lower thyroid and the carotid space and went through this.
Dr. Varun, can you
thank you.
wrap? Yes.
Thank you so much for your patient listening.
Thank you, Dr. Varun. So, if any question from the audience, any audience question? Okay, I have a question, Dr. Varun. So, how do you manage the bleeding, as you said, in the lung biopsy or abdominal biopsy? Can you just throw?
So, how would you detect it? You would see it on the scan itself, or the patient will start spitting blood. Turn the patient down on the biopsy side, check airway, breathing, circulation. If at all you have to put some nasal cannula or face mask, give them oxygen, talk to them, make them comfortable. Take a check scan, make sure it is not increasing, and we just follow the usual guidelines. We send a repeat hemogram. If there is continuous bleeding, we put them on Trenexa, keep the puncture site down only. If there is massive bleeding, that is a sign of trouble. You don't want the patient to drown in their own blood. Give a cardiac page, and there are very few instances when you even have to do suction and intubate the patient as well. Very rarely does that happen. 99% of the time, just basic measures like turning the patient down and giving oxygen will help.
Thank you, Dr. Varun, for a very nice lecture. So we will close this talk now.
Thank you so much, sir, for sharing your knowledge. With this, we come to the end of the first session. I would now like to call upon Dr. B.M. Swain, sir, to kindly felicitate our chairpersons and our speakers. Firstly, I would like to call upon Dr. Kanhaiya Lal, sir. Thank you so much, sir. Next, I would like to call upon Dr. Biswajit, sir. Thank you, sir. Next, I would like to call upon our speakers. Firstly, Dr. Deepak Das, sir. Thank you, sir. Next, I would like to call upon Dr. Varun Yadav, sir. Thank you, sir. I would like to request our chairpersons and speakers for a photograph. We would like to start the second session on non-vascular interventions. I would like to introduce the panel of our chairpersons. First, Dr. B.B. Panda, Dr. Subhendu Mohapatra, sir, Dr. Suprabha Nayak, ma'am, Dr. B.M. Swain, ma'am, and Dr. Ambika, ma'am. Ambika, sir. I'd like to call upon our first speaker, Dr. Varun Yadav, sir.
Good morning, and again I will try to be on time this time. Okay, so I'll be talking about percutaneous transhepatic biliary procedures. It is a minimally invasive procedure where we, under image guidance, we gain access through the skin side into the liver and into the biliary system for the purposes of drainage or stenting or taking samples, cytology samples from there, or even doing advanced procedures like cholangioscopy or endobiliary ablations. So our role is basically to decompress the biliary system to reduce the hyperbilirubinemia, which helps in treating the pruritus. Many of these patients will present with pruritus. And we can also take samples through these accesses when there is not a mass to biopsy. Basically in malignant, if it is a malignant obstructive jaundice, the purpose is to reduce the hyperbilirubinemia so that the patient can either undergo a surgery or a chemotherapy. And of course, we can do advanced procedures like cholangioscopy and ablations through these procedures as well. They are indicated in biliary obstructions, be it benign or malignant. In benign causes, most commonly your intraluminal causes like gallstones or biliary surge. Mural causes like biliary strictures caused either because of recurrent cholangitis, primary sclerosing cholangitis, recurrent pyogenic cholangitis, or after surgeries, anastomotic strictures after hepatectomies, Whipple surgery, or liver transplant. In malignant causes, most common causes are cholangiocarcinoma, carcinoma gallbladder, and pancreatic carcinoma. Biliary obstruction may also be seen in advanced gastric or duodenal carcinomas. So again, no absolute contraindication except uncorrectable coagulopathy, but there are certain situations where these procedures become really difficult. For example, if the coagulation parameters are deranged, you have to first optimize them. If there is ascites, you have to drain that first. If you cannot take care of the ascites no matter what, then endoscopic drainage is the option. If there are skin site infections, first you have to treat them. Many times there would be large tumors or large metastasis precluding your way into the biliary system, or there might be lobar atrophy, in which case biliary drainage does not solve any purpose because it will not help in reducing your jaundice unless the system is actually infected and it is the one which is leading to cholangitis. So we should be very well aware of the biliary anatomy. The most common anatomy, like we know, is right hepatic duct and left hepatic duct joining to form a common hepatic duct in which cystic duct drains, and that forms the common bile ducts draining into the second part of duodenum. This is how usually a right-sided ducts appear. Right posterior biliary system is slightly curved and joins into the straighter right anterior duct. However, in many cases, it may not be the anatomy. You might see a trifurcation of ducts, or you might see a right posterior duct apparently joining into the left hepatic duct, a common hepatic duct, or a cystic duct. So it is very important to know this anatomy. Why? Because it will help in planning your procedure, and also it will help in planning the surgery later on, if at all it is planned. You should be aware of the Bismuth-Collier classification for hilar cholangiocarcinomas. So it is a type 1 block if only common hepatic duct or distal to it is involved. If the primary confluence is involved, it's a type 2 block. If the primary confluence along with the secondary confluence on the right side is involved, it's a type 3A block, type 3B if it is on the left side, and if both secondary confluences are involved, or it is a multifocal disease, it is a type 4 block. Obviously, as you go through the types, the higher types have worse prognosis. These are the usual cholangiographic images of say this is a type 1 block with stricture at the distal CBD. This is a type 2 block with the involvement of primary confluence. This one is a type 3A block with the involvement of secondary confluence on the right side, and a multifocal type 4 block. So again, initial workup, have a safety checklist, look at the patient, are they fit enough to undergo this procedure, how long is their overall survival, is it less than a month, then there's actually no point in making them go through this procedure. Look at the laboratory parameters. We usually follow that the hemoglobin should be preferably more than 8, platelet more than 50 or 80,000, INR less than 1.5, creatinine to be preferably with the normal limit, but it may not be in cases of cholangitis. If the labs are deranged, you try to optimize them as much as possible, and always first evaluate under ultrasound. It will give you an idea of how to proceed with the procedure, but always supplement that with a cross-sectional imaging, because that will really help you in planning the procedure, which ducts to target. You basically want to drain as much liver as possible, theoretically speaking. If you drain at least 1/3 of the liver, it will take care of the jaundice. You drain at least 1/6 of the liver, it will take care of the pruritus. So for that, you need to actually see which system is the largest one, which you should be draining. Basic equipment that we use is a micropuncher set. A micropuncher set is nothing but it is a small needle, a 21 gauge needle with a 018 wire and a transition dilator of 4 or 5 French. So we are puncturing the ducts with a smaller needle, and we can always upsize it from an 018 system to a 035 system. If the dilatation is severe, you can directly puncture with an 18 gauge system and enter through a 035 wire. So we manipulate or navigate through the strictures using hydrophilic guide wires, preferably these J-tip guide wires. And once we have gone where we want to go, we exchange them for stiff wires, because on stiff wires you can actually put your stents, put your balloons, or put your other stuff like breast cytology catheters. Many times you can use an introducer sheath through the skin into the biliary system. That will help in promoting rapid exchanges, and it gives more stability. Plus, many times these catheters have a habit of dislodging themselves, but the sheath will stay in place. So the catheters can be for external drainage, like these pigtail catheters, or these long catheters with multiple side hose and this angulation which is corresponding to the CBD angle. So these are clean, contaminated, or even dirty procedures at times. Complete aseptic precautions are a must. You have to drape the patient, clean the patient very well with betadine and chlorhexidine. Antibiotic prophylaxis is very important. We usually continue them for even 7 days after the procedure, and you have to maintain adequate hydration peri-procedurally. These procedures can be done under local anesthesia if you can get an anesthetist to give sedation. Nothing better than that, because no matter how much local anesthesia you give, they will be a little painful. So these terms that we keep hearing on external drainage, internal drainage, internal external drainage, what does that mean? When we have put a catheter above the level of obstruction and it is only draining outside into a bag, it is an external drainage. Its purpose is basically 3/4 of the obstructed systems are infected, and initially when you're trying to drain them, you should drain the infected while outside. You should not let it drain inside or let the internal contents ascend into the biliary system. So at least for a day or two you should maintain external drainage so that the infected bile is drained out. Then you can internalize, and there's an internal external drainage where you are promoting both external or internal drainage, and a complete internal drainage is when you've capped the catheter from the outside and it is only draining inside into the bowel. So we preferably do internal drainage, or start promoting complete internal drainage only after 48 hours, once the antibiotics have started taking their effects and the infected bile has separated. So a right puncture, left puncture, both punches, what to do? If it is a type 1 block, doesn't matter, right, left, it will drain the entire system. If the primary confluence is involved, then should we take a right or left? Depends on what kind of surgery they're doing. Are they doing a right hepatectomy or a left hepatectomy? Do on the opposite side. What lobe is larger? Obviously the right one is larger. So if you have to do just one drainage, the right one is preferable. And so there are advantages and disadvantages to both side punctures. Left is usually more patient compliant. Why? Because the patient has less pain. They can lie supine. The right one usually causes more pain because of continuous movement with breathing, intercostal nerve irritation, and also has higher chances of dislodgement because of the movement. Advantage is that there is less exposure to the operator's hand when we're doing a right-sided puncture as compared to the left side. Also, a right-sided drainage, right lobes are larger in size, so the drainage is better. The drop in jaundice is faster with right-sided drainages. We usually prefer both-sided drainages for a type 2 or higher block, and for a type 1 block, a left-side puncture suffices most of the time. So the basic steps are left side puncture, you do it under ultrasound guidance. You can very well see the left segment 3 duct just behind the portal vein. So you try to avoid the portal vein radical. Puncture under ultrasound guidance after giving adequate local anesthesia. Once you have punctured it, you can see the bile coming out. Either you can straight away put your wire under ultrasound guidance, or you can do a minimal cholangiogram, very diluted 50% contrast 2 to 3 cc to opacify the ducts, and then you can nicely see your wire going through the ducts, and you are sure that you are in the right system. You put your transition dilators, then through that you put your hydrophilic wires, navigate the stricture, enter the bowel, track your diagnostic catheter over the hydrophilic catheter, do a gram to confirm that you are in the bowel, and then exchange for a stiff fire over which you can put your sheaths or catheters. Same thing on the right side, you can do the right sided punctures under ultrasound guidance. Many times it may not be possible on the right side because the right sided segmental ducts are small and usually less dilated than the left sided one. So you can also do a fluoroscopy guided puncture. The fluoroscopy guided puncture can be done blindly as well, where you go enter through the 10th or 11th intercostal space in the mid axillary line and direct your needle towards the mid clavicular line, and then gently you come back, slowly injecting the contrast, and wherever you see the bile duct opacifying, you put your wire. We usually prefer doing injecting subcontrast to opacify the right ducts and then puncture the major drainage system. So similarly, on the right side, you follow the same procedures and you put your catheters. You have to admit these patients. This is not a daycare procedure because again, it's a clean contaminated procedure. High chances of infection, increasing cholangitis, even increasing in the next 1 to 2 days. Admit them for at least a couple of days. Maintain good hydration because you're externally draining, so there's loss of bile salts, there's loss of fluid. And start antibiotics peri-procedurally. We usually use third generation cephalosporins like cefoperazone sulbactam. That is really good. Some people also prefer piperacillin tazobactam because it has high biliary secretion. Once after 48 hours patient is improving, the jaundice is coming down, the WBC counts are coming down, the bile has cleared, you can start internal drainage. Once you have capped the catheter, don't send the patient immediately home. Observe them for at least 6 to 12 hours that they are handling the internal drainage very well. They're not going to cholangitis again, and maybe then you can discharge or you can keep them further in the hospital as well. Complications, there is a long list of complications. What mostly happens is these catheters get blocked or they get dislodged. This is the most common complication that you will find either in the immediate phase or the delayed phase. You basically have to take the patient again, and if flushing doesn't work, then you have to reposition them or exchange them. What is the thing that can happen which is severe is bleeding. Usually the immediate bleeding that will happen will clear off in a couple of days because our bile ducts are adjacent to the portal vein and there's a portal tride, so there is a chance that you might have caused some injury. So you try to be as peripheral as possible when you're doing these punches. Don't do central punches, big no. Sometimes the patient might present with a delayed bleeding like 7 to 10 days after hemorrhagic output. So get a CT angio done to rule out a arterial bleed. And when you're getting a CT angio done, don't put your wires through the catheter and remove the catheter because that will help in increasing the diagnosis of this pseudoaneurysm or these arterial bleeds. If it is not an arterial bleed, most likely it is coming from a portal vein radical. Your holes might be facing towards the portal vein radical, so gentle repositioning helps most of the time. So basically just most of the time you'll have some catheter related complication only. Sometimes the surgeon might ask you to do a PTC gram to demonstrate the level of block, the hilus stricture or the biliary stricture, which will help them in planning the surgery or deciding whether to operate or not. So in these cases, do gram from one side or both sides if you've taken both axes, increase the frame per second, and if you have the facility available, also take a 3D CT scan. Coming on to stenting in malignant cases or even benign cases, plastic stents can be done in benign cases. Good thing is they can be removed endoscopically or percutaneously, in fact. Disadvantage is they tend to block in a couple of months. Metallic stents have better patency, but then again they're permanent, so you only put them in malignant biliary obstructions. Uncovered, covered, there's data all around, but there's no clear-cut data which is better. Covered stents sound better because there is less risk of tumor ingrowth, but then again there is risk of tumor overgrowth with them, and then you might block some side branch which might cause recurrent cholangitis. So usually we prefer doing uncovered stents. Do you have to place a stent above the ampulla sphincter or below it? Again, no clear consensus. Both work. There's no clear-cut advantage of one over the other. The idea behind suprapapillary is that you are not sort of compromising the sphincter of Oddi, so the chances of ascending cholangitis or pancreatitis are less. But in studies, no clear difference has been yet seen. So in stenting, you basically do a mild cholangiogram, and you also can do a pull-through-gram to demonstrate the length you would be required. Most of the time, a 10 mm diameter stent in this with a length of 100 to 120 mm suffices. I would urge the younger people to put less contrast. I know in these images you see a lot of contrast, but put as little contrast as possible, do as little manipulation as possible, because the patient may land up in cholangitis if you're doing too much. So after stenting, we usually tract our glue embolize our tract. You can avoid that as well with 8 French catheters. The tract usually seals off on its own. So this is basically a T-stenting where you do stenting from one approach only. Sometimes, like for whatever reason, the left-sided approach may not be possible, or right-side approach may not be possible because of ascites. You can do breast cytologies, you can do endobiliary RFAs for stent blockage, for hepatolithiasis as well. You can use balloons to push the stones out. And again, in biliary leaks, you can do post-op leaks. You can do these procedures. They are very technically challenging in bile leaks. So I think, yeah. Thank you.
Any questions from the audience? Thank you, Doctor, for your nice and elaborate talk.
Thank you, ma'am. Thank you, everyone.
Thank you so much, sir. Next, I would like to call upon Dr. Harish Bhujare for his talk on enteric axis. He is currently working as an associate professor in Department of Radio Diagnosis and Imaging in PGI Chandigarh. He has around 94 publications to his name, and his area of interests include chest and abdominal intervention.
Good morning, everyone. So I will be talking on enteric axis, how I do it, and it's basically for the percutaneous radiological gastrostomy. So as such, we know the nutrition is the most important part of our life, whether it's a normal life or within in any patient. So basically, gastrostomy is the placement of a feeding tube directly into stomach through the abdominal wall. So first successful gastrostomy was performed is way back in 18th century, and that was the open and surgical placement. After that, there is too much advancement in the gastroenterology as well as in intervention radiology, and then endoscopic placement of the tube was started, and then subsequently the percutaneous tube was placement started using the IR. So the gastrostomy can be placed via open gastrostomy or the laparoscopic gastrostomy. This is placed by the surgeon. Then from gastroenterologist can place the gastrostomy tube using the percutaneous endoscopic approach, and radiologist place using the percutaneous approach using the fluoroscopy and CT scan or the ultrasound guidance. So I will be talking on the percutaneous radiological gastrostomy. So rationale of gastrostomy is because good supportive nutrition is required to avoid the malnutrition in hospitalized patients. Most of these patients are having chronic illness, and there can be a nutritional deficiency. Patient may not able to take the adequate nutrition because of either obstruction in the digestive tract or because of some neurological condition. Patient is unable to take the feeding. So in this case, the other option is a parental nutrition, but there are many risk factors associated with parental nutrition because parental is directly giving into IV. So this is more natural pathway of having nutrition. So nutrition, if you are giving enteral nutrition, it can be given by nasogastric tube or by the gastrostomy tube. So initially, if it is required for the short-term duration, then nasogastric tube is inserted, or if it's for the longer duration, then the gastrostomy is preferred. And usually in our institute as well, the endoscopic approach is the first approach to go for the gastrostomy. Then second is, if it's not feasible for endoscopic approach, then we do percutaneous approach, because if there is a esophagus and scope is not going beyond the obstruction, then endoscopic cannot be done. Then you have to go either surgical or the radiological gastrostomy. So advantage of endoscopic versus radiological is, in radiological, of course, the endoscope is not required. I mean, doing the endoscopy is also one of the tasks. If you have gone, I have gone through endoscopy, and it's a it's a very huge scope and it's going into your mouth. So coming to indication of the percutaneous radiological gastrostomy. So first is a head and neck cancer when there is a obstruction to aerodigestive tract because of the any malignancy in the head and neck region, or esophageal cancer, or the proximal stomach or the GE junction cancers. Then second is the neurological disorders because of the in most of the stroke patient we require the long-term nutrition, and this is given by gastrostomy. Then in chronic illness or patient has extensive surgery, prolonged recovery in surgeries, those surgery which require prolonged recovery, then this can be done. There are contraindication as to the other procedure. So same uncorrectable coagulopathy or specific to this procedure, life expectancy should be more than, at least should be more than 1 month. If life expectancy is lesser, then there is no use of placing the tube. Then if patient is not having stomach, you cannot do the gastrostomy, that's the idea. Then you have to go for the jejunostomy. Then this is for the gastrostomy. Then unsatisfactory anatomy. So when the stomach is deep seated or when there is a partial gastrostomy, colon is draping around the stomach, then our patient is having ascites sometime, in that cases we cannot do the gastrostomy. So whenever there is a ascites, what we can do is we drain the ascites first, we wait for ascites to get drained, and once ascites is fully drained, then we can still perform the gastrostomy. When in CLD patient, when there is a varix and you can see where there are multiple collateral around the stomach, then there is a higher risk of bleeding. Prior surgeries, there can be a difficult anatomy, so in which there is difficulty in doing gastrostomy. And gastric pathology like C. esophagus, which is infiltrating gastric wall, or gastric cancer itself involving the anterior stomach wall, then you cannot go through that disease wall. So coagulation as required in all procedure is the same. Then fasting is usually patient is taking liquid or that diet, then he has to fast. Otherwise, most of the time this patient is having absolute dysphagia and they are actually on long fasting. So this is not that much required. So we usually give Buscopan to relax the bowel, and this can be done under local anesthesia or mild sedation. Then as a radiologist, we have to assess the CT images before doing the gastrostomy. So first we need to see if there are any gastric varices or any cirrhosis with portal hypertension, is there high risk of bleeding. Then if there is a ascites, we can see on imaging or ultrasound, or the stomach wall is involved with the lesion or the cancer. So in this case, like there is a involvement of the stomach wall, we cannot do gastrostomy. Then when there is a difficult anatomy, then this patient has a partial gastrostomy with the colon is draping around anterior wall and there is a no safe passage to enter into the stomach lumen. And then we have to look at the vascular anatomy as well, in the form of that the superior epigastric will come in the anterior abdominal wall, and we should avoid this artery. So this is the short So this patient has already esophageal stenting and still there was an ingrowth. This is our gastrostomy sheet. This is the dilator with peel away catheter. This is guide wire. This is scalpel. And this is the small gastrostomy tube. So this video is again playing. So this is our gastrostomy set. It has this gastrostomy tube, needle, guide wire, and this is the peel away sheath. This is the syringe to inflate the balloon with at the tip of the gastrostomy tube. This is the T fastener suture. So before placing a gastrostomy tube, we have to anchor the anterior abdominal wall and the stomach wall with the suture. So this is called T fastener suture. It is placed percutaneously. And first we need to get the access via nasogastric tube into the stomach. So once the stomach is accessed using the nasogastric tube, then the air is injected into the nasogastric tube, and stomach is inflated with the air. So when stomach is inflated, we can puncture. This is a T fastener suture. So this is a hollow needle in which suture is inside the needle. So when we puncture the stomach, we remove the suture, we confirm the position of this T fastener, and when needle is removed, now suture is in place. And usually the we have to do three suture in triangular fashion, and from the center point, now these are the three suture we have placed, and then we puncture at the center of this triangle with the 18G needle and confirm the position. When the position is confirmed, we place the guide wire into the lumen. And one thing we have to remember, that whenever puncturing the stomach, we have to angle our needle towards the pylorus of the stomach, not the fundus, because in case in future we have to change it into gastrojejunostomy, then we have need the track towards the pylorus. Then once the over the guide wire, we place this peel away sheath. This is the 20 French peel away sheath, and through that peel away sheath we have to insert the gastrostomy tube. So this is the insertion of gastrostomy through peel away sheath. Then we have to remove. This is just like a PICC line or the dialysis catheter placement. This is the removal of the peel away sheath, and once it removed, we have to inflate the balloon with the 1 ml of contrast and 8 ml of distilled water. So do not use saline because it can crystallize the balloon. So we use 2 ml of contrast to see it on X-ray or the fluoroscopy, and for inflating, distilled water is being used. So whenever there is a gaseous distension and or there is a absolute dysphagia of this dysphagia in which there is no access into the stomach. So sometime there is difficulty in placing the nasogastric tube into the stomach. So how will we inflate the stomach? So this is being done under the CT guidance. So first we puncture the stomach using the CT guidance, place a angiographic 4 French catheter into the stomach and inflate it through that catheter. Now in this case, we don't have to go through the nasogastric route. Directly stomach is punctured first, stomach is inflated percutaneously, and then patient is shifted to the fluoroscopy room. We have this hybrid system in which the CT machine and the DSA machine is with the same table. So in this system, we puncture the stomach using the CT, then CT goes back and fluoroscopy comes in with the same table. And then after that, rest of the procedure is done using the same technique. Using first T fastener is placed, anchor the stomach wall to the anterior abdominal wall, and then gastrostomy tube is placed using the Seldinger's technique. So coming to endoscopic versus the PRG and what data says, this is one paper evaluating the outcome of and complication of both the procedure. So success rate is very good in percutaneous radiological gastrostomy, because endoscopy, sometimes the endoscope cannot be negotiated into the stomach because of the obstruction. In those cases, we have to convert it into the PRG. The procedure related complications are also lesser in the PRG. And this is one paper from New Delhi AIIMS in which they evaluated the safety and efficacy in 31 patients. So the overall technical success was over 90%, and the complication rate was also very minimal. And these complications were in those patients in which there is a absolute dysphagia and they have used the CT guidance. So sometime when the stomach route is not available or there is any pathology which is infiltrating the duodenum, we have to do the percutaneous jejunostomy. So in percutaneous jejunostomy, sometime if the CT is not available, you can use the ultrasound guidance to puncture the jejunum. So once the jejunum is punctured using ultrasound guidance, you can inject saline to distend the jejunum to see on his ultrasound. Once it's distended on saline, then puncture with the needle, place the guide wire, and then the rest of the procedure can be done on fluoroscopy. Complication of gastrostomy are very less, and this related to the procedure. There is a dislodge or leakage of the tube, superficial wound infection, then local pain. Major complication can because of the septicemia, aspiration, peritonitis, and perforation or the bleeding, but these are usually very less because we are all doing procedure on the imaging guidance. So post-procedure care is very important in this patient. We have to educate the patient about how the feeding is given and instruction after the feeding. So usually we keep the catheter drainage for the 24-hour to drain any small hemorrhage or any gastric fluid, and then after 24-hour we start the feeding. So initially the plain water is given, followed by the liquid diet, and then after 48 hours the full diet can be started. The T-fastener suture need not to be removed. They usually fallen off on its own, but if not fallen, then you can cut after the 7 days. So in conclusion, PRG is safe and effective, and it's a reasonable alternative to the endoscopic and the surgical gastrostomy. So it is procedure of choice when PEG is failed, because we are doing PEG because patient is not surgically fit, and if PEG fail, then PRG is the procedure of choice. And CT and ultrasound guidance can be used in difficult case, and we need to give the catheter care instruction to the patient. Thank you. So in this case we use this Seldinger technique. So this is Sven Ivar Seldinger, and this is actually a sketch made by me, and this technique is used for the gastrostomy. Thank you.
Very nice talk by Dr. Harish, and it is very helpful to the obstructed, GI obstructed patients. Any questions from audience? One question I can ask.
Yes, sir.
It is done. Usually there is indication, any obstruction cases and patient not getting the proper nutrition. Whether I want to know that any systemic disease, CKD cases, so that the patient not taking anything, there is complete anorexia. Whether in this case, is it done or not?
It is done, but if the aerodigestive tract is intact, so in our institute, first approach is endoscopic. So first patient referred to gastroenterology. They try to put it under endoscopic guidance. If it is failed, then we do on percutaneous route.
Thank you.
So for the chronic illness also, it is being done. Thank you, sir.
Thank you, sir. With this, we come to the end of the second session. I would now like to request Dr. Suprabha ma'am to kindly felicitate our chairpersons and our speakers, following which I would like everyone to stay back for a group photo. First, Dr. B.B. Panda. Dr. Subhendu Mahapatra. Dr. B.M. Swain. Moving on to our speakers. Dr. Harish Bujare. I would like to request our chairpersons and our speakers to kindly come on stage for a group photograph. Thank you. The speaker for our session is Dr. Latband Kaur. Ma'am is a pioneer in TVS, peripheral color Doppler, OBS and gynae ultrasound, has a vast experience in fetal diagnostics, fetal interventions, having delivered more than 200 talks on OBS and gynecology at various national and international conferences. She has held key faculty positions in ISUOG approved courses, and currently she is the director and consultant radiologist, fetal medicine specialist at Prime Diagnostic Center, Chandigarh.
Should we start? Should we start?
मैडम जी आपका ऑडियो उधर मिल गया है
हाँ स्टार्ट करें
हाँ हाँ जी
ओके sorry yeah good morning can you hear me
yes ma'am
okay very good morning to you all it's been a complete pleasure of mine to have come all the way from Chandigarh to Bhubaneswar and it all happened when Dr. Tara Prasad called me and I think I need to fly a little more and bring my whatever I have learned bringing it to Orissa. Thank you so much Dr. Tara Prasad for having me over here. So we begin with a fetal workshop which is an inherently challenging entity because we all understand that ultrasound is the person behind who does the ultrasound, one. Secondly, the morphology of the fetus keeps on changing over and across each period of gestation. What you see in the first trimester is going to be entirely different, especially when you talk of brain, when you talk of cardia, you are going to see a sea change in these two entities, and of course, the other areas too, because we are looking at a succession or developmental process. Two, it becomes very challenging when you have to visualize and map a moving baby. And I'm sure those people who do fetus, they are always at doing a challenge every day. So now I begin with a fetal workshop. My baby is 25 weeks, and I have been supported by Dr. Kranti, who has been very kind. We have been mapping up the baby since morning, and we've taken certain videos, captured images, and we begin with a fetal ultrasound. The most important thing is the history, right? First, we go ahead and take the history, which is entirely important before we begin the scan. Second is we always try to map the fetus right from the fundus to the pubic symphysis to see how the baby is lying down, right? That is the presentation. Third, it's very important to see whether we are looking at the cardiac activity. Many a times we start doing the biometry, never realizing that we are absolutely not even looked at the fetal heart, whether it's viable pregnancy or not. Then we look at what is the number. Are we looking at a singleton? Are we looking at a twin? All these things are very important. History is very important. We need to take a short history, which should be a part of our protocol to entail us or guide us to what we are looking at. Then we should go ahead and do the situs, which is also very important And here, my baby is breech in position. I'm going to the second trimester, right? And I see, can you switch off the zoom, the box? Yeah, right. So at this time, towards the fundus, you see the fetal head, right? And towards the pubic symphysis, you see the bum of the baby. And I'm sure it is a breech presentation. So what I do is I turn my hand transverse. I like to visualize now. First, before we check the situs, it's a good idea to do your visceral situs. Once you see the visceral situs, you need to assign which structures are on the left side and which structures are on the right side. On the left, you have the stomach, the aorta, and on the right, you have the gallbladder, the liver, right? So, and then once you ascertain the size, all you need to know, your baby is in breech presentation, and if you need to map with spine as your reference point, you go anti-clockwise, spine, stomach, and the portal vein, SSP. So my hand moves from, can I have an arrow? So I need to go from spine, stomach, and the portal vein, and I move my hand, or I move in the anti-clockwise direction, and I know that my baby is breech. If I see the cephalic position of the baby, that means my situs is not correct, right? So this is just to show you how we examine the situs. The hand has to be in the transverse. You need to have a transverse position of the, and I use a rotation technique, right? There are various techniques which have been mentioned, but I go by the rotation technique. Remember, SSP with transverse section of the abdomen, moving in the anti-clockwise, spine, stomach, and the portal vein. And you need to go and check below, and you check for the bum of the baby. That means towards the cervix, you have the baby in breech presentation. So that is the situs. Apart from that, there is another thing which we need to see is the environment of the baby. Is it a good liquor around the baby? Is my baby moving well? The movements, the liquor, the placenta, the umbilical cord, and the cervix. What if you have a very well grown baby and the cervix is short? Believe me, that is another important area, and the way you do it is also very crucial. In the second trimester, we always go and do a transvaginal assessment of the cervix. So all these things are important beyond looking at the baby. And remember, we as radiologists have always been taught, look at the four corners of the screen. That means I need to see whether there is any fibroid, whether there is any ovarian mass. How about looking at the rest of the area? So that's the ovary you see. So it's very important to map the four corners of the uterus. So after you do that, then we go ahead and start taking the biometry. So as far as the biometry is concerned, we are having a look at the femur, and the femur needs to be completely horizontal to the plane of imaging. Make sure it is a good zoom of the femur, and so it's very well zoomed up, and also you see the edges very well, right? That's how you measure the femur. The ultrasound beam needs to be perpendicular to the shaft of the femur. Avoid the diaphyseal epiphysis, right? Second most important thing, apart from looking at the femur, is that try to measure the femur which is closer to the probe, right? The near femur. The other femur is also need to be looked into. You may not measure it, but a subjective assessment is required, because in case you have a short femur on the other side, needs to be mentioned. And once you finish with that, then we go ahead and do the biometry for the fetal abdomen. Now, and then the fetal head. So as I will show the biometry, as and when we do the target scan. Can I have the adequate zoom? So we were, trying to look at the fetal. I think head is okay. थोड़ा सीधे हो जाए. हाँ. Can I have the gray map? The near map. 5. Yeah, 5. Okay. Second trimester. The probe and the, yeah, second trimester. Yeah. The map. Can you change the map, please? Yeah, and I'll zoom. Yes, thank you so much. So is the display okay going on the other side? Okay, that's wonderful. So at this time, we are looking at the fetal head. I'm going to zoom it a bit, right? And, sorry, yeah. Yeah, yes, that's fine. That's good. So that's a good section of the fetal head, right? So now the fetal head examination is very important. It's just a sweep actually which we take. It's important to visualize the 3 important planes. One is the plane which cuts across the lateral ventricle, this one. It's the superior most plane for the fetal head. Then we get the second plane is the plane where you take your BPD, and that is the transthalamic plane, where you see the falx, which divides the interhemispheric fissure. Yeah, can I have the arrow? Yeah. So that's the falx, that's the cavum septum pellucidum, and that is the third ventricle, and these are the 2 subtended thalami beside the third ventricle. That's the third ventricle, and that is the cerebral peduncles. That's the thalamus, that's the peduncles which imperceptibly enters into the midbrain, and that is the aqueduct of Sylvius. So that's the third ventricle, the thalami. This arrow thing should be projecting towards the posterior part of the brain. So that is the transthalamic plane. Let's take the biparietal diameter, where we take the widest diameter. We can go from outer to inner, or we can go from outer to outer. So that's how we do the BPD, and then we do the OFD. Yeah, so here we, again from outer to outer, from one of the frontal bones to the occipital bone, occipitofrontal diameter will give us the head circumference, which is mandatory when we start doing our biometry. Defreeze, please. Yeah. Yeah. So, yeah, no. Yeah, the zoom should be there. Right. So now looking at certain hotspots of the fetal brain, I call it hotspot, and the most important hotspot is the cavum septum pellucidum. That is going to be seen in the anterior part of the fetal brain, and that is a rectangular black box which interrupts the anterior 1/3 of the intrahemispheric fissure from the posterior 1/3. So that box needs to be seen here, and the length has to be more as compared to the width. The ratio is 1.5. If you see the box which is looking like looking like a square, or you don't see the proper fluid in the box, needs a detailed neurosonogram. So this CSP forms the constituent of a very important complex, which we call it as an anterior midline complex. The anterior midline complex, it does show you the frontal horns on either side. These are the frontal horns. I'll defreeze it and show you the frontal horns of the lateral ventricle. Can we have the gray? Can we change the gray mode for this? Yeah. Anyway, so the frontal horns are going to be lying on either side. The middle margin of the frontal horn is going to form the lateral border of the CSP. So this, and the intrahemispheric fissure is obstructed by the genu of the corpus callosum. This is seen in the transverse plane. As I finish all the planes, we will show you the sagittal plane of the fetal head, which will project the CC, the corpus callosum. Now going on talking about the BPD plane, which I already talked about, that you need to see the thalami, and once you measure the BPD, the cerebellum should not be in view. That is also another point. Then coming to another very important area, I call it another hotspot, which is the lateral ventricle, for which we get a lot of references. People inaccurately measure it. So today I will show you how to actually go about looking at the lateral ventricle. Once you look at it, it is in the transventricular plane. Can we change the gray, please? Because it will become a little sharper and will be 5, gray 5. Yeah. 5, yeah. So now, as you can see, we've changed the map, and you can actually look at a very wonderfully looking lateral ventricle, the medial wall, the lateral wall, the POS, where you need to measure the lateral ventricle, that is very clearly seen. This is the POS, means the parieto-occipital sulcus. Opposite to that, we need to measure, considering the fact that we always map the ventricle from inner to inner, and it needs to be perpendicular to this axis. This is the lateral ventricle. Always put your cursor here and here. Can we have the cursor, please? Yeah. So we place the crossbar of the cursor along the medial margin of the medial wall of the lateral ventricle to the medial margin of the lateral wall of the lateral ventricle, and the direction has to be measured like this. This, not like this, right? Because this is the plane of the lateral ventricle, and you need to go perpendicular to this, opposite the parieto-occipital sulcus. I think you can see it. The sulcus is seen very clearly and sharply. Another thing you see in this lateral ventricle is always look at the choroid plexus, which occupies more atria and the anterior part of the lateral ventricle. And then many a times we are handicapped by not looking at the fetal brain, which is towards the probe, the lateral ventricle, which is towards the probe. How I did, I just moved my hand about 30 degrees to the horizontal, and I have started seeing the lateral ventricle, which is towards the probe. As you all see, you can visualize the lateral ventricle towards. So it's very important where you have unilateral lateral ventricular Magelli. You need to just do this maneuver. You need to just move your hand about 30 degrees, and you will be able to see not only the lateral ventricle, mind it, you will be able to see the sulcus, you will be able to see the cerebrum, the sylvian fissure, and even the area of the entire internal capsule and the entire fetal brain on the side, which is hampered by the reverberation artifacts, which is an inherent problem of ultrasound. So this is how you can visualize the entire brain on the other side, and you will no more be handicapped for this looking into the fetal brain. So from going on to the lateral ventricle view, the transventricular, transthalamic, we finally enter the transcerebellar plane of imaging, which is very important because we need to see the posterior fossa structures, the normal structures, and that will help us and embark us looking at the various abnormalities of the posterior fossa. So what do we see here are the dumbbell-shaped cerebellar hemispheres, which are joined by a relatively echogenic vermis, right? The vermis, remember, is the handle. The hypoechoic ones are the cerebellar vermis. And then we look at the posterior fluid, that is the cisterna magna, and I'm sure this should not be more than 8 to 10 mm in width. So this is another important area to be seen. Apart from looking at the cerebellar hemispheres, another very important structure, can I have the arrow? I have the arrow. So this is a quadrangular shaped, or the shape which is opposite to the CSP is the fourth ventricle, right? The fourth ventricle has a wider lateral diameter as compared to the anteroposterior diameter, and is exactly the opposite of the CSP. So remember, your fourth ventricle should not look like a CSP, and your CSP should not look like a fourth ventricle. So that's the take home. So normally we do not look at the fourth ventricle. We are just bothered about measuring on the TCD, and I'm sure all the residents know how to go about and measure a TCD, right? But more important is to look at the fourth ventricle, because you embark upon many anomalies, right? And especially with Joubert's, right? You have the diameters which are absolutely opposite to this, right? That is the catch. The rest may be looking normal. So these are the intricate things, but this just is an addition. So once you finish with all the views for the fetal head, it's a good idea to just go about and changing the axis of your head. So moment you are in this plane, you lose the plane. Have we lost the plane? Yes, we have lost. And we just turn our hand, and can you zoom it off, please? Yeah, just switch it off, right? And remember to use the other hand, right? And as I'm saying, I'm using the other hand, sorry. Yeah, so I'm trying to see the mid-sagittal plane of the fetal head. You can zoom a bit, and maybe you can use the Grace 5 or Grace 6. Yeah, we are looking at the vermis at this time, and the vermis is a relatively echogenic structure. Can you point out the vermis, because I'm holding the baby with one hand? Yes, that is the vermis, and that is the corpus callosum in the midline. Yes, that's the corpus callosum, a band-shaped hypo. थोड़ा सा उस तरफ घूमना, yeah, थोड़ा सा, little bit, yeah. So it's very important to add one mid-sagittal plane into your routine pre-axial planes of imaging, right? So maybe we'll show it to you in the end, or when I try to see my images, we can probably switch on from that video which we have. Yeah, so we can do it later. And then now, moving on to the fetal spine. Seedhe ho jaye beta, thank you. So that's the fetal spine. Just do this, yeah, decrease your depth. Yeah, that's fine, that's fine. So the spine needs to be handled right from the craniocervical junction, right up to the sacral tip. Ensure when you examine the spine, there's a good amount of LICA. This lady holds a little less LICA. Depth, can you increase the depth a bit? Yes, thank you. Increase, yeah, thank you so much. And can you increase the angle of imaging? ये वाला angle, थोड़ा सा बढ़ा सकते हैं? नहीं तो it's okay, fine. That's okay, doctor, fine. So we examine the fetal spine, right? It's looking like a railroad appearance. The anterior most vertebrae, that is the ossification centers, the arrow please, yeah. So these represent the body, right? This represents the body of the vertebrae. The anterior is towards this, posterior is towards this. So we see the body, the ossification centers of the fetal bodies, the vertebral body, and these are one of the two, the right and the left ossification centers of the neural arches, right? Once I show you the transverse section, things will become easier, but the sagittal plane needs to be seen with good amount of LICA, and you also try to visualize right up to the sacral tip. Remember to document this image. Remember, the sacral tip with the skin overlying good LICA needs to be seen in every woman. Can we show you the video which I have taken in the morning? The previous patient, S patient. S, yeah. It is Jim. Did we have? Yeah. Okay. Can we show you this? Yeah. Now you see, we see in this video, you see the sagittal section of the fetal brain, which shows you the vermis Can my arrow work here? Yeah. You see the vermis and you see the entire corpus callosum, which is a band-shaped hypoechoic structure, right? So this is how you must include one section for the fetal brain in a sagittal section, apart from looking at the fetal head. Now, can we go to the next where we had the spine imaged? Agra, next. Yeah, next. Right, next. Maybe the other patient, yeah. The SM1. Yeah. So whenever we do the spine, it's very important to examine the spine sagittal, axial, and coronal. Sagittal, as I told you, has its own indications which helps you to look at any kyphotic deformities, look at the skin. You may not have a deformity, but there could be just a complete, problem with the spine, and which can be easily seen. Yeah, here we are. Now here you see the sagittal section. There's good amount of LICA, right? We are trying to see the entire spine. The tip of the spine is documented. And if you have a high resolution probe, you can actually look into the conus. The level of the conus should not go beyond L3 in second trimester, right? And then, of course, you can also visualize the cauda equina. And going on to the other section, that is the axial, that is the axial section, starting right from the craniocervical junction. Look at this, right? You can see the transverse section of all the ossification centers for the vertebral body. You make sure you stop seeing the spine and then only you finish it, right? There could be a large sacral meningocele sitting at the caudal end and you will completely miss it, believe me, right? We have missed these things. That's why we keep iterating and repeatedly telling you. So this section is very important. Shows you the flaring very nicely of the vertebral arches, shows you the overlying skin defect, shows you the diastematomylia, and shows you all the three ossification centers which form a equilateral triangle. The neural arches should converge, right? You should never see diverging neural arches, right? So this is a very important section where you should do all the three. And remember, use high resolution probes. You can go on to your using linear probes. You can use transvaginal probes wherever, whenever necessary. So make sure your spine is imaged in all the three planes, good LICA, good skin, and entire spine, starting right from craniocervical to the sacral end, showing you both sagittal and axial planes. Yeah, that's okay. Can we move on to the live scan? The live, this patient, yeah, back to the acquisition. Okay, so since we had taken few videos, we took the benefit of that. And then, of course, I do also examine the spine, the depth, please. Yeah. So I do also examine the spine in the coronal plane, which gives me a fair enough idea. In coronal plane, you will never see the skin, right? But gives me a fair enough idea of looking at the vertebral bodies. Can we use the same gray map of 5, which will bring out the vertebral bodies? Yeah. Now you see the center forms. This is the center, and these are the ossification centers which represent the body of the vertebra. On the either side, we'll show you the ossification centers as you see the 3-line sign. So this is very important, right? And you see the ossification centers of the neural arches on either side. So this is very important. This section also gives you an edge of looking at the ribs of the baby, right? There are conditions which involve the vertebral anomalies and also the rib anomalies. And also gives you assessment of the scapula, also gives you assessment of the clavicles, right? So this is a wonderful view where people don't use it, but start using it Monday morning. It's very important because there are abnormalities which are only highlighted. Believe me, we start doing our sagittal sections, and the moment the coronal comes, there's a hemivertebra. Believe me, it will not produce any angulation deformity on a sagittal, and even on an axial, it may be easily overlooked. So it's the coronal which helps you to look at the spine. So from the spine, we move on to the fetal abdomen, right? So as we move on from the fetal abdomen, we'll just, pardon? Okay. Yeah, I'll change the map. Can we have the video which we took in the morning? Yeah. No, abdomen. Yeah. 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 Okay. So that's the fetal abdomen. We can see the stomach, right? No, not this, the previous patient. This is the cardia. No, the previous patient. She's SM, the S patient. Yeah. S, never mind. Got it. S. Yeah. Yeah. Okay. Remember, I have taken off. Okay. Right. So we go to the live zoom. Live. Okay. Okay. So थोड़ा सा घूम जाए इधर को. Okay. Yeah. So that's the fetal. That's the fetal abdomen. We always try to make sure that the spine is at 3 o'clock or 9 o'clock position, right? And in the upper abdomen, we try to see the stomach is on the left side and the coursing of the portal vein is seen towards the right side. That's the portal vein, which is coursing towards the right side, and that's the gallbladder, right? And then coming to the mid part, we should try to ascertain the cord insertion both on 2D as well as on color Doppler. So that tells me that I'm looking at just the two vessels which are coming out, and it's very good idea that if you have a good Leica, you should also try to see the adjacent wall beside the cord insertion to exclude all your anterior abdominal wall defects. In the mid-abdomen, it's always a good idea to map the kidneys. Can we have the gray map 5? Yeah. So in this, we are looking at the fetal kidneys. As you can all see, on either side of the spine, that's one kidney. I'm doing a sagittal plane, right? That's one kidney, the left kidney, and as I go across, I see the other kidney, right? Also, if I just do my coronal plane, I can put on my color or Doppler to ensure the presence of both the renal arteries, right? That's the left and that's the left and that's the right renal artery coursing into that, and that gives me a fair enough good assessment or reassuring presence of both the kidneys. Apart from that, when we come to the lower abdomen, it's a good idea to map for bowel, right? सीधे हो जाए थोड़ा सा. To map for, और मेरी तरफ थोड़ा घूम जाए. So mapping for the lower abdomen includes looking at the fetal bladder, right? Looking at the umbilical arteries, which can be aided by using either power or color Doppler, and that's how we do it. You can see both the umbilical arteries adjacent to the urinary bladder, ascertaining the presence of the urinary bladder, right? And then you can also see the bowel, which occupies more towards the left lower quadrant of the fetal abdomen and is better seen when you reduce your gains. You can see the bowel, and here you can actually see the bowel, which is normal, right? That's the echogenicity. It's more relatively echogenic as compared to the liver. So you see it in the left lower quadrant of and the distinction between the large and the small bowel is seen along in the later part of the second trimester. So once you are complete with the checklist of the fetal bowel, which includes looking at the renal, all starting right from the upper the mid, and the lower abdomen. So that's extremely important. Seedhe ho jaye. So that's extremely important. So after you finish with that, we enter and we try to slide our probe across the lower limbs. For lower limbs, I've shown you how you measure the femur, and we make sure we map or look at both the, first it's very important to ascertain the presence of the limbs. Two, it is important to ascertain the three segments of the limbs, which includes femur, the tibia, and the fibula, and also looking, and also looking at the feet, right? It's very important to image the feet from the plantar aspect, because if you are visualizing the foot, can you switch off the cursor for a minute? The arrow, yeah. Yeah. So once you're looking at the feet, that's okay. That's okay. Okay. Once you're looking at the feet, take it. Once you're looking at the feet, it's very important to look at the toes, right? I know it is a challenge to, measure, map the number of the toes at times, but it's a good idea to do it. You can count the metatarsals. You can use your different maps of Gray to measure, to map the, and then also once you are looking at the sagittal axis of the foot, remember if you're looking at the sagittal axis of the foot, you are likely to miss the number of the toes. So for oligodactyly, or these are small little tips, always examine the feet in both the sagittal as well as the coronal plane. And also make sure that you look at the number of the bones, the tibia and the fibula. How do you say which is tibia and which is fibula? The tibia is the one which is seen on the medial aspect and will be seen opposite to the thumb, the big toe, right? And that is the one which articulates, right? And similarly, the similar thing has to be done on this side as well. There are abnormalities which could involve, a part of the tibia or part of the fibula where you have tibular hemimelia or fibular hemimelia. So in that perspective, you should also see the movements, the muscle mass, the orientation of feet with the legs. Or it is also very important because if the orientation is not correct, you will not be able to diagnose things like clubfoot deformity, which is very, very common, right? So this is how you examine the lower limbs of the fetus. Then going to the upper limbs, it is extremely important. Can we change the patient for a while? Can we change the patient, right? So in this time, we are going to change the patient. Thank you. आपका हो गया. Can we have the other patient? हाँ, सब ठीक है, सब ठीक. Is 20 weaker. Yeah. Zoom, the cardia is in position, they will just do the cardiac examination and show them the video, right? The face is there. Zoom kar zoom kar no. Give me the map, Gray, 5, bus. And depth. Okay. So now we were looking at the fetal face, the profile which tells you to look at the nasal bone, the forehead, the nasal bone, the lips, the nose, the chin, and the mandible maxilla. So this all needs to be seen on a sagittal. It's a part of the scan that we see the end face view for looking into the nose chin view, which is very important. You're seeing the nostrils of the baby. The upper lip, the lower lip integrity can be only handled on a corneal plane, right? Apart from that, we can also see the orbits in this plane and also the lens, right? So a brief overview of the face needs to be handled both on a sagittal, the coronal, as well as the axial view. The axial view gives you the entire assessment of the orbits, starting from the orbits, going on down into the mandible and into the maxilla and the mandible, right? So these are the views which needs to be entertained for the fetal face. And then going on and completing our examination of the fetal upper extremities, that is the hand which you could see. Open hand documentation is extremely important once you're visualizing the upper limb. The similar things need to be mapped, the segments, the echogenicity, the shape, the presence, the three segments, the humerus, the radius, and the ulna. The radius is shorter bone as compared to the ulna, and the hand, as we saw in this patient, needs to be documented in the image. And, huh? Yeah, it is open. Do we have time for 10 minutes more? Okay, so we will take 10 minutes for the fetal heart, right? I've almost completed by looking at fetal abdomen. We've looked into the fetal head. We've seen the fetal spine. We've mapped the upper and the lower extremities. Well, I do include the ears also into my everyday scanning, right? And also we do the palate. We also include a 2D examination of the palate to exclude the possibility of isolated cleft palate. So these are things which I also include into. And now going on and examining the fetal heart. The fetal heart is in position. Examination of the fetal heart, we've taken few videos which I'm just going to run. So it does not, yes, this one. So it does not include the looking at fetal heart. We must begin fetal heart examination by starting from the, can you reduce the speed? Yeah. And can we start it again? Yeah. 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 So we always examine the fetal heart by looking at the fetal abdomen. Always, always. Because the stomach has to be on the left side. I've told you how to look at the situs. And then as we go into, you can play the video, as we go into the fetal thorax, we understand that we are, very nice. So I'm going very slowly and I'm trying to show you the four-chamber first. You are looking at the, can I have the arrow? Yeah. And this is the left atrium, and this is one of the pulmonary veins. How do you switch off the arrow and move the, yeah. So you are looking, one of the pulmonary veins is entering into the left atrium. The left atrium is the closest chamber to the spine, and that is the other arrow again, yeah. So that is the other pulmonary vein. So the inferior pulmonary veins are seen. You can show them, all the four pulmonary veins in the basal view. So this is the left atrium, and aorta is closest. In between, you should not have another aorta between the spine and the left atrium. The distance should be bare minimum. On the video, you will see it is bare minimum, right? So I'm just doing the cine, and that is the flap of the foramen ovale, which you see it is extending into the, yeah, it is extending into the opening towards the left atrium. So left atrium will receive the pulmonary veins and will receive the flap of foramen ovale. As you see this flap of foramen ovale, you can also see the septum primum, right? You can see the septum primum, very clearly. And this septum primum, you will see that as I move ahead, you will see the right atrium, right? And it lies to the right of the midline. Yes. The view in this, and you see, I'm going very slow, and you are seeing this cross-shaped structure, which is called the crux, right? This is a very important entity. Remember, this is to be seen in all your four-chamber views. And this crux is the pivot of where the IVS, the interventricular septum and the septum primum meet. They should fuse with each other, right? And is also contributed by the mitral valve leaflet as well as the tricuspid valve leaflet. And this is also called as the offset. And this offset, you see the tricuspid valve has more apical insertion. Let us again go very slowly and show you the offset, and you will see this offset is having with the tricuspid valve. We can play it properly now. We can increase a little bit of speed and play. Can you play, please? Yeah, play. Okay, so now you can see the chambers. We are playing it again for you. Right, we can play.
Frame by frame.
Frame by frame, even otherwise also we can play. No problem. Yeah. We can play it as a routine, maybe. Yeah. Okay, maybe select it and play it again. Yeah. No problem. So in this, the right atrium and the left atrium should be of equal sizes. The right atrium is the one which receives the systemic veins, that is the SVC and the IVC, and the left ventricle should be the same size of the right ventricle. So before you do your fetal echo, one is beginning from the abdomen. Two is make sure you look at the fetal heart as a whole. As a whole means you look at the synonym is PASS. PASS. P means the position. The position means that 2/3 of the heart should be on the left side and 1/3 of the heart is towards the right side. So this is the right side and this is the left side. So my position is all right. So I finish with P. Then is my axis. Axis means that this heart with the axis with a line drawn from the chest up to the spine and another one drawn across the interventricular septum should be close to 45 degrees plus minus 20 degrees. So that is the normal axis. You can have conditions where you have the axis which is more or axis which is less. And these are the conditions which could involve the outflow tract abnormalities or inflow tract abnormalities. So we finished with P, then we finished with axis A, and then coming to S. S means size. Just by look of it, I know the size of my heart is normal. It is about 1/3 of the entire thorax. So, and second point, you can measure subjectively by looking at the length at the level of the AV valves, and that should correspond to the period of gestation. Second, you can do an objective measurement where you can take the area or the circumference of the fetal heart and take the circumference of the thorax or the area of the thorax. Normally I take the circumference, and the CT ratio is about 0.4 or 45% at second trimester, and it increases to 50% at term. So this is the P, A, S. We finished the size. Then we come to symmetry. Symmetry means LA equal to RA. The chambers of right atrium, left atrium normal equal to each other, and so will be with the left ventricle and the right ventricle. So the symmetry, then we finish, and then we talk about the squeeze, the last S. And the last, which we already talked about, is the triple S, is the situs. We've already done with the situs, right? Make sure the stomach and the apex of the heart lie on the same side. And try to take a section where you have one section which includes the stomach and the other section which shows you the fourth chamber with the apex pointing towards the stomach. So this is another check on yourself. And the situs, the way, the rotation technique I have told you should be done in every patient. We do it as a routine, right? And the rhythm has to be regular, right? Between 120 to 160, right? Anything which is less or more needs a detailed fetal echo. Now, it's very important. Whenever you do your cardiac examination, you need to add the color. Without color, today, your cardiac examination is not complete. Now, this is to show you the inflows. The red or blue is not important, right? It is the inflows, and these are the outflows which form the 3BT view, right? I will take you to these views in the next video. So always do side-by-side examination, use your color Doppler, 2D and color Doppler side by side to get the assessment of the fetal cardia on both grayscale and color Doppler simultaneously. That is very essential point. Your presets for the cardiac examination with a higher frame rate, zoomed up image, reduce your box, correct your color gains are extremely important for a good fetal cardiac examination. And then now coming to another video, yeah, this was showing you, I'm trying to show you the right outflow tract, right? I'm showing you the right outflow tract where, okay, can we show it on this? Yeah, this was better. So now I've used the simultaneous display of 2D and color, showing you the right outflow tract where you see that is the right ventricle, this is the pulmonary valve, that is the pulmonary artery, the main MPA. It is dividing into the right and the left branches. You can see the branching of the pulmonary artery, and here is the cross section of the fetal aorta, right? So this is to show you a wonderfully done complete view of the pulmonary valve, which this is the semilunar valve, which should not be seen consistently in systole and diastole. Remember, if you see it consistently in systole and diastole, indicates pathology of the pulmonary valve. So this is how you examine the bifurcation of the pulmonary artery and the main pulmonary trunk. And then now trying to show you the LVOT view, right? Once you go from the forechamber and go superiorly, right? The first is going to be the LVOT. Then you get your RVOT because the pulmonary artery is an anteriorly placed structure. The right ventricle is an anteriorly placed structure. Pulmonary artery is anterior and to the left of the aorta, whereas aorta is posterior and to the right. So for looking into the LVOT, the LV is the smooth chamber. It is devoid of trabeculations. Whereas the RV is showing you the moderator band and the attachment of the chordae. So that is chordiphobic, and this is, the other way around. This does not show any attachment of the chordae, right? The LV is smoother. That's how you differentiate the LV from the RV, right? Apart from looking at their configuration and the placements, right? And then you see the LVOT view, the aorta, the ascending aorta, and the arch of aorta arising from the LV chamber, and the continuity of the septum with the aorta needs to be ascertained to exclude the VSTs, right? And this is the IVS, and it is seen continuing with the anterior wall of the aorta, and the posterior wall of the aorta is seen continuous with the mitral valve leaflet. So this septo-aortic continuity showing you these views are very important. Then after you finish with the four-chamber, LVOT, RVOT, what you see is a three-vessel view. In the three-vessel view, you have three vessels, right? By the name, that is the pulmonary artery, the aorta, and the SVC, right? So this is the SVC, and this forms the three-vessel view. And then you go a little superior, you will get the three-vessel trachea. So now going on with the patient, we've already taken these videos in the morning. Since we had the view for we call it an opportunistic, मेरी तरफ घूम जाइए, opportunistic approach. Turn, मेरी तरफ turn, घूम, yeah, बस. So here, zoom करो, Yeah, sorry. Yeah. Okay. So similar things. Again, that's the forechamber. Always begin with the fetal abdomen. You see the stomach on the left side. I see the cardia, the forechamber, and I proceed up. I get first the LVOT, right, emerging from the left ventricle. My baby is not, listening to me. But anyhow, I was able to take the videos in the morning. Yes, my baby's turning a bit. थोड़ा सा हाँ बस ठीक है. So now we see, okay. Anyhow, so it's basically a sweep. Once you have to explain, then you need the baby and almost, listening to us. But it's a sweep. We form a sweep right from the base to the apex of the thorax. And remember, once you look at the fetal heart, just don't keep looking at the fetal heart. सीधे हो जाएं, उस तरफ घूम जाएं, उस तरफ घूम जाएं, turn कर लें. हाँ. So it's better also to look at the fetal lungs, right? So we need to see the homogeneity, the symmetrical homogeneity of the fetal lungs, which are relatively more ecogenic as compared to the underlying liver. Also ensure the presence of the fetal dome, of the dome of the diaphragm, right? Because once you see the lungs, we always do not bother to see the सीधे हो जाए. Anyhow, so we've shown you a good amount of fetal heart in the videos which I had saved. I think we can close it now. Any questions from the audience? Okay. So thank you so much for a very patient hearing.
Yes, ma'am. Hello.
I think I'll join
Can
you in
hear
the
me?
hall very soon. And if anyone has any questions, I would be more than happy to answer. Thank you all.
Thank you very much, ma'am.
With this, we come to the end of the fetal medicine workshop. I would like to now call upon Dr. Naresh Santuka sir to kindly felicitate our chairpersons. Our esteemed speaker is in the department right now and was doing the live, so we'll felicitate her once ma'am comes here. Dr. Beenadi Agarwal. And Dr. Kamal Mahapatra. Moving on to our next session, which is interventional oncology. I would like to introduce the panel of chairpersons, Dr. S.S.G. Mahapatra, Dr. Premraj Satpathy, Dr. Selendra Kumar Prosti, Dr. Prasant Kundu, and Dr. Surai Murmu. I would like to request everyone to kindly take their seats on the stage.
So good morning everyone. So I'll discuss the basics of different venous catheter for the role of chemotherapy and our role in IR. So I will discuss the central venous access, tunnel and non-tunnel catheter, the technique of introducing the catheter and its complication during the procedure or post-procedure, tips and tricks, and last conclusion. So we can divide the venous access in central and peripheral one. Central means it can be divided in tunnel, non-tunnel, chemo port or PICC line or PICC port. And in peripheral, it is peripheral IV line or midline catheter. In basically central vein means that is the closest to in the central of the body and it is closer to the heart. So it accounts that SVC, brachiocephalic vein, IVC, common iliac vein, and both IJV. These are the central veins. So we can place any venous access into the tip. The tip should be within the heart, and there is a non-valve catheter. So that is a central catheter, and that can be divided into tunnel, non-tunnel, chemo port, PICC port, or PICC line. And in peripheral, it can be accessed in any peripheral, superficial, or deep vein. And another is a midline catheter. So central venous access, the principle is the catheter tip should be within the central vein without valve between the catheter and within the right atrium. So these are the central vein. I already told that SVC, IVC, and the brachiocephalic vein, subclavian vein, common iliac and external iliac vein, and bilateral IJV. And it can be used in multiple situations like dialysis, like any hypo or hyperosmolar long-term infusion, chemotherapy. When there is high volume pheresis is required, in that case also put central venous access. And long duration of therapy, in that cases peripheral venous access is not suitable. In that cases we can place central venous access. So these are the just basics anatomy showing the basilic vein, cephalic vein, and the brachial vein and subclavian. This is the just basic upper limb anatomy. And we can see the central catheter, that dual lumen catheter. It is seen, and the entry point in the IJV, and the tip should be within the 1/3 of the SVC or in the cavatrial junction. So that can be seen. So this is a temporary catheter. It can be tunnel or non-tunnel. If case of tunnel catheter, there are a cuff at the end of the catheter, and it should be under the skin. So it just increases the formation of the tissue, and it will adhere the catheter with the tissue. So it will not. So this is another catheter. This is the type, the skin subcutaneous, and we puncture the vein, and this is the another catheter, and the tip should be in the cavatrial junction. So this is another tunnel catheter. That tunnel should be in the subcutaneous tissue. So we puncture the vein, make a tunnel, and place the catheter, and tip as usual. So it is a Hickman line. So, and this is a chemo port. Here we make a pocket in the chest, or it can be done also in the arm according to the situation, the clinical situation. So placement of chemo port, it requires like mild sedation or under local anesthesia. We just make a pocket just in the subclavicular location, and make a pouch and place the port in the chamber, and with the tubing, the tip of the tube should be in the cavatrial junction. So this is the chemo port. And tunnel we make with the metal tunneler. And this is a PICC line. PICC line can be placed in the cephalic or the basilic vein. This is the entry site, it is in the cephalic vein, and end of the catheter in the 1/3 of the SVC. And in case of midline catheter, it is a one type of peripheral catheter. The tip of the catheter is either at the axillary fold or just above the axillary fold. It is not used for long duration cases, and in cases of irritation, high viscosity fluid or any fluid that cause irritation, it cannot be used for the midline catheter, and it is also not suitable for long term use. So catheter type and their basic uses. So one by one I can tell that short term catheter use is when it is used is up to 6 to 14 days. Medium is range is when 15 to 30 days, and long term is when it is more than 30 days. So when non-tunnel catheter, when comes to the non-tunnel catheter, it is a percutaneously inserted into the jugular vein, subclavian or femoral vein. So short term access when the peripheral IV is not suitable, and volume like high volume resuscitation, or in case where the central venous pressure monitoring is required, or short-term dialysis. In that case, the non-tunnel catheter is preferable. When it is avoided, when the long-term access is required, in that cases, that non-tunnel catheter like just central line, IJV line, that is not used, and it is the easiest catheter to place and easiest to remove, but highest chance risk of bloodstream infection, that is catheter-related bloodstream collapsing. So, and the central venous catheter can be of 5 French, 6 French, that dual lumen or triple lumen or single lumen, whatever, that to be decided according to the clinical need. Then comes to tunnel catheter. Tunnel catheter is when that shorter term, long term access is required. So, it is a subcutaneously tunnel placed in the jugular vein or subclavian or femoral vein, and where long term access is required, like frequent antibiotics, TPN, or transfusion or blood sampling, when PICC line is contraindicated or not possible. When shorter term is access required, in that case, tunnel catheter is not usually more than one month when it is required. In that case, the tunnel catheter is preferable. So here also lower infection rate than the non-tunnel catheter and higher infection risk compared to the chemo port. In case of port, it is a subcutaneously placed in the chest or arm according to the clinical situation. Where patient is very bulky, in that cases we can place it even on the sternum according to the body habitus of the patients. And the catheter inserted in the jugular vein and tip captured or jugular or subclavian vein and tip at the cavertral junction. So where long-term access is required, but use of the chemo port is infrequent, like chemotherapy, it usually after 1 week or 2 weeks. So it is avoid when the frequent access is required, because during that infusion of the chemotherapy, it needs needle stick every time. So in that cases where the frequent use is required, in that cases chemo port is not preferable, and it is more aesthetically appealing option for the patient, and also basically emotionally it is better for any cancer patients. And it has the lowest infection rate and minimal local site care. After the suture removal, there is no need of any local site care, but it is for the first time it is expensive, and it is more difficult to place and also more difficult to remove. It needs every time expertise. And the care of the chemo port is also required, at least flushing of the catheter once in a month. And peripherally inserted catheter, that is a PICC line. It is a percutaneously inserted catheter. Cephalic is basilic, brachial or cephalic vein advanced to the central vein, where there is a frequent use, access is used for the short to long term, when up to 3 months PICC line is preferred. So it does not need needle stick every time. That's why where frequent access is required, in that cases PICC line is preferred. So in cases of dialysis or pre-dialysis patient, PICC line is not used, just it increases the thrombosis formation. So it has the lower risk, infectious risk than the non-tunnel, but more infection rate than the chemo port. And it requires a patent peripheral vein or potential for occlusion also. It is a major drawback for the PICC line. So tunnel catheter, it can be like Hickman, chemo port, farm cath. So we make a tunnel and place the catheter in the cavertral junction. And so before the procedure, we have to see the blood report like CBC coagulopathy. Right IJV is preferred access because the straighter course to the right atrium, and large accessible easily and lesser chances of pneumothorax. Other access like subclavian access, it is riskier, but some may prefer. And femoral, if IGV are thrombosed, in that cases femoral line are preferred, is used. And in blood tests like iron goal is 1.5, PTT should be less than 1.5 times of the control. Platelets usually not count, but if it is more than less than 50,000, it should be infusion. Infusion is required. No need to withhold the aspirin. And if there is an patient is antiplatelet, so 5 days before the procedure is required, and LMW is also should be withheld for 1 day. So these are the pre-procedure checklist we have to see before planning for a tunnel catheter. So in this is some tips. If that IJV or any venous size is not suitable, so in that cases we can just turn the head down and it will engorge, so puncture will be simpler. So this is the PICC line. This is the PICC line. There is a single lumen and double lumen, and this is the chemo port under the skin. We can see. So this is the chemo port. It is under the pocket, and this is the tip of the catheter in the SBC. And during the how to use the chemo port, like one is a Hubbard needle. We have to just puncture the chamber with that Hubbard needle and do a just flush and aspiration, then use. And Huber needle should be should not be reused after 5 times. After 5 times, it should be replaced by new one. Uh, so these are the material when we place a permacath. So these are the material. This is the puncture needle, and this is the guide wire. This is the metal tunneler. So this is the use for the skin tunneling. This is our the dual lumen dialysis line permacath, and this is the pillow acid, and this is the dilator. So different size dilator. So under ultrasound guided, we take the puncture, then access the just secure the access of the guide wire, and take a nick and the skin incision site. So after that, make a tunneler, and during tunneling, just we have to see that the plane should be maintained, not should be in the deep more, it cause pneumothorax. And after the just pull the catheter through the help of that metal tunneler, and then this just place the that pillow sheath, and just place the palm cath end through the pillow sheath. This is like peeling of the sheath and putting the catheter into the right atrium, and this is the end picture. So this is the final images. So this is the palm cath. So, and in case of chemoport, the steps are same. Only we have to place we have to create a pouch in that area, just removing the fat and place enough space for the chemoport, and we have to secure the port with the chest muscle. So there will be no more movement during the puncturing or any other patient movement. So, and after the rest of the steps are same as the palm cath. The complication associated with this is like pneumothorax during the puncturing or during the palm cath insertion or the lung injury pneumothorax. Another thing is like that catheter may just abort the that vein wall. So in that case, free flow, backward or forward flow will not be there. In that case, we have to reposition that thing. And air embolism, sudden air embolism may happen during the pilloway of the sheath in that cases. So that can be diagnosed by sudden coughing or desaturation. In that cases, left decubitus position and give 100% oxygen. And in some cases, like in chronic palm cath insertion, after that there is that patient can flush, but that sister can flush, but cannot aspirate from the catheter. So it is a diagnosis of mostly it is a fibrinces around the palm cath. So in that cases, infuse RTPA or exchange the catheter, or in that cases, some cases that snare the fibrinces from the another access. So it is also another type of complication. So key point acute complications in pneumothorax, hemothorax and air embolism, chronic complications like fibrinces formation, catheter-related thrombosis and infection. And care of the catheter, like in PICC line, we have to change the dressing every 48 hours to 7 days according to the skin insertion site, condition of the skin insertion site. And we have to flush the PICC line every time after the use of the chemoport or after blood drawing or blood transfusion every time. And if it is not in use, at least every week we should flush the PICC line. In case of chemoport, we should flush the chemoport before and after the use. And if the chemoport is not in use, in that cases we have to flush the chemoport every monthly. So these are the basics of the different venous line. So conclusion in essential to note the indication and requisite of the procedure. Sterile precautions are must. The care handling, like sister or doctor, whoever the caring, they should wear gloves and everything. So, and skin insertion site, that should be every time they should see if any site of infection, that should be treated accordingly. If there is an infection in chemoport or PICC line, so it should be removed as early as possible. Or if in case of it there is a thrombus formation or anything, in that we have treat by the anticoagulant otherwise. Thank you. Any question? Any question from chairperson, sir?
Hello?
Yeah.
Like it's a overlapping field actually because the anesthetist, the oncosurgeons and radiologists are doing the same job. Like
Yeah.
how often you do it in your centers? Like how often do you get the referral for a chemopod especially?
For chemoport, we used to do it regularly. Most of the cases done by IR only.
Okay.
Only where there is a during the surgery, in some cases, surgeon may place the chemoport. Otherwise, most of the chemoport, more than 90% of the chemoport put by IR only.
Okay.
And in case of PIC line, most of the PIC line is placed by our sister.
Okay.
When it gets failed, then in that cases that comes to us.
So difficult cases mostly we will coming to the IR
Yes.
routine there.
Yeah. And left-sided port is most likely, most of the time placed by IR.
Okay. Thank you. Thank you, sir.
Yeah.
Thank you, sir. With this, we will be taking a small break from the academic part and will begin with the inaugural. In collaboration with Interventional Radiology Outreach Initiative of ISVR, Chandigarh, Punjab and Himachal Pradesh State Chapter. Without further ado, I would like to call upon our respected dignitaries on the stage for the inaugural and lamp lighting ceremony. Firstly, Dr. Suprabha Nayak Ma'am, HOD, Department of Radio Diagnosis, AIMS Bhubaneswar. Our chief guest for today, MS AIMS Bhubaneswar, Professor Dr. Dilip Kumar Parida, sir. ISVR General Secretary, Dr. Nitin Shetty, sir. ISVR Chandigarh, Punjab, Himachal Pradesh State Chapter President, Dr. Ajay Kumar, sir. IRI President-elect, Dr. Sandeep Kafthale, sir. ORIA President, Dr. Prafulla Kumar Das, sir. ORIA Secretary, Dr. Satya Mohapatra, sir. Organizing Chairperson, Dr. Sudipta Mohakud, ma'am. Organizing Secretary, Dr. Harish Bujare, sir. And Organizing Secretary, Dr. Tara Prasad Tripathi, sir. I would like to request all our dignitaries to kindly come up for the lamp lighting ceremony.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं गच्छामि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्
Thank you, everyone. Now I would like to call upon Dr. Suprabha Nayak ma'am for the inaugural speech.
Jai Jagannath. Respected Chief Guest, Dr. Dilip Padira Sir, Medical Superintendent AIMS Bhubaneswar, ISVIL General Secretary Dr. Nitin Shetty, ISVIL Chandigarh, Punjab and Himachal Pradesh State President Dr. Ajay Kumar, IRIA President-elect Dr. Sandeep Kavtale, ORIA President Dr. Prafulla Kumar Das, ORIA Secretary Dr. Satya Mahapatra, Organizing Chairperson Dr. Sudipta Mahakur, Organizing Secretary Dr. Harish Bujade and Dr. Tara Prasad Tripathi, distinguished speakers, senior faculty members and my dear colleagues and residents. A very good afternoon to all. It's my great honor and privilege to welcome you to AIMS Bhubaneswar for the 51st Annual State Conference of ORIA 2025. On behalf of the organizing committee, I extend a warm and hearty welcome to each one of you. It's a great honor for us to host this intellectual gathering. I would like to extend my sincere thanks to ORIA, IRIA and ISVIR for entrusting us with this opportunity. This is the first time ISVIR outreach program is being conducted at AIMS Bhubaneswar. The field of radiology is at a turning point right now. Radiology is more than just a diagnostic support service as it was in the past. Presently, we serve as the central axis of contemporary patient care. From the early detection of pathology to image-guided therapeutic intervention, our discipline is redefining boundaries of what is clinically possible. The theme of this conference, Imaging and Interventional Radiology, reflects our commitment to today's rapidly evolving landscape that demands more than accurate diagnosis. We explore how diagnostic information can be promptly utilized to guide effective treatment without any delay. From identifying challenge through robust assessment to designing and executing the right intervention, our aim is to close the gap between knowing and doing. We have curated a scientific academic program that is both rigorous and relevant. We are honored to have with us experts who are leaders in their respective subspecialties. Over the coming sessions, we will explore how advanced imaging protocols are pushing the limits of resolution. Artificial intelligence is transforming workflow reporting and patient triage. And how interventional radiology is delivering faster, safer, and more effective treatment across specialties. Furthermore, I would like to draw special attention to the hands-on workshop embedded within our schedule, focusing on emergency life support for radiologists, neurointervention, radiofrequency ablation, and microwave ablation. The advancement of our field depends on robust exchange of ideas that starts in the event like this one. So I encourage all the delegates and residents to take full advantage of these academic and practical modules. This conference would not have been possible without the vision and constant encouragement of our Executive Director and administrative facilitation provided by our Medical Superintendent. Their unwavering support has been the pillar upon which this academic endeavor stands. I would like to extend my heartfelt gratitude to the organizing committee for their meticulous planning, to the administration of AIMS Bhubaneswar for their support, all the speakers, the sponsor, and every participant who has contributed to making this conference possible. Once again, welcome to the 51st Annual Conference of ORIA. I wish you all a productive and inspiring experience. Thank you. Jai Hind.
Thank you, ma'am, for your kind words. Next, I would like to call on the dais ORIA President, Dr. Prafulla Kumar Das, sir.
Dr. Shiprova has introduced and welcomed all the dignitaries. So I re-welcome our chief guest, Dr. Dilip Parida, and all the state executives traversing across from different parts of the country, like Punjab, Haryana, Himachal Pradesh, and they are with us. I welcome to them, and I welcome to our upcoming President-elect, Dr. Kaptale, and I welcome all the organizing team of the AIMS, Dr. Tara Prasad and his team like Ranjan, Manoj, and Dr. Sudipta, Dr. Shiprova, all of them has done a wonderful job in organizing it. So a lot of accolades to them and big round of applause. And now I don't want to make a speech-making session. So while I was coming, a resident asked me two questions, and as outgoing president, I need to answer it. So he asked me two pertinent questions, of course. As office bearer, as a president, or my past presidents, or the IRA presidents or secretaries, what they are doing for these young radiologists, for the protection of their future and future subjects. This thing I need to answer. The question number one from him, unfortunately I am not finding him here. I request the residents who are over here, you can convey it to him. The question he asked and the answer lies with him. Last day I was observing the proffered papers that you have been presented by you people. You are all talking about ASL, tractography, cartilage mapping, all these interventions and all that thing. Sitting in this beautiful auditorium, staying in a tier 2 city like Cuttack and Bhubaneswar, are you ready to move periphery? This question you should ask yourself. None of you are ready to go to periphery. You are serving to a tier 2 population, say Cuttack or Bhubaneswar or some cities in Odisha, comprising hardly half a crore people. There are 3.5 crore people who are deserving also health care like us. So, member of parliaments, and they are there to answer their questions. You don't want to move, you don't want to do ultrasound. Either way, you also don't want that anybody else to do ultrasound in periphery. That's quite injustice. The day you will be ready to move, that day we can raise the question before the representatives that yes, let us stop this 6 months training. Because 6 months training is there to save their skin. The way you are interested to save your skin, the MLAs and MPs, the Sarpanch, whatever they may be, they also want to save their skin. They want to protect their position. They are answerable to public. You are not. So the question they are asking to us, the question should be asked to yourself, whether you are prepared to migrate to periphery. Suppose one of my colleagues is from Chandigarh. I can remember one of my colleagues, he was practicing there in Chandigarh. Now he has moved to Odisha and migrated to a district level, Keonjhar. is our friend Dr. Sunil. He is doing wandering practice. I don't find any logic behind to stay back at Bhubaneswar and to WhatsApping the message like what the association is doing. Instead of you get yourself ready to move out. That's the whole issue. So now second question was that two places practice. That unfortunately an injustice meted out to the radiologists in the sense that this PC-PNDT Act came up and it is a general assumption by everybody else. Most of the doctors will think that the radiologists are doing obstetrics. But the fact is that very few radiologists are interested to do obstetrics. Many are not doing, and it is an irony that we are being blamed for doing these things. Of course, in every profession that do have the black sheeps, like supposing you are over here, your certificate is wandering there in Nayagarh or Koraput, some mischief is there. But apart from that, this thing is being particularly done by gynecologists. I am not misconstruing them, I am not misunderstanding them, I am not telling bad about them, but they are given dual licenses. They are allowed to do ultrasound and they are allowed to do medical termination of pregnancy. In this scenario, that last time in that conference I had requested my friend Dr. Manas to take care of the issue. At least one thing should be curbed. If they are allowed to do ultrasound, MTP certification should not be given to them. If they are doing MTP, then that center should not have an ultrasound machine. But that thing is yet to be materialized because their lobby is far, far ahead of us. We cannot fight it out them. Whatever we say that we are radiology doing wonders, doing intervention, doing this, doing that, that's within that room. But they are the front runners. They are the front people, we are the second hand people. So their lobby is far, far bigger than us. They can fight it out in a bigger ways. Their numbers are big. Their lobby is big. Their political connection is big. You cannot fight it that way. And I'll request Dr. Kapter, who is over here to take over President of ORIA, to see that 50% of time should be devoted for subject protection, 50% of some time should be for academics. Academics without subject protection is having no consequential benefits. Because you see, I was very disheartened in that IRA program. The questions on PET CT was asked to radiologists. Do we do PET CTs? In my younger days, when I was attending and even delivered lecture in national conference about PET CTs, how often we are getting a chance to report it out? That subject has been snatched away from us. Now, the nuclear medicine people do not want to see your face. They do not want to see that you people are there around them. Single-handedly they are doing. And if you will tell questions to the residents about the PET, the HIDA scan, this, that, does it carry any sense? You learn and you get degree which is fruitful to you. Get subspecialty things that is passionate to you. Don't run after having so many subspecialty certifications, fellowships, etc., which will be meaningless in future. So this thing I request to Dr. Capital to segregate timing to see that the subject is protected. And particularly these IR people, I will be requesting that you spend time to have patency. Because you see, his vascular surgeon is doing vascular surgery. Do you think he cannot do intervention? And a neurosurgeon, he is doing, is operating over brain. Do you think that he cannot do neurointervention? So, you have to have your patency, you have to have the protection for your subject. If you are not doing that, in future, in shortly, the time is not away that you will be losing the subject from your hand. The way we have lost many of the subjects from ours because of the carelessness not to spend time for association activity. Anyway, I hope that this thing will be taken care of, my president who will be taking care of the IRA presidency. So ultimately, I want to thank the AIMS director, superintendent, those who have extended their extensive cooperation for making this conference a successful one. And I thank to my General Secretary, Dr. Satyasundar, who has done a wonderful job for the last 2 years of organizing so many academic meets to meet the interest of the residents. And I have a very good team, those who have worked with me, all the ORIA executives in concurrence with the fellow people have done wonders for making this thing success. I thank to the director, Dr. Shutos, I thank to Superintendent Dr. Dilip, I thank all the dignitaries, those who have come and are with us from different parts of the country, and they have spent quite good time and also energy to be here with us to impart their learning to us. And I'm thanking finally Dr. Tara Prasad, Dr. Manoj, Dr. Ranjan, Dr. Suprova, Dr. Sudipta, and their the team of AIMS Bhubaneswar. And notable missing is our Vice President Dr. M.B.K. Rao. He has some personal commitment, he could not be with us. And I thank all the senior presidents, secretaries, and senior members of ORIA Association, and long live Radiology Association. Thank you all.
Thank you, sir. Next, I would like to call upon ORI General Secretary, Dr. Satyasundarji Mahapatra, sir.
To you all, like respected Chief Guest Dr. Dilip Parida, ISBR General Secretary Dr. Nitin, ISBR Chandigarh, Punjab and Himachal Pradesh President Dr. Ajay Kumar, IRA President-elect Dr. Sandeep, ORA President Dr. Prafulla sir, Organizing Secretary Dr. Harish Bujade and Tara Prasad. So distinguished faculties, guests and residents. So thank you once again for coming here to be a part of 51st ORIA State Annual Conference. It's a unique blend of like imaging and intervention. First time in state we are having this kind of conference because we are having a unique mix of both imaging and intervention. Being a radiologist, we should go into intervention because we know our image better, so it keeps us or puts us in a better position to do intervention rather than anyone else doing it. So any day, like in future, like we have to be more assertive in getting our patients, like we have to prove that we are good and better and we can do our job better than any clinicians or anybody else. So thank you once again to be a part of this conference, and I welcome again once again everyone else here. Good day.
Thank you, sir. Next, I would like to call upon ISVIR General Secretary, Dr. Nitin Shetty, sir.
Good afternoon, everyone. Dignitaries on the dais. On behalf of the Society of Indian Society of Vascular and Interventional Radiology, let me convey my warm regards to all of you who have come. Congratulate the team of Tara Prasad and the organizing team for conducting this conference, and also thank the PGI team for the outreach program. You know, I think there are residents over here, and I would like to say that we are entering a new era in the as far as radiology is concerned, because artificial intelligence is coming a big way, and you know, there has been apprehensions, anxiety about whether there would be job losses because of AI. I would like to say that fear, it is need not have that fear that we are going to lose job, but at the same time we need to be aware that that also is going to be a sort of competition for the radiologists who are passing out. It is better to embrace that, because eventually that is going to come, and it's better to be prepared to face the, to collaborate with AI, I would rather say. And most importantly, we need to stay relevant. And one of the way of staying relevant in the era of artificial intelligence is to super specialize. So just being a general radiologist is not going to be easy. You need to specialize in some way so that you, for the future job, or one of the part that was mentioned by the Orissa chapter president-elect was the need to go to the periphery. Now, it's very true that we need to go to the periphery. If you don't, then this AI is going to come there. It's going to take most of the job, and only few critical ones are going to come to the tier 1, tier 2 city. So it's important that we go to the periphery. But also, like I mentioned, one of the way to stay relevant is to super specialize, and interventional radiology is one of them. imaging, it can be read by AI, but it is very difficult to take the skill. Be it a simple ultrasound guided abscess drainage, biopsy, CT guided procedure, or a vascular, non-vascular, name the procedure, it requires skill, it requires training. And AI is not going to replace you overnight. It might happen for the diagnostic, but definitely IR is not going to be that easy. So I request the youngsters who to continue using the ultrasound, because I know even in my institute, most of the residents would want to, look at the CT scan, MRI, not read books, only refer to the Google or Chat GPT. Yes, please remember that that is all what you are doing in CT MRI can be done by AI. What you do in the ultrasound procedures is going to stay with you, and when you pass out, when you go for a job or you want to put your own practice, definitely it will be much more easier to settle down if you have got some other talent. All right. So with this, I would again like to thank for inviting me here, and wish you the organizing team the very best for the next couple of days. And this is my first visit to Bhubaneswar, and I'm just looking forward to go see the rest of the city also once this program is done. Thank you.
Thank you, sir. Next, I would like to call upon ISVIR Organizing Secretary, Dr. Harish Bhujare, sir.
So, respected dignitaries on the dais and off the dais. So, as already mentioned, this is one of the unique concept that collaborating ISVR and the IRIA. So, of course, though diagnostic and the therapeutic both are important, and we have our own competition in ISVR as well as the IRIA. So, as a ISVR secretary and as our chapter branch, so we are actually a 3-state chapter. So it includes Punjab, Chandigarh, that is UT, and the Himachal Pradesh, and this is state chapter of the ISVR. So we usually do the peripheral programs like this outreach program, and we started covering the other aims. So we previously we covered AIMS Rishikesh, we did one program. Then next year we did AIMS Bhopal, then next year AIMS Patna, and then also the medical colleges in Punjab like Ludhiana, then in Shimla, and then Udaipur. So we are covering the other hospital, and to show them that the various IR procedure, the knowledge about the IR procedure, the workshop, and also we have one undergraduate awareness program or youth education program in which we go to medical college and we target the MBBS student about the radiology. So in radiology it's both, it's related to first you have to learn the diagnostic and then you can come to the intervention part. So we tell them the what is this intervention radiology is all about, and I think this is as an executive member in the association, so this is our job to educate all about the radiology, what is it, what we can do and what we cannot do. Because as already mentioned by President Sir, that the competition for the radiologist, whether it's diagnostic or intervention radiology, is very high. And other branches are encroaching, plus AI is now encroaching. So we need to have all the information, knowledge, and we have to improve ourselves rather than defaming the other. We have to improve ourselves. So that's our motto, and that's why we do these outreach programs to teach and to spread the knowledge, and also we get other knowledge from this outreach program. So we have one annual conference, and I would take this opportunity to invite you all for our annual conference of state chapter of ISVR, and that will be held in 7th and 8th February next year. So at last I would like to thank the local organizing team to accept our this collaboration, and the collaboration was made with the local IRIA team, and thank you the local IR team as well, and thanks for the all dignitaries who has come from far away for this program, and I welcome you all, and this will be very good teaching for the all resident. Thank you. Thank you.
Thank you, sir. Next, I would like to call upon IRI President-elect Dr. Sandeep Katwale, sir.
Thank you, Dr. Ankita. Namaskar. Good afternoon. Dr. Suparva Naik, Dr. Dilip Kumar, Dr. Nitin Shetty, Dr. Ajay Kumar, Dr. Prafulla Kumar Das, Dr. Sudipta, Dr. Satya Sundar, Dr. Bujade, Dr. Tara Prasad. At the outset, I wish to express my gratitude for inviting me for this conference. I am happy to be here today in this historic city, Bhubaneswar. Organizing such a conference of such a scale is not an easy task. This needs dedication, passion, commitment, and I must congratulate all the organizers, specifically Dr. Ajay Kumar, Dr. Das sir, Dr. Mandeep, Dr. Mohapatra sir, Dr. Panda, Dr. Tara Prasad, Dr. Rao, Dr. Vijay sir, Dr. Snehadev. My best wishes for this conference. I am sure this conference will serve as a noble platform to interact with the scholarly faculties, to present your work, to exchange the ideas. The theme of the conference is International Radiology. This is a need of the hour, and this is a rapidly progressive branch. I would like to congratulate the scientific committee of this conference for selecting the rich content for all the delegates. Today, Das sir raised a few questions like regarding the PC PNDT and 6-month training. I want to tell all of you that IRI has filed a case in the Supreme Court for this government rule, government order of 2 places. Initially, many states filed the case, and in many states, many high courts, there is a stay at the 2 places. But in few states, this rule is still, authorities are enforcing rule. So we went to the Supreme Court regarding this. And as far as 6-month course is concerned, IRI is fighting since long with the government authorities regarding the same. As Das sir said, what IRI is doing for the members, and specifically for the young radiologists and residents. To start with, in the last year, we updated our website. Now our website is at par to any international societies. IRI has published a comprehensive textbook of radiology consisting of 6 volumes and more than 12,000 pages. The unique feature of this textbook is all authors are the Indian authors, and this is now a largest selling textbook of the radiology across all the platforms. Then as far as resident is concerned, we are conducting daily teaching programs for the residents. Daily means daily, and we have completed almost 1,300 days in continuous. There is a teaching for the residents, and this is according to their syllabus. And this program has become so popular in the residents. Nowadays, more and more resident members are basically taking benefit from this. For the female empowerment, female radiologist empowerment, we reserve a post of a vice president at the national level, as well as we are organizing a Shakti Summit at the national level. This year we are organizing Shakti Summit in the Surat next month. The unique feature of Shakti Summit is all organizers are female radiologists, all speakers are the female radiologists, but there is no discrimination for the delegates. IRI conducting MICR exams in India. There are 2 centers. One is at the IRI headquarters, Delhi, and another in the Chennai. We are planning to add 1 more center at the Mumbai. Our aim is to take our organization at par to any international societies like ECR and ISNR like that, RSNA like that. And we are making our global presence more and more. We are always trying to promote young radiologists, not only in academics, but at the organization level. Many things are happening in the RIA, but there are a lot of challenges also. And we need your active participation to face the challenges. Once again, thank you for inviting me. My best wishes for this conference. Thank you. Jai Hind, Jai RIA.
Thank you, sir. Lastly, I would like to call upon our chief guest and Medical Superintendent AIMS Bhubaneswar, Professor Dr. Dilip Kumar Parida, sir, to kindly address the gathering.
Dignitaries on the dais, off the dais, faculty members, dear students and delegates. It gives me a great pleasure to stand before you. We professionally are conjoined twins. My department is radiation oncology now, previously radiotherapy, and your radiodiagnosis. Both were born from same mother, radiology, early 80s. So we are brethren. That is the reason I could not say no to Suprabha and Tara. Today it's a coincidence that actually there are different other meetings going on. That is the reason actually director could not come to grace this meeting and sent me. And I am very happy the Department of Radiodiagnosis is organizing such an excellent academic event in our institute, which is our mandate, teaching, research, besides doing clinical. Radio diagnosis is a beautiful department. How much smart? Maybe when I go to Tara, Tara will give 3 reasons. There is a stricture inside me, there is a blockage inside me, and my prostate is not looking as smart as me inside. So the department is beautiful, but sees all ugly things inside. You are the Sanjay of Mahabharata in modern days. Our training was in 2D era. I have seen the dark room and dried the X-ray film, ultrasound, black and white. The first CT machine came to our state in 1994. But right now, both yours as well as mine department, technology has taken over, and as aptly said, now AI is going to enter, and nobody knows how much it will go inside. But anyway, we have to move with the time. There is no way out. Professor expressed his dismay. Young radiologists are not going to villages. India lives in village. That's very pleasant to hear only. But actually, when it comes to anyone, the thing is different. Anyway, again, thank you so very much for giving me an opportunity to stand before you and share some thought. Thank you, and I end here. Thank you.
Thank you so much, sir. As Dr. Ladbanskor ma'am has a flight to catch, I would like to request ma'am to come on the stage for felicitation. I request Dr. Suprabha ma'am and Dr. Satya sir to kindly felicitate ma'am. We would like to thank ma'am for an excellent live demonstration of fetal echo and level 2 anomaly scan. Thank you, ma'am. We will now begin with the felicitation of our dignitaries. Firstly, I would like to request ORIA President Dr. Prafulla Kumar Das sir to kindly felicitate our chief guest and Medical Superintendent Professor Dr. Dilip Kumar Parida sir. ठीक है सर. Thank you, sir. Next, I would like to request ORIA Secretary Dr. Satya Mahapatra sir to felicitate Dr. Nitin Shetty sir, ISVIR General Secretary. Next, I would like to request sir to kindly felicitate Dr. Ajay Kumar sir, ISVIR Chandigarh, Punjab, Himachal State Chapter. Kindly felicitate Dr. Ajay Kumar sir, ISVIR Chandigarh, Punjab, Himachal Pradesh State Chapter. Next, I would like to request Dr. Satya Mahapatra sir to kindly felicitate Dr. Sandeep Kafthale sir, IRI President-elect. Thank you so much, sir. Next, I would like to request our organizing chairperson, Dr. Sudipta Mahakud ma'am, to kindly felicitate Dr. Prafulla Kumar Das sir, ORIA President. Next, I would like to request ma'am to kindly felicitate Dr. Satyasundar G. Mahapatra sir, ORIA Secretary. Thank you, ma'am. I would like to call upon next Dr. Prafulla Kumar Das, sir, once again, ORI President, to felicitate Head of the Department, Dr. Suprabha Nayak, ma'am. Next, I would like to request sir once again to felicitate our organizing chairperson, Dr. Sudipta Mohakud, ma'am. Next, I would kindly request sir to felicitate Dr. Harish Bhujare, sir, ISVIR Organizing Secretary. Thank you, sir. Now I would like to call upon Dr. Ranjan Patel, sir, to kindly felicitate our organizing secretary, Dr. Tara Prasad Tripathi, sir. I would request everyone for a group photo to kindly stay back on the stage for a group photo. I would like to request all our dignitaries to kindly take their seat on the stage as we are about to begin the felicitation of our senior faculties. Now we shall begin with the felicitation of our senior faculties. I would like to call upon ORI President Dr. Prafulla Kumar Das, sir, to felicitate Dr. Shamimam Nisa, ma'am, retired professor and HOD Radio Diagnosis, MKCG Medical College, Behrampur. Next, I would like to request Sir to kindly felicitate Dr. Thank you so much, sir. Thank you, ma'am. Felicitate Dr. Shashmita Parida, ma'am, retired professor and HOD radio diagnosis, PRM Medical College, Baripada. I would like to call upon ORI Secretary Dr. Satya Sundarji Mahapatra, sir, to felicitate Dr. Kamal L. Mahapatra, sir, Senior Consultant Care Hospital.
We actually, this is a bad news as a society for us. Kamal sir has been our rock solid, sir, please come on the stage. He has been a rock solid backbone of this organization for a very long time. Unfortunately for us, sir is moving out to Delhi. He will be leaving Odisha. So we'll miss definitely sir in further conference. Please. Satya sir will felicitate sir.
Thank you so much, sir. With this, we come to the end of the felicitation program. Now, I would like to request everyone to kindly stand up for our national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल वंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
With this, we come to the end of the inaugural ceremony. And now, I would like now kindly request our delegates, I would kindly request our dignitaries to be seated with the audience for a talk by Dr. Ajay Kumar, sir. Yes.
The stage, I'll take the opportunity of this time to welcome and thank our chief guest, Dr. Parida sir, our very young and dynamic Dr. Nitin Shetty, who is secretary to the Central ISVIR, the team from the IRIA, Dr. Kavthale, Dr. Dash, Dr. Mohapatra, and my support pillar, Dr. Harish Bujade, and locally the leader and the guide for this entire conference, Dr. Suparva Naik. And last but not the least, and the showstopper, our star himself, which is there in the name, Dr. Tara. So great show. So this is not a lecture, this is not a talk. This is just time to introspect and how we can go ahead in the intervention radiology where we are right now. So, what is the need of discussion? The IR is a relatively newer but path-breaking specialty, and we are treating so many patients, but the recognition is not there. The awareness is not there. So, institutionalizing the intervention radiology with the help of the leaders in the medical field, leaders in the radiology, and healthcare policy makers, which will ensure the sustainable growth of the specialty. And in India, there is growing demand of the procedures, of the minimal invasive procedures, but we are not having well-trained and well-skilled professionals. And another important thing is infrastructure. So need of discussion for IR and this thing is, so I tell you one thing, so why we need to discuss, why we need to having lobbying or this thing, need of this thing. So even if a mother having a twin to her, so she feeds the kid who cries more, even if that kid is chubby and healthy. So we need to ask the policymakers, the person who are in helm of affair regarding the intervention radiology needs and what to be done in future. So what is the problem? Problem is from the start only, nomenclature of the specialty. So many places it is called MD radiology, and in past, as Chief Guest Sir himself told, that in past the radiology was dealing with imaging as well as therapy. But later on radiotherapy separated out for a good reason, and now it is a totally separate department and well recognized department. Another terminology, MD radiodiagnosis. The radiodiagnosis, the diagnosis with the help of X-rays, but there is no mention of ultrasound waves, there is no mention of magnetism, and the most importantly intervention part, which is very much important. Now we are working in tandem with our clinicians for the complete and standalone treatment in many diseases. Now onwards, like there are many places where MD diagnostic and intervention radiology is there at some places, which is a bit better. But what I want to stress upon here, the name has to be imaging medicine, so that even our residents are having that kind of mindset that we are part of medicine. We need to talk to the patient. We need to like write the report very much carefully. We need to take care of the patient post-op or post-imaging also. We have to take the follow-up. Right now what happens, our residents, they think just their business is just to sit in the air-conditioned rooms and just do the diagnosis part of it. But that is not the true. So this I was trying to see the AIMS Bhubaneswar. The name is radio diagnosis. In AIMS Rishikesh, the name is diagnostic and intervention radiology. In Central AIMS, the name of the department is again radio diagnosis. At my institute, it is radio diagnosis and imaging. So our administration is same. We all fall under NMC and Health Ministry, but there is a lot of difference of the names, and this creates problem when our students are practicing in India or abroad. So their certifications, the nomenclature is different. So this creates a lot of problem. Our student, after doing Same true for IR specialty. There is DM neuroradiology, then at some places that is DM in neuroimaging and interventional neuroradiology. So our previous students, 6 to 7 years before, they were having degree only DM neuroradiology, and they when they went to work like in abroad, in Middle East, in Dubai or Europe, so this degree creates problem that they say there is nowhere it is mentioned that you can treat the patient. There is nothing written like intervention neuroradiology in those things. So we have changed this name in our department, but lot many things to do, and that is the idea of making aware the general public as well as the policymakers. So IR, what IR do, everyone knows that with the help of image guidance and with the help of hardware, we do minimal invasive procedure, and that can be standalone or for the diagnosis adjunct to the clinician, or adjunct to the clinician some therapies, some so who are the stakeholders in this? The intervention radiologist, the hospital administration and infrastructure, fellow clinicians, especially the anesthesia department, that is whatever, if I am a neuroradiologist, I am working with neurosurgeons. The body interventionists, they work in very close association with hepatologists and general surgeon and medicine. And the most important stakeholder is the patient. If the patient is taken care well, so they will always remember you, and that is the further advertisement for your specialty. And you have to tell that you are coming from which specialty and what are you doing and how it is different from the past when the surgeries or things were done with the laparotomy and other things. Then policy makers in the government. We all from students and seniors are there, and they are in helm of affair in different things. So we should make it very much clear whenever we are meeting them, at least discuss all these issues, because whatever, when you are out of sight, you are out of mind. When you are not going there, you are not talking about your specialty, then you are invisible to them. Another important is industry. Industry is very much happy helping the intervention radiologists in the major cities, like in tier 1 cities in like Mumbai, Delhi, Chennai, where they are having a lot of business. And they don't want to go to the places where there is no business. So this is vicious cycle. When you are not going to go there, the business will not start. So all these things we have to tell them that you have to start from somewhere. In PGI, when we were working, say 15, 16 years before, we were working only with one company. And when we came to know that there are a hell lot of companies who are making hardwares, and we started approaching them, then they came to know that some kind of work is being done in Chandigarh also. So now at this point we are having whatever possible on this earth, even if it is not available to US or European guys, it is with us. So that is there with the awareness on all the corners, your clinicians, industry guys, policy makers, and all those. So what are the barriers? What are the problems with the intervention radiology? Many students, they come to the intervention radiology because of glamour part of it, but they are of the mindset that I am taking the radiology, I am on the top of the rank, I am taking the radiology just to sit and report. And sometimes they glamorize with the intervention and they go toward the intervention side. But that is not the right approach. Whosoever entering into the intervention radiology, they should be ready for 24/7 availability, talking to the patient, touching the patient, dealing with the complication, dealing with stress. and dealing with so many things. Infrastructure again, not a problem with the institutes, and we are very much lucky to have now so many aims across the India. So the government is providing us the infrastructure and we have to make the maximum use of it. Industry and hardware companies, again, the people who are working in the better place like Dr. Nitin, myself, so we have to push the company guys to help those guys who are starting somewhere in peripheries. The awareness amongst the medicos and general public. See, awareness many a times in your hospital, in AIMS only, many of the clinicians, they might not be aware of what all you are doing with the intervention radiology. And this is my job to tell them, to go to them, and that this is happening in our place. So I'll tell a small example about this. The vein of Galen patients, they are young, newborn, and just 5 to 6 years before we were not getting these patients for the treatment because our gynae department was not aware, our neonatology department was not aware about the possible treatment. But when we showed them 2 or 3 cases, gone to their meetings, gone to their societies, and start telling them that we are doing this. So now it is rarest of rare disease, but we are getting say 1 or 2 cases in a month because now they know these patients can be helped. Weak and heterogeneous policies are there. We have to like homogenize them, like with the help of IRIA, ISVIR, ISNR, and different chapters. So sailing through this, all our problems, how can we get away and conquer this problem? So positive mindset with adequate enthusiasm. I am using this term adequate enthusiasm, not aggression. Aggression creates offense. So you have to have adequate enthusiasm while dealing with the patient, while dealing with your clinician, and consistency. It is not like that I am doing IR today, tomorrow I am not feeling like, or I am not going to practice this. Never say no policy. Approach and 24/7 availability. So if I want to do intervention radiology only in the daytime and only on the weekdays, I'm not like very much happy coming on Sundays. This is not going to do. Good interpersonal relationship with the fellow clinicians along with safeguarding your specialty. This is important. I am eyeing for good interpersonal relationship, but I should not compromise about my specialty, and I have to safeguard the nooks and corner of my specialty. Professionalism. Never get indulged with anything. You have to see all the things like far off, and you should not party to any bad mouthing on all those things. Relevance and say in the policy making, I have told it before, try to keep the cost as low as possible. We are living in India, and most of our patients, they pay from their own pocket. So what we need to do, if we want to like in the forefront of what is the problem with intervention radiology, it is very much costly affair. A surgery is going to be costing like 10,000 or 15,000, but the same procedure, if you go for intervention radiology, it might go for 50,000 to 1 lakh, but the patients are ready to pay if they are very much confident that it is cost effective. So there are so many ways and means to do one thing, from the as low as hardware possible or to the maximum hardware available. Continuous updating the skill and knowledge. Publications, again, make yourself visible in publication, not only in the intervention or radiology arena, but On the clinician side, then only the awareness is going to increase. The conference and workshop, see myself, our society, Dr. Nitin, IRIA, we are working day and night trying to achieve the awareness with the help of conferences, workshop, outreach programs. And let me tell you, there is hell lot of change and so many departments are cropping up with the intervention radiology and they are doing the best. The international collaborations, whenever we are going to international conferences, try to be visible there, try to present something, even if it is a poster, even if it is an oral presentation. So make yourself. So what is turf erosion, turf war? I will tell this is all confusion among the different specialities. So this side there is very primitive organism, amoeba, and amoeba, this is the leg of amoeba, this is the heart, this is the stomach, everything is in the one cell. But this is very much primitive. Now we are in 2025 and we are human being and we are Homo sapiens and then sapiens. So now there are different body zones work differently in the different zones. They collaborate with each other, but they do not interfere in the work of each other. Same holds true for the medical specialty. I am doing intervention radiology. I am trained for it. I am trained for it from last say 5 to 7 years. I know the three-dimensional understanding of the body. My surgeon also knows, but he is not or the medicine or other respected fellows, but their training is somewhere else. So ultimate thing is the good outcome. So whosoever is good at the particular subject, whosoever is trained well in that particular subject, they should do the work to get good name to the specialty. And what are the reasons for this? The possessiveness among any specialty. I am a radiologist. I will think I will not share this thing with the other specialty. Somebody is neurosurgeon. They think that they have to clip all the aneurysms and the coiling is doesn't make any sense. So this possessiveness is the problem. And another important thing, glamour associated with the minimal invasive techniques. So that is another thing. And the most important thing, it is best for the patient. So if I am not keeping fine, I am having some problem, and the first and foremost question for me, if I am a patient, कि डॉक्टर साहब खाली दवाई से ट्रीट हो जाएगा क्या? वो कहेगा नहीं, दवाई से नहीं कर सकते, सर्जरी करनी पड़ेगी. तो सर्जरी कुछ छोटे से छोटा कर सकते हैं, ज़्यादा से ज़्यादा बड़ा इंसिजन ना लगे. So that is the idea with intervention radiology, and this is why that everybody is tilted toward the intervention radiology, and they want that they are going to learn their part. The neurosurgeon is going to, or neurologist is going to learn the stroke or aneurysm treatment. The hepatologist, they want to learn the PTBD and all those things. But we have to safeguard our specialty, not offending anybody, but keeping your point valid, strong and unchanged. So what are the positive aspects of turf erosion? Whenever we are having less manpower in some periphery, and some in the countries like Scandinavian countries, there in their single city they are having only one cardiologist and one radiologist. So they are doing the work of cardiology also, they are doing the work of neuroradiology also, they are training for everything. But same is not, same doesn't hold true for India. We are the country of maximum population, and we are the country with so many doctors. What are the negative aspects? Sense of possessiveness, single person holding multiple skills, so he'll be jack of all but master of none. Having no or suboptimal training, because somebody has already given his career 5 to 7 years, then first MD, then DM in DM or MCH in neurosurgery. Now he wants to pursue the endovascular part also. Now he get the smallest period of training. So poor patient outcome and bad name to the specialty is the problem. Self-referral will be the problem, and lack of audit. See, whatever I do, I am being audited by my clinicians because patient come from them and it goes to them. So I am being cross-checked. So I have to like keep pace with the good outcomes and the good outcome of the patient. Higher programs in India, they are non-structured like observership and fellowship. There are structured and recognized like fellowship or PDCC or DM programs. But sadly, all are recognized same at corporate hospitals. So in government, yes, there are check and balances, but in corporate hospitals, everyone is same. I am same, and if somebody is doing some observership from somebody who was already untrained, and now he is a recognized so-called IR in that particular field. So that is the problem. So it improves the outcome, reduce the hospital stay, lowers the cost, enhance the hospital reputation, your department reputation and revenue, and align with modern patient care models. So this is not the problem only in India. There are intervention radiology program in abroad also, and they all are having different names. So this is one important article which says like recognition of the intervention radiology as a specialty will erase the invisible radiologist stereotype. So we have to like do more onto this. Daughter very rightly profiled. If we don't assume clinical responsibility of our patient, we will face the forfeiture. Forfeiture means our specialty will be in others' hand of our territorial rights based solely on the imaging equipment and other obtains skill and they can learn. So if we are not doing, somebody else will do. So this is very much important. So if we are not part of policy making, this is very important quote. If you are not at the table, you are part of menu. So choice is yours. So bottom lines, institutionalizing intervention radiology ensure sustainability, leadership, policy, infrastructure are the key. Collaboration among the stakeholders. Stakeholders means the doctor, patient, and the company guys, my policy makers, they are vital. So this is my acknowledgement, my all teachers, my patients, Dr. Anuj, Dr. Ujwal, Dr. Navojit and Sarfaraz who helped me for this presentation, and thank you all. And I invite you all for the 27th annual conference of Indian Society of Neuroradiology in the city beautiful Chandigarh. Thank you. Any questions or suggestions? Better, there are so many seniors are there, they are teachers. So if I kind of left something, if there are some suggestions on this. Dr. Nitin can add something on this. Dr. Harish, they are young guys also. Now can I invite everybody for lunch?
Sir,
From the organizer's side?
I'll just give the vote of thanks.
Oh, vote of thanks. Please come. Thank you, Dr.
Thank you, Ajay sir, for this enlightening talk. So I'll just finish off the inauguration with the vote of thanks. So respected chief guest, our dignitaries on the dais and senior faculty members, esteemed delegates, dear colleagues, it's my privilege to propose the vote of thanks on behalf of the organizing committee of the 51st Annual State Conference of ORIA, which was held along with ISVR outreach program. So I like to extend my heartfelt gratitude to our chief guest. Besides that, all the distinguished speakers and faculties who have traveled from different parts of the country to be with us today. Your expertise and commitment elevate this conference and enrich every participant. A special thanks to ORIA leadership who gave us this opportunity to organize this hybrid sort of program in between the ORIA and ISVR. The ISVR leadership and area leadership who have traveled here to be part of this program. I'd like to thank both of them. My heartfelt thanks to the organizing committee, volunteers, residents, and our technical teams who have worked tirelessly over the past weeks and months. Their dedication behind the scene ensured the smooth running of everything. To all the delegates whose enthusiastic participation have pushed us to give a good show, your presence adds energy and purpose to this academic gathering. We hope the next 2 days will be enriching with the lectures and the workshops in store. With this, we conclude the inaugural ceremony and look forward for an exciting, academically rewarding conference ahead. So we'll please move to the lunch, which is through this exit gate. We have the lunch area. So after lunch, we will restart the academic program. Thank you. We have a session that was not completed. We'll just complete that session. Mention oncology session that was not completed. I'd like to call Satya Mahapatra sir to chair the session. Satya sir, we'll complete that session, sir. That was not completed, sir. Sir, please come on the stage. Premraj sir. Surai Murmu sir, please come on the stage. Dr. Surai Murmu sir, please come on the stage. Sir.
We'll continue our session on interventional oncology. So the second speaker on this topic is Dr. Nitin Shetty. He's going to speak on the topic of beyond loco-regional therapy, TACE in the age of immuno-oncology. I welcome sir to the dais.
Thank you, Tara, Ranjan, for the kind invite. I think this is a very focused topic. So I'll have to start the discussion and the talk, assuming that all are aware of what TACE is, because I'm not getting into the basic of TACE. So straight away going on to when it comes to HCC, the management, it always has to be based, it has to be graded, it has to be staged. And one of the staging system that we follow is the Barcelona Clinic liver cancer staging system. That is called the BCLC, which very clearly demarcates, towards the right is the higher stage wherein not much can be offered palliative care and systemic chemotherapy, and towards the left is much more curative intent where we have ablation, resection and transplant. And in between this, the curative and palliative is something that is the intermediate stage where the role of TACE comes. So now essentially TACE, the intent of TACE is to make to downstage or bridge the treatment so that the patient goes towards the curative intent. Alright, so there are a lot of transarterial treatment that are available. It can be bland embolization called as TAE, it can be chemoembolization where chemotherapy and embolization both are done, which is called TACE, or it can be radioembolization, which is STARE. Now the concept is very simple. You do the angiography of the liver, identify all the feeders that are going to the tumor, go into take the microcatheter into the feeding artery. Do you have a pointer? Okay, so you take it to the point where, so you take the catheter over there and very directed towards the tumor, you inject this chemotherapy and the embolizing agent so that the tumor shrinks and the parenchyma remains stable. So that's the whole intent. Now with the latest we have got the balloon TACE wherein you occlude actually the branch, and so that whenever you inject, the flow is preferentially towards the tumor. So what type of candidates are ideal for TACE? So we all know that it should be a large or multiple tumors not amenable for surgery, and then it should have a good function because posterior procedures, there should not be liver decompensation. There should be, the tumor has to be within the liver, and most importantly, the portal vein has to remain patent. So these are the major criteria that we look at when we are doing TACE. And why we have been doing TACE? Because it has been from the 2000 proven that there has been survival benefit when we do TACE as compared to the patient left alone. Here we can see that the survival has steadily been increasing from 14 months to 20 months to the latest one which published in 2018. It shows that the survival is as close to 37 months, that is close to 3 years. Right. So among all this trial, this was essentially a TACE trial, and there was one trial which included for the first time the chemotherapy, that is called that was the Brivanib was used, which also showed that addition of this chemotherapy did not make any much difference. So this is in short how TACE is formed. So despite having 3 years of survival, there has been some limitation. So one of the limitation is the recurrence rate. That is, after at 3 years, once it recurs, it has been shown that the survival rate just is 30%, 31%. That means that 100 people are treated, so at the end of 3 years, only 30 are surviving. So that's a pretty bad survival rate. And also, whenever TACE is done prior to resection, that's called as a neoadjuvant TACE, with or without TACE, they have not found any survival benefit. So in short, all the attempt to combine other treatment along with TACE is in a way to improve the survival. So what are the candidates? These are called all the TACE refractory and TACE failure patients. So these are the ideal patients for whom there should be an additional of some treatment along with TACE. So as per the Korean and also as per the Japanese criteria, if you are doing TACE to a particular tumor, despite changing the chemotherapy, changing and identifying the arteries and changing the route of delivery, if there is no response, that is called as TACE failure or TACE refractory. Also, there is another set of patients called TACE unsuitable, that is though you cannot do TACE, and one of them is up to seven criteria out nodules. So up to 7 criteria means any nodules which is either more than 7 centimeter or more than 7 in number. So this is up to 7 criteria out. So these are the patients whom they have shown that is not going to respond to TACE. So TACE refractory, TACE failure, TACE unsuitable. These are the 3 patients for whom along with TACE we need to do something more. So this right now the hot topic is combining, because multiple trials have shown that combining it with systemic therapy has not given good survival benefit. So they have now combining immunotherapies, which in this point is called as a checkpoint inhibitors, to combine along with TACE. So TACE plus checkpoint inhibitors is undergoing trials. So in simple, body has got a mechanism wherein the immune cells going overdrive is prevented. So there is multiplication of the T lymphocytes, the immune cell, but this PD1 and PDL1, this is the combination, and also CTLA4. So just remember, these are just PD1, PDL1 and CTLA4. These are the receptors or antigens which keep the immune in check. Okay. So anytime PD1 and PDL1 combines, there is immunosuppression. So the body, there are signals which says that enough of synthesizing T cells. Whenever the T cells combines with the CTLA4, that's get activated, again a signal goes telling that the immune activity is too much, stop. And tumor cells are quite good at that. So they have a system wherein it upregulates the CTA and also upregulates the PDL1, so that there is by some way suppression of the immune system. This is called as immune checkpoint, and the drugs which block this PDL1 receptor or PD1 receptor or this CTLA4. So if these three receptors are somehow blocked, that means that the immune system can, more number of lymphocytes can be produced, and it will become overdrive. It will go overdrive so that it controls the tumor. All right. So how does TACE help in that? So essentially the tumor is sitting in the liver and it is all suppress the immune system. You do embolization, there is necrosis. The minute there is a necrosis, there is antigen release. So what is a cold tumor suddenly becomes a hot tumor. It's like you are given vaccine and the immune system goes active. So this is what happens. Second, because there is necrosis, there is more inflammatory cells that are reaching there. Once the inflammatory cells reach there, more antigens are picked up. So that is another advantage. Third one is overall the tumor burden. It reduces, it shrinks in size. And because it shrinks in size, the response becomes better. And this is an additional point. Whenever there is a release of, there is chemoembolization that is done, there is hypoxia, and hypoxia releases VEGF. So these VEGF are one which are secreted by the tumor. It helps in neovascularity. Okay. So combining this TACE with the VEGF inhibitor, in fact, it normalizes the vessels, and so the activity is better. So in short, by blocking the immune checkpoints, the immune cells increases in number and they become quite active. Just two trials that was released in the earlier part of this year. There were, one is called as the Emerald 1 trial, where it combined in one arm the IO agent, that is the durvalumab, and the other arm there was just a placebo. It showed that there was a progression-free survival of around 15 months. So instead of 8 months survival where nothing was given, the survival improved to 15 months, which showed that there was a beneficial effect of combining IO. Right. Another study, again published in this 2025 Jan, is a LEAP 012 trial. Again, this combined the TACE with Pembro versus TACE and only the placebo, which also showed that there was a improvement in the median progression-free survival. But what was also important is that the adverse event by combining IO with TACE also increases, because like I told, the immune system goes overdrive whenever you remove the checkpoint, and it does not differentiate whether the T cells are attacking the tumor cells or the normal cells. So all the autoimmune diseases like the colitis, the hepatitis, the pneumonitis, all these autoimmune diseases are actually, it will increase once you give a checkpoint inhibitor. Okay, this is just a reference. I took it from this article. You can see a large tumor, again more than 7 centimeter. A TACE was done, and then it had reduced significantly, and new lesion came for which it was less than 3 centimeters. So the RFA was done. So at 20 weeks, at 100 weeks, again almost 2 years, another new lesion came which was ablated, and you can see that beyond, it's almost 200 weeks, that is close to 3.5 years, there is still the disease is under control. So definitely there is improvement in the survival when you combine TACE with IO. So next question is sequencing. Which one would you want to do first, the IO first or the TACE first? So the classical sequence is do TACE first and then you start on IO. So this is predominantly done if the tumor burden is low and the liver function is good. And the late TACE, that is first start on immunotherapy and then do TACE. This is called as a late TACE. This is classically beneficial if the tumor burden is high. Because the tumor burden is high, first you would want the immune system to be activated, and after that you do TACE so that the immune cells are ready to go and counter the cells, the tumor cells. So all in all, combining TACE and IO, it prevents recurrences, or I would say rather it delays the recurrences, as well as the micrometastasis which are not seen on imaging is also taken care. So that's about the TACE, but is there any role with the other transarterial treatment, that is the radioembolization? There are a lot of trials that are going on. We don't have conclusive evidence of combining TARE with IO, but this is one anecdotal case which we had in the department, a case of CLD with HCC. You can see that is arterially enhancing, and then this is the thrombus extending all the way till the main portal vein. So the disease burden was definitely higher. So only IO would not have control. So we did TARE, the radioembolization, and then it was followed by atezo-beva combination. So the atezo is the IO component, and after that you can see that there is significant reduction in the size, there is atrophy, the arterial enhancement goes off, and even the portal vein has shrunken as compared to the previous one where it was quite expanded. So the disease is under control, and progressive there is enlargement of the or compensatory hypertrophy of the left lobe also. So in a way, just to conclude, this I would say that it's like the couple has just recently got wedded. So the IO and the TACE, they are trying to find a balance with each other. As the days pass or as the years pass, we will come to know the strength and weakness of each of these modality, TACE individually and the IO individually, and we will definitely come to know which is the best way, which is the best combination. But definitely in whatever trial that we have done, which is there in evidence, it shows that the survival has improved, so also is the complication. But then the call has to be multidisciplinary. There has to be a medical oncologist on board, and it's a combined decision as to whether the patient has to be TACed first or TACed next. So we are finding the ideal candidate for the combination therapy upfront, and also trying to sequence that for the maximum effect. So that was all about the combination of TACE along with the immunotherapy. If there are any questions, I'm happy to answer. And thank you.
Thank you, sir. Coming to the last speaker in the interventional oncology session, I would like to invite Dr. Harish Bujade, sir, to talk on ablative therapies in liver tumors.
Good afternoon, everyone. So my topic is ablative therapy in liver tumor. So what has been previously discussed about the TACE, that is in the intermediate stage, we will see this is before the TACE or in the early stage. So ablative therapy is basically, it's a minimally invasive image guided treatment which destroys the tumor. So ablation means destruction of the tumor either using the heat, cold or liquid chemical based tools. So this can be applied to primary liver tumors like HCC or the metastatic liver tumor. Most commonly is done for the metastatic in colorectal metastasis. So our goal is to attain the A0 margin. So in surgery, when any surgeon do the surgery, they resect the cancer, take the 1 centimeter off or 5 mm of margin. So similarly, during the ablation, we have to take the 5 mm or 10 mm margin. So as we are doing this procedure on image guidance, we have to take help of the ultrasound or the CT. Most common it's done under the ultrasound guidance, because On ultrasound, the liver tumor are very well visualized. However, in some high dome cases, we may require CT guidance. So this is BCLC treatment guideline. So ablation fall in the very early and the early stage of HCC. So bottom line of this BCLC staging is the less than 3 centimeter tumor which are surgically unfit for resection or transplant or waiting for transplant, and number of lesions should be less than 3. So in those cases we can do ablation. So this is for the HCC. And what about in metastatic disease? So in metastatic disease, the primary disease should be controlled. There should not be any extra hepatic disease and there should be adequate liver function. In metastasis, we can ablate up to 5 lesions and that should be less than 3 centimeter. So for HCC, it's less than 3 centimeter up to 3 lesions, and for metastasis, it's 5 lesions less than 3 centimeter. So in metastasis, there are two intent. One is a palliative intent, one is a curative intent. In curative intent, usually they are for the up to 3 to 5 lesions. In palliative intent, it is just to control the disease. If any lesion which is causing other symptom like compression, or then we can use the palliative, or it is causing pain, then it can be used for palliation. So coming to various ablative modalities, it can be chemical ablation, thermal ablation, or non-thermal, non-chemical ablation. In chemical ablation, percutaneous ethanol injection and percutaneous acetic acid injection into the tumor can be done. In thermal ablation, radio frequency ablation, microwave, cryo ablation, then HIFU, that is high intensity focus ultrasound to the tumor, laser ablation, hysteroscopy. Hysteroscopy is the new tool on this list, and currently this is not available in India, and this is also a ultrasound based technique. In non-thermal, non-chemical technique, it's a irreversible electroporation in which high electricity current is passed through the probe into the tumor, which causes destruction of the tumor. So I will be talking more focused on the RFA, microwave, and the cryoablation. So this is I usually do in all my talk. This is one glass sketch made by me. So this just to represent that the alcohol can cause HCC, and alcohol is actually used to treat the HCC. So coming to chemical ablation, the mechanism is it causes cytoplasmic dehydration, protein denaturation, which causes coagulative necrosis of the tumor cell. Apart from this, there is vascular endothelial damage which leads to occlusion of this vessel, thrombosis, and the ischemia, which causes the secondary necrosis. So it will act by two ways, and it will increase the amount of necrosis. So we have to use the smaller gauge needle to enter into the tumor, and this is the specialized needle with multi prongs. You have to it's like a biopsy. You have to reach the center of the lesion, then open the prongs, and each prong has side holes through which the alcohol can be injected. So this is one case in which there is this enhancing lesion with the washout and the capsule formation, and then needle is inserted into this lesion followed by the alcohol injection. So once alcohol injection, you can see the air foci within this lesion, which if the air foci covers completely the lesion, that means its complete ablation is done. And on follow up, we can see there is a non-enhancing lesion. So disadvantage include because alcohol, there is no control, so we have to do multiple sessions. There can be uncontrolled instillation, or there can be more chances of residual. So nowadays, alcohol ablation is seldom used. We just use in case we do microwave or the other ablation, and there is a small 5 mm or 10 mm residual lesion, and which can be targeted with the alcohol ablation. So instead of alcohol, acetic acid can be used. The advantage of acetic acid is it can diffuse through the fibrous capsule of the tumor, and which can produce more effect than the alcohol, absolute alcohol. This is another my two sketches. So I think many of you may not know, this is Nicole Kidman, an Australian actress, and this must be known to everyone. This is Madhuri Dixit's sketch. So coming to hot treatment. So hot treatments are head-based ablation. So the first and foremost is a radiofrequency ablation, which is considered first-line treatment in unresectable SCC less than 3 centimeter. So the mechanism of radiofrequency is it uses alternating current, which causes the agitation agitation of the ions, which releases the local heat, and heat causes the thermal damage through the coagulative necrosis. So for this we need to at least to have the temperature of 50 degree, because the protein denaturation start around 50 to 60 degree. So we need to go beyond this temperature. So usually up to 90 or 100 degrees Celsius temperature is enough to ablate the lesion, and we have to make the ablation zone of more. If the lesion is 3 centimeter, we have to make ablation zone of 3.5 or 4 centimeter. In the radio frequency ablation, there is a RF generator which give the power to this RF probe, and there is a RF probe. We have to directly insert the RF probe under ultrasound guidance into the liver lesion, and it is connected to the generator, and there is a grounding pad to complete the electrical circuit. So this is one case in which there is a hypervascular lesion here, and this is after ablation. There is a air foci covering this lesion, and on follow-up we can see there is a no enhancement in the arterial bed and in the venous space. So this is suggestive of non-viable lesion. So this is another case in which there is a high dome lesion. This is the high dome lesion, and it is not well visualized on ultrasound. Then we take guidance of the CT, and CT guided this probe is inserted, and then after the CT the ablation has started, we can monitor it on ultrasound. The air foci can be seen, and this is on follow up, which shows non-viable lesion. Coming to complication of the application are very less. These are the mortality is less than 0.5%. And the major complication it related to pain and the damage to the surrounding structure. So mostly the RF is used when it is not in the center, it is in the periphery, non-exophytic or subcapsular you can do with the formation of hydrodissection or the formation of ascites. Another heat-based modality is a microwave ablation. Microwave radiation is electromagnetic energy. So this deliver the microwave waves within the lesion, which causes interaction of the agitation of the water molecule, and interaction of the water molecule releases the heat, and which leads to coagulative necrosis of the tumor cell. So this is a small video. So this is the microwave antenna. This is the local is given at this site, and we have to see this is the local from this side. We can see the lesion is here, very nicely seen on ultrasound. Under ultrasound guidance, we have to puncture, and this is actually been done under sedation. But first we need to insert the probe into the lesion, and then we give the sedation to patient, because we need patient to hold the breath during specific time so that the lesion get visible on ultrasound. Once your position is done, you can apply the you can start the generator, and this is the electric current is passing through the probe, and it causing formation of this air foci. This is air bubble. Once the air bubble covers the lesion, that means your ablation is done. So the another role of ablation apart from HCC is metastasis. So this patient has underwent colonic resection, and after that there was a lesion in the liver, which is around 3.5 centimeter, and for this lesion the microwave ablation is done, and you can see it is completely covering this lesion. And on follow up, not only this, the lesion will shrink, this ablation zone looks more enlarged in size because it is more than the lesion. But on follow up, we usually do PET scan after the metastatic ablation and triphasic CT or MR after the HCC ablation. So RFA versus microwave. Nowadays most of the companies are not making RFA probes because microwave have taken over the RFA. So there are advantages of microwave over the RFA. So in microwave, no grounding pad is required. There is less susceptibility to the heat sink effect. So heat sink effect is whenever there is a one vessel adjacent to tumor, the all heat will carried away by the flowing blood in the vessel. So in that case, the microwave is, because microwave causes the instant formation of the heat compared to RFA. RFA is slow burning, microwave is instant burning. So there are other advantage of microwave, that even the slight larger lesion can be ablated, and the surgical clip or pacemaker is not a contraindication for microwave. So this is my another sketch. This is one character from the Game of Thrones. If you remember, this This was few years back. And the one saying in that is a winter is coming. So whenever winter is coming, we go to the next ablative modality, that is the cold base modality, that is ice. And cryoablation is a ice based modality to ablate the lesion, in which the low temperature is used to form the ice within the tumor. So it based on the Joule-Thomson effect, in which the argon or nitrogen gas is passed through a small chamber and allowed to expand, and once it expands, there is a loss of temperature in surrounding, which causes the ice crystal formation. Once the ice crystal form intracellularly, it causes the solute solvent switch, and there is a tumor dehydration and rupture, which causes the necrosis. So this is how this after placement, this is ice ball will look on ultrasound. It shows this echogenic border. This is the ice ball and the shadowing, and on ultrasound it looks hypodense. So compared to RFA and microwave, if you see there is a gas bubble in RFA and microwave, and in this case instead of gas bubble we see a hypodense area. So the margin of ablation is very clear. So advantage of cryoablation is we can actually see the margin of ablation, so better control of the tumor. So as I said, size and shape of the cryotherapy can be seen on the CT or MRI. So there is accurate monitoring of the procedure. This is relatively pain, because if you have pain we apply the ice, and this is ice based treatment, so pain is relatively lesser than the microwave. So cryoablation, the complications are similar to microwave, that is collateral damage or the bleeding, but pain is lesser, but other side effect of the RFA and microwave are similar to cryo. Then this is one published article from our center. We have this published, in which we found that there is no local progression. This was a small sample size publication, and the cryo is feasible in HCC, and it is a effective and safe technique for HCC in CLD patient. Another article in which we the local survival and local recurrence after RFA, microwave and cryoablation were evaluated, and actually all three modality are equally effective for the LRT, but there are some technical differences, but the overall survival of all the modalities are same. So coming to another, the ablation modality, this is non-thermal, non-chemical ablative modality. This is called irreversible electroporation, in which there is a once the current is passed into the probe, it will form the pores within the cell membrane, which causes the lysis of the cell and the apoptosis of the cell. So in IRE, there is a natural cell death. The cell is death by the natural means, not by the coagulative necrosis. In other modality, there is a coagulative necrosis. So IRE is to be done under GA, because the actual, once the probe is inserted, 3000 volt has been applied to the probe, and it will create the electrical circle between two probes, and it will form the nanopore within the cell. So this is the video which is showing, this is how when the electrical current passed, and you have to give the good muscle relaxant, and these are the probes to cover the tumor. So we have to cover the tumor like this, and you have to keep all in parallel to each other, so that the electrical circuit is complete. And the IRE is more challenging than the cryoablation or the microwave or the RFA, because in those modalities single probe is used, while in IRE we have to be parallel to each other. The distance between two probes should be 1.5 to 2 centimeter. So we cannot go beyond 3 centimeter. If you go beyond 3 centimeter, there is no electrical activity between two probes. So this is one case. So IRE is limited for the centrally located tumor, because IRE don't cause damage to the bile duct wall or the vessel wall, because it causes nanopore, and endothelium or the connective tissue don't have this cell membrane. So this is one case in which there was a lesion in the caudate lobe, which is arterial hypervascular washout with capsule, and then these are the parallel probe inserted into the tumor, and this is post procedure. There is a non-enhancement of this tumor, and on follow-up also there is a non-enhancement of this tumor. So the other role of IRE in other tumor as well. Now this patient has one lesion here which is very central. So surgeon asked to first ablate to decrease the size, and then they can go ahead with the surgery. So IRE was done for this lesion. The lesion shrunk and they got the margin free from the vessel, and then they resect this central resection was done, and you can see the resection specimen. So IRE can be useful before the pre-surgery. This is our experience in IRE, which was published in European journal. So in which we found that it is technically successful in all patients, though the technique is more challenging than the RFA and microwave, and it is effective for the smaller lesion like 3 centimeter, or very effective in 2 centimeter lesion. So another meta-analysis published for IRE, which also shows that it is more than it has good survival and progression-free survival. Complications are related to general anesthesia and the electrical current. So it is the cardiac arrhythmia, electrolyte imbalance, and these are the more, these are transient. There is no, because first we give the test pulse and then we go ahead with the complete cycle, and other are the same as bleeding or the pain at the site of ablation. So this is one article, I think this is a landmark article, and every resident should go through this article, because for the colorectal metastasis surgery is the first choice, but this article suggests that the overall survival with the surgery and the ablation is same, and in fact there is a decreased hospital stay, shorter duration, and better early quality of life is better in the ablation group than the open surgical group. So there are new emerging trend, like I said, RFA is nowadays is not that much popular. Now the microwave is, most of the intervention radiologists are using microwave, and there are new robotic and navigation system to see the exact ablation zone and to place the needle. Then it can be combined with immunotherapy, as TACE is combined with immunotherapy. So this is our model how we do ablation of the liver tumor in PGI. So this is the liver hilum and lesion close to liver hilum. These are for the less than 3 centimeter lesion. Liver hilum, lesion close to liver hilum, IRE, and or the cryo. Then if it is close to the vessel, so in this the lesion is very close to the vessel, then microwave is preferred, and if lesion is peripheral, not close to any vessel, then RFA is preferred. So this is another two sketch. This is Charles Totter, father of intervention radiology, and this is one character from the Netflix series. And thank you very much. And I would like to thank the organizer for having me there. So this is yesterday's photograph of Chilka Lake. So it's very beautiful lake. Thank you.
Thank you, Dr. Harris, for the excellent presentation and demonstration of all modalities to address liver tumors. Thank you. Any questions from the audience? Okay, thank you.
Thank you.
Thank you, sir. That was very insightful. So we have come to the end of the session on interventional oncology. Now I call upon Dr. BK Samal sir to felicitate the speakers and the chairperson. The chairpersons for this sessions were Dr. Satya Mohapatra sir, Premraj Satpathy sir, and Sir A. Murmu sir, and Sailendra Kumar Prishti sir. You can come towards us. The sir will felicitate. I would like to also call upon the speakers for this session, Dr. Falguni Hotta sir, and Dr. Nitin Shetty sir, and Dr. Harish Bujade sir. Dr. Falguni Hatta, sir. I request all the speakers and chairpersons to take a good photo. Move on to the next session, the session on vascular interventions. For this, as chairpersons, I would like to call Dr. Debashish Padi sir, Dr. Siddharth Satya sir, Dr. Sangram Panda sir, Dr. Tapas Sahu, and Dr. Shrikant Panigrai sir.
Good afternoon. So first of all, I would like to thank the ORIA organizing committee for inviting me in this conference. So I will start. My topic is vascular access routes in endovascular intervention and closure device. So I will be talking about vascular access. So this is the most, we know that most critical part of every endovascular procedure. Success of every endovascular procedure lies in a safe, efficient vascular access and adequate hemoptysis after the end of the procedure to minimize complication and for best possible outcome of patients. The choice of vascular access route significantly impacts the procedure success as well as patient's comfort and complication rate. Successful access usually based on the knowledge of anatomy, basic principle and skill of an individual patient characteristics. For adequate hemostasis, traditionally manual compression techniques is the most often used, and now there are a variety of vascular closure devices available which if properly used can greatly assist in securing adequate hemostasis. So first talking about the vascular access technique, as we all know that in 1953 Sven Ivar Seldinger made a historic breakthrough by introducing a safe technique for percutaneous access of any hollow viscous or artery or vein without any surgical cut down. So this gives rise to the birth of interventional medicine, and which is practiced by several cross specialty and super specialty. So this is this Sir Seldinger, who is a Swedish radiologist. So sir, this is the technique of Seldinger technique of vascular access. So for that, there is only three things are needed. That is one hollow needle and a guide wire and a plastic catheter or tube. So the first, as we all know, the needle is used to access the artery, and then wire is passed onto the lumen of the artery or any vein. Then the sheath is threaded over the wire. So what are the sites that are commonly used for vascular access? Most common sites are, as we all know, femoral artery access, retrograde femoral artery access, and radial artery access, which is the most oftenly used access types for to investigate any part of the vascular bed. Except for ipsilateral infraangular disease, we use antegrade CFA access. Other access includes brachial and axillary artery access, which are used when there is no safe access possible in the radial or femoral artery. Other access are popliteal artery access, for which is specifically important in case of complex femoropopliteal lesions, and pedal access for below the knee arterial interventions. So coming on to the retrograde femoral access, that is most widely used access for peripheral intervention. So optimal access site is identified in the common femoral artery against the middle third of the femoral head, just below the inguinal ligament, which is in between the inferior epigastric artery and femoral bifurcation. So we can this is for so that the adequate hemostasis can be achieved with compression against the femoral head, and retrograde approach is most commonly used, and antegrade approach for infrainguinal disease. Technique is that Selninger or modified Selninger technique. So this is an example of high femoral bifurcation. In this case, that you can see the bifurcation is high above the level of the femoral head, and in this case there is increased risk of femoral arteriovenous fistula and retroperitoneal hematoma and risk of complication. Retrograde femoral access, what guidance to be used? Traditionally, we used to do the access with help of palpation and fluoroscopic guidance to identify the femoral head with the help of fluoroscopy. Now the trend is to use ultrasound guidance, which helps in identification of the exact site of the femoral bifurcation. And sometimes what is ideally I practice, or many of the interventional radiology practice, is combination of both. That is to identify the femoral head under fluoroscopy, and then use the ultrasound to identify the femoral bifurcation. So access should be taken above the femoral bifurcation at the level of femoral head. It is taken at a 45-degree angle, access angle of the needle, and after access, that same technique is used to gain into to place a sheath inside the artery. So what are the pros and cons of fluoroscopic technique and ultrasound technique? As we all know, that fluoroscopic technique will not reliably identify the femoral artery anatomy, and in case of high bifurcation, it can result in the superficial femoral artery access. And if we only use ultrasound guidance can be easily helpful for visualization of the common femoral artery bifurcation. However, it will not clearly show the inguinal ligament of landmark, and the femoral head sometimes poorly visible, especially in obese patients. So if we use both combination of two, the chances of complications are much less reduced. Other techniques of guidance are guide wire assistance. Here, a secondary access is usually taken on the contralateral femoral, or if in the brachioradial, and the guide wire is placed into the common femoral artery, which is the target zone, and then needle is used to target the wire within the vessel. And then another is both combination of the this guide wire as well as ultrasound guidance technique. These special techniques are useful in cases of when we are planning a high or large caliber arterial access in complex aortic interventions, where we want to minimize the chances of complication. We can take both standard 18 gauge access with 18 gauge needle and 0.35-inch guide wire, or a micropuncture needle access, which usually reduces blood loss and which is specifically used in smaller arteries with help of 20 or 21 gauge needle and mini guide wire. The angle of inclination is traditionally told is 45 degree, but once artery is accessed and during passing of the guide wire, we reduce the angle so that the needle become more parallel to the vessel, and which helps in easy passes of the guide wire. Now, second axis is radial artery access. For radial artery access, as we will know, traditional radial artery access is taken into the just above the level of flexor aspect of the wrist, few centimeter proximal to the wrist flexor crease, and here so this is the traditional conventional radial access, and this is distal radial access, which is taken at the level of anatomical snap box, and it is usually taken under ultrasound guidance, which helps also us to identify the ulnar artery and patency of the palmar arch. And the technique is same as a modified Selniger or Selniger technique, and a small amount of local anesthesia is usually given to show that the vessel does not get compressed with anesthesia. And if we keep the environment a little bit warm, then it is also helps to avoid spasm, because radial artery is very prone to spasm, and for that there is also other medications, combination of medications we called radial cocktail, which is administered just after the arterial sheath insertion, which comprises of calcium channel blockers like verapamil or diltiazem, and nitroglycerin, and sometimes lignocaine. Maximum sheath size that can be put in radial artery is usually 6 or 7 French, and when we want to plan some subdiaphragmatic vessel interventions, we can use left radial access so that the aortic arch is not crossed. Advantage of radial artery access, as we can show, it significantly reduces bleeding complications compared to femoral. It results in early mobilization of the patient, so patient's preference is there, no bed rest required, and lower in infection risk, and also there is a reduced risk of injury. Other access are brachial artery access, which is usually taken in the distal arm, which is usually done under ultrasound guidance. So this is the cross-sectional ultrasound at the level of distal arm, which shows the artery and brachial artery and their corresponding brachial veins. So it is indicated when there is a femoral artery or radial artery is diseased or occluded, and when we are planning a visceral artery intervention, and when there is very acute origin of the abdominal visceral arteries, which can hamper catheterization from femoral side, and also used as an adjunct access, secondary access in case of complex EVAR procedures. The sheath side that can be placed up to 7 French, and complications is usually slightly higher compared to radial access. And sometimes when there is we need to do axillary access, usually we prefer to do a high brachial puncture apart from over the axillary artery access. Now the other upper extremity arterial access is axillary artery access. This is specifically useful in case of large bore access for EVAR or cardiac procedures like mechanical circulatory support.
Please, Dr. Papi sir, please wind up your talk in 5 minutes.
So this is the ultrasound examination, which shows that this is the anatomy, basic anatomy of the axillary axilla, and showing the axillary artery 3 segments. So puncture is usually taken at the second segment of the axillary artery, which lies posterior to the pectoralis minor muscle. And other access are popliteal artery access, which is used in case of failed integrate femoral approach, in case of femoral popliteal CTOs or high SCFA bifurcation, and when there is no proximal CSF stamp available. And here usually smaller size Cs are placed, and ultrasound is usually done with the help of ultrasound guidance, and the access site usually is in few centimeters below to the actual arterial site, which is marked here. And now coming into the complications, there are several complications: hematoma, pseudoaneurysm, arteriovenous fistula, retroperitoneal hematoma, and occlusion thrombosis. So this there are example of complications of radial artery interventions. Here you can show there is a dissection of the radial artery and with occlusion. Then there is a perforation of the radial artery. So now this is the article which shows that there is increased risk of complication in case of even upper extremity access using radial artery for doing the peripheral vascular interventions compared to brachial access. Now coming on to the last part, that is vascular access closure. Manual compression is usually the technique. However, in case of there is large bore access or whether other risk factors like obesity, abnormal clotting factors, and cooperative patient, in this case vascular access closure usually helps to reduce the complications and achieve quicker hemostasis. There are several vascular closure devices in the market. There are suture-based mediated device. There's a ProGlide, which is suture-based approximation device, which is usually placed after the sheath insertion and before, and it is closed just after end of the procedure. Here, two sutures are passed. It's usually at 10 o'clock and 12 o'clock location. If but it is also used for large bore access closure. Other is collagen plug-based devices, that is angioseal, which can be used as in 6 French and 8 French sizes. And for large bore vascular access closure, Manta is a device which can be used up to 24 French sheath. Now, there are some emergency techniques for vascular access closure when there is there is no previous pre-planned close placement. In case of large bore access, we can use dry seal technique where a balloon is inflated against the arteriotomy site before removal of sheath through a secondary access or access site, and this result in occlusion of this axillary artery. Arteriotomy. So, to conclude, key takeaways is multiple access routes are available, which need to be selected based on the procedure type and patient anatomy. Radial access offer benefit over femoral, especially in the body and neuro interventions. And also, ultrasound guidance is the gold standard whenever available, should always be used. And upper extremity alternatives are also important in case of femoral access is not possible. And the proper technique and anatomical knowledge is essential to minimize complications. And also always confirm access site location fluoroscopically before upsizing. And lastly, always need to plan the access closure or access site before the beginning of the intervention to reduce the complication rate. Thank you.
Thank you so much, sir. Next, I would like to call upon Dr. Ujjwal Gorsi, who is additional professor, PGI Chandigarh, has 114 publications to his name, and his areas of interest include genitourinary, peripheral vascular imaging, and interventions.
A very good afternoon to everyone. First of all, I would like to thank organizers, especially Dr. Tara and Ranjan, for having me here. So, topic for me today is a little different, and it's actually innovative topic, relatively new in field of intervention radiology. So that is embolization beyond oncology. For the uninitiated, embolization means blocking an artery. So intervention radiologists, they work just like plumbers. You either open artery or you block arteries. Just like plumber, either they block pipes or open pipes. So the topic which is given to me today is MSK embolization and emboroid. So we'll just see, I'm not going into technical nitty-gritties, but would just like to share the spectrum and the things which we can do which were not thought were possible a few years back. So transarterial microembolization is basically a minimally invasive treatment option, and its role is in painful chronic musculoskeletal disease for there is no well-defined treatment option available. So usually the pains which last for more than 3 months are indications, and contraindications are infections, malignancies. So there is a whole spectrum of MSK conditions in which this transarterial microembolization or TAME is coming up. It's in hand, in trunk, and also in lower extremity. Most of the literature and experience is in genicular artery embolization for osteoarthritis. However, for frozen shoulder plantar fasciitis, again, this thing is picking up. So osteoarthritis, so what happens is, as we know, there is a mechanical damage, then there is a cartilage dissection, then there is inflammation and angiogenesis, then increased inflammation, again more cartilage damage. So this is a vicious circle. So what transarterial microembolization does is, it blocks the neovascularity. The new vessels are blocked, angiogenesis is blocked. So this circle, vicious circle, it gets broken, and the patient gets reduction in inflammation, and there's also a pain relief. So visual analog score and Womack score questionnaires, these are just to assess the severity of disease before you take the patient for genicular artery embolization. So if you see on radiograph, there is a classification of osteoarthritis which is known as KL grade. So from 0, there is no joint space narrowing, to grade 4, where there is marked joint space narrowing. So this genicular artery embolization is good for 0 to 3. In grade 4, this is not very useful. So treatment, we all know that it's a graduated approach. You start with conservative treatment, then you start with pharmacological treatment, then intraarticular steroids and hyaluronic injections are given, which do not have a consistent result. In some patients they work well, but in others they may not work well. And if nothing works, then it's surgery, but that is for high grade, grade 4 kind of osteoarthritis. So GA is a selective intra-arterial embolization of genicular artery. It embolizes hypervascular segments related to pain location. So this single line, embolize hypervascular segment related to pain location, is true for all MSK embolization. Whether you are doing genicular embolization, whether you are doing adhesive capsulitis, plantar fasciitis, wherever there is neovascularity, abnormal vascularity, you have to reach there, embolize it, block it. Neovascularity decreases, angiogenesis decreases, the circle gets broken, and the patient gets well. So patient selection, so basically those patients who are not responding to conservative treatment. So anatomical details. So there are 6 arteries, 3 on medial side, 3 on lateral side. On medial side it is descending genicular artery, which is a branch of superficial femoral artery. Then you have superior medial and inferior medial genicular artery, and on left side, on lateral side you have a superior lateral genicular and inferior lateral genicular artery with the recurrent genicular ATA arising from ATA. So basically, as osteoarthritis, we all know it's the medial joint space narrowing. So medial joint is affected 5 to 10 times more than lateral joint. So you have to target descending genicular artery and the medial genicular arteries. So either you can come from common femoral artery, you can come from tibial arteries, use microcatheter, cannulate this artery, give lot of nitroglycerin, because these arteries are very prone to spasm. So once you are reached where you want to reach, then you use embolic agents. Embolic agents can be either permanent embolic agent, they can either be temporary. So aim is to prune vessels. You don't occlude vessels, you don't block complete blood supply, because the same artery is going to supply the meniscus, the cruciate ligaments, the joint capsule. So you just prune. So embolic agents, temporary and permanent. Temporary is imipenem and celastin sodium. It has got very good safety profile and it's cheap. And permanent embolic agent can also be used. Permanent embolic agents are more prone to cause some minor complications like skin changes and erythemas, whereas this does not happen with imipenem celastin. So just to show you some cases, this is the classical osteoarthritis. Here we can see there is a grade two disease, medial joint space is narrowing, you are seeing osteophytes. This is MRI, which shows that joint capsule is, so there is cartilage is destroyed, and this is surface is exposed. You also see there is a joint fluid is there in joint space, and on post contrast you will see extensive synovial enhancement. So the patient in which inflammatory component is more, in which synovial enhancement is more, they respond much better to genicular artery embolization. So this was our catheter. We started from common femoral artery, went into the descending genicular artery. You can see that there is a neovascularity here, this abnormal blush. So this is after embolization. So you don't have to block this artery, don't completely cut off the supply, just block, just give slowly, so that this abnormality, the neo vessels have disappeared. So again, for superior medial genicular artery, similar thing was done. Another patient, this is grade 3, more severe disease, more synovial inflammation. Here the arteries which were involved were different. So here you can see that there is a superior medial genicular artery and inferior medial genicular arteries, again showing that abnormal blush, and it was embolized. So endpoints, as I'm telling you, you have to embolize the neovascularity, not block the parent artery as such. Clinical success is usually good. So this was our paper. I think it was the first paper from India which studied this genicular artery embolization. And then there are multiple meta-analyses now which tells you that this treatment works well. So other indications are frozen shoulder, which is also known as adhesive capsulitis. So it's again a very therapeutic dilemma. Even surgeons don't know what to do, because it's a self-limiting condition. It will resolve on its own within 2 years if you don't do anything. But those 2 years can be challenging. So if patient is not responding to pharmacological treatment, then we can offer this treatment option. So imaging wise, if ultrasound CHL ligament is more than 3 mm, axillary recess is thickened. On MRI, if coracohumeral ligament is more than equal to 4 mm. So this is how you diagnose on MRI. So you can see that there is a axillary recess thickening here. CHL ligament is thickened, and IGHL ligament is also thickened, edematous. So those patients who are not responding to pharmacological conservative treatment can be taken up for embolization. Here again there are 6 arteries. So suprascapular is the first, second is thoracoacromial. So this thoracoacromial is the artery which is mostly responsible for this, is commonly responsible, though other arteries like coracoid branch, scapular arteries, and anterior and posterior circumflex humeral arteries can also be involved. So you can do this procedure either through femoral route, or now more and more people, they are trying to do it from radial side. So you puncture radial side, get your catheter, and you see this abnormal blush. This abnormal blush is the one which causes symptoms, which causes pain, and you embolize it. Make sure you don't embolize the complete artery, but only the neovascularity. Another indication is plantar fasciitis. Again, the same problem. Surgeons, even they don't know after some time what to do with this kind of patients. So it's an angiofibroblastic hyperplasia, vascular component is there. So imaging findings, radiographics, there can be a spur on ultrasound more than 4 mm. If plantar fascia is thickened, it's diagnostic. And hypoechogenicity of plantar fascia is also found. In MRI, more than thickness 4 mm is almost 100% diagnostic. So just on X-ray, you can find a calcaneal spur. On ultrasound, you can see that this is abnormal side, this is thickened, this is the normal side, which is less than 4. And on MRI, you can see that there is edema, and there is also thickening of this plantar fascia. So again, you can do an integrate puncture, come into common femoral artery, put a microcatheter, see the artery which is showing a normal blush, and embolize it. Or you can also now, people are also doing it at ultrasound guidance. So here there is a posterior tibial artery. This is the abnormal blush. You go inside, inject imipenem celestin, break this chronic inflammatory cycle, and the patient recovers. So now people have also started doing ultrasound guidance, where you just puncture the posterior tibial artery. Here is the posterior tibial artery, and when you start injecting, there is a color change. So it's a transient discoloration happens, which returns to normal within approximately 15 minutes. So this is, once it returns to normal, so you know that this treatment, and patient usually tells immediate pain relief. Even while being the procedure is offered, patient will tell you that he is feeling better. Again, chronic soft tissue pathological conditions, which again no one knows what to do with them. So these kind of conditions, this responds well. So mostly the studies have been on tennis elbow or lateral epicondylitis. This is a brachial artery run. From here we can see that there is a radial recurrent artery which is supplying this abnormal blush. You embolize this and the patient gets better. So this was the one part of my talk, that is transarterial microembolization for chronic MSK conditions. The other is a new entity which is known as emboroid. So this is rectal artery embolization for hemorrhoidal disease. So first, anatomy. So hemorrhoids are present in anus in everyone from the birth. So they are not only venous channels, they are blood lakes. So blood lakes have small arterioles and venous vessels which are grouped in clusters and attached to the anal wall. So what the current pathophysiology of hemorrhoids is that there is a vascular theory which is responsible for hemorrhoids. So arterials supply to the corpus cavernosum recti. So CCR are these normal vascular channels, so they are the vascular lakes. So when they become chronically inflamed, when they enlarge, when they prolapse, so then they become what is known as hemorrhoids. So hypertrophy of the hemorrhoid vascular plexus happens. There is a chronic inflammation, it recruits more vessels, there is more AV shuntings. So congestive symptoms happens and this prolapse start happening. So there is a vascular endothelial growth factor overexpression here. So again, if you are trying to do this procedure, C for hemorrhoidal bleeding score and C for Golayer classification, which is there for these hemorrhoids. So grade 4 usually do not respond because prolapse is significant. 1, 2 and 3 are the one which is in which you can go. So procedure is actually simple for people who are doing interventions. So you just go into inferior mesenteric artery. There is a terminal branch, superior rectal artery. It has 2 branches, anterior and posterior. Go there. Mostly these hemorrhoids are supplied by anterior branch. Go inside the anterior hemorrhoid branch as close to the hemorrhoids as possible. You can inject larger PVA particles, 500 to 17, or you inject coils and you are done. Mostly supply is from superior rectal artery. In around 20-25% of patients, supply can be from middle and inferior rectal arteries, which are branches of anterior division of internal iliac artery. So if you don't find anything on IMA run, go there and see, you might get supply from internal iliac artery. So indication, grade 2-3 prolapse, as I just told, these are the indications. So this is a typical patient. You go into superior rectal artery and you see this extensive blush. You put 2 coils here and your job is done. Again, in another patient, you see that there is this corkscrew kind of thing is the abnormal vessels within the hemorrhoids. So you go there, put a coil here, similar case on the left side, put coils, and your job is done. Technical and clinical success rates are good. Clinical success rate is also acceptable. So just to conclude, these have expanded the role of intervention radiology in functional symptom-based care, and these are very, you can do it in OPD. You don't need admission. You don't need a big setup. So you can just have a cath lab. These patients, elective procedure, office care-based procedures. So minimal, durable, and patient-centric treatment options, and they are still in their early stage. Not very robust data is not available, but then so many studies are coming up. And results appear promising. Thank you all for your patient hearing.
Thank you, sir. Next, I would like to call upon Dr. Deb K. Barua, who has fellow in oncoradiology and neuroradiology, has around 83 publications to his name, and is currently working as an additional professor in the Department of Diagnostic and Interventional Radiology, AIMS Guwahati.
So good afternoon to all. At first, I thanks Dr. Suparva, Dr. Tara, Manoj, and Ranjan for inviting me and giving us such an opportunity to talk on renal interventions. So my talk is on endovascular management of renal artery pseudoaneurysms, which are very commonly encountered because of that nephrologist, urologist, they are doing too much renal biopsy and cases of post-PCNL. So as a IR, we are getting these cases commonly from nephro and urology. So my learning objective in my presentations to know the most common etiology, the variable presentation and history, how that renal artery pseudoaneurysms are developed, and to understand the diagnostic imaging modalities from ultrasound, CT or MR angiography, how they helps in managing such patients, and describe few tips and tricks in technology. So what is renal artery pseudoaneurysm? You see, in any pseudoaneurysms, that blood leak is there which is not covered by the 3 layers of normal arteries. So it is surrounded by adventitia or adjacent soft tissue. So they're forming an irregular separate aneurysm or bulge or out bulge that is called pseudoaneurysms. The most common cases we are getting from renal biopsy and patients of the partial nephrectomy and the patients of trauma, commonly from the penetrating injury. And another important part is the post-PCNL bleed. And few cases we might encounter in patients of polyarteritis nodosa or mycotic aneurysms. So as we all know, the presentations, it's most commonly the patient presented with hematuria, flank pain, or maybe we may encounter incidental renal artery pseudoaneurysm without any symptoms. So coming to the anatomy, as we all know that renal artery arises from the aorta at L1, L2 level. It divided into 2 branches, anterior and posterior branch. This anterior branch give 4 divisions and it form an initial intersegmental artery, then interlobular, then arcuate artery. So in post-PCNL and renal biopsy, we are commonly get injury to the interlobular as well as arcuate arteries. So coming to the appearance of pseudoaneurysms. So these cases having a 30-year male patient, post-PCNL bleed patient, the plain CT shows some blood in the dilated renal calyx. Here, the hydronephrosis we are getting on the post-contrast CT images. And this patient underwent DSA. In DSA images, we are getting lobulated lesions here. So video shows, if you see the video, initially we are getting a lobulated feeling, and secondly, we are getting more density in the initial part and less density in the medially located part. So this is called pseudoaneurysm. It is not true aneurysm. If you see the true aneurysm, we are getting the same density should be in the DSA. So indication of intervention. See, all patients, those who are presented with recurrent bleed or severe hematuria, then we have to do, even don't think from size of the aneurysm, we have to go for endovascular treatment. So endovascular treatments, the commonly as to the residents, we are using diagnostic catheter RDC that is called renal double curve, or you can use the C1 catheter. This is for diagnostic angio. After diagnostic angio, we are using the micro catheter. You may use the Progate micro catheter 2.4 to 2.9 frames. Asahi catheters also there. Then we are, for this embolizing this pseudoaneurysm, we are using micronestar coil or microcoil. We can use the NVCA, that is glue, vascular plug, and gel foam. This can be uses for interventions of renal artery pseudoaneurysms. So coming to the cases, I am presenting 5 cases. This is the 40-year male post-PCNL patient bleed. This is the MR T2 and this is T1 weighted MR images. Here we are getting ill-defined central hypo and peripheral hypointense lesions, and there is associated blood in the dilated calyxal systems. This is the corneal stair images very nicely, so something T2 hypointense peripheral lesions. It shows intense post-contrast enhancement of contrast MR images. So it is a dealing with the intense vascular lesions. If you put a Doppler, we are getting the classical of yin-yang pattern of Doppler flow. So this is the case of renal pseudoaneurysms. So this angiogram, initial angiogram, we are getting some irregularity here. If you see the video, this is the small jet of blood is coming. So this is large pseudoaneurysm. If you see this next video, you can see the movement of the blood flow within the pseudoaneurysms. So this is a classical case of pseudoaneurysms. Again, the movement of the blood going while doing the DSA, we can able to see, as we have seen in the Doppler images. So this patient underwent coil embolization. We have selected, we are put the microcatheter there near to the parent artery, then we are putting coil. After coil embolization, we have taken diagnostic DSA. It shows that complete non-visualization of the pseudoaneurysms. So this angiogram image shows that complete non-visualization of the renal artery pseudoaneurysms. So this most commonly the renal artery pseudoaneurysm we are treating with coil embolizations rather than other particles. So next second case, this is 27-year male patient having recurrent episodes of hematuria. That hematuria is not gross, it is mild hematuria, but patient had a history of all abdominal injury. It is blunt abdominal injury. This is CT images. The CT image shows some vascular enhancing lesion in the lower pole of right kidney. This patient also having accessory renal artery. Here we are getting the AVM formation in the right kidney lower pole. So this is DSA image. We have taken diagnostic angiogram from the right renal artery. Here we are getting the right lower polar AVM formation is there. This is classical of AVM nidus formation. You can see in the this is video. You can able to see this nidus formation. It is draining into the renal vein, and there is also early opacification of the IVC. So this patient having renal AVM. So this patient we think underwent. Sorry. This patient we have treated initially with PVA particle followed by glue embolization. After glue embolization, that lower pole is completely occluded. There is no draining vein also. But another most important finding in the late images is that we have to see how the renal parenchyma is preserved. So this is we have to think from preservation of the renal tissue. Here after PVA as well as glue embolization, this lower pole part is necrosed. So it does not show any contrast opacification in the delayed image. So renal preservation is another important in renal interventions. So third case, this is 33-year female patient. This patient did renal biopsy. Day 4 she had bleed. So she presented with large hematoma in the perinephric space. In ultrasound images we are getting the large perinephric hematoma. This is MR images, this is T2 and this is T1 MR images. We are getting T2 hypointense bleed. This is hyperintense on T1. So at the large acute posterior perinephric space bleed. You can see the biopsy site of the lower pole of the left kidney. We did MR angiogram. This is twist MR angiogram, new technique. You can able to see small vascular filling in the lower pole of the left kidney. We underwent DSA, but the negativity point is that DSA we are not able to get any active contrast extravasation or any active contrast leak or any pseudoaneurysm formation. But here we are getting some irregularity in the vessels. This is artery. That artery we thinking we completely embolized with coil. We completely occlude that artery, and after that complete occlusion of the artery, patient don't have any episodes of hematuria. So DSA sometimes fail to recognize that injured vessels. So we have to think also help from the MR angio or CT angiography. So case 4, this is the 37-year female patient, post-PCNL bleed, developed hematuria after 6 days of surgery. This patient have hydronephrosis on the ultrasound images. If I increase the color again, we are getting some abnormal mixing of the aliasing of the blood vessels. So probably this patient having AVF formations. So we did MRI. MRI also seeing some ill-defined lesions here in the lower pole. It shows some contrast filling on the MR angiogram. Here the lower pole in the axial images also show hematoma formation, irregularity at the cortex of the right kidney. So this patient underwent DSA. DSA shows irregular AVF formation, arteriovenous fistula formation here. So this is the associated pseudoaneurysm is there. This is renal artery pseudoaneurysm associated with AVF. So usually renal artery pseudoaneurysms may be isolated or it can be associated with concomitant arteriovenous fistula formations. See, this patient underwent coil embolizations. We are putting the coil here, and after coil embolizations, we are doing the DSI. It shows to complete non-visualization of the pseudoaneurysm as well as AVF. So minimal renal pseudoaneurysm is filling up, but in subsequent images we are getting complete non-opacification of the renal aneurysm. And last images does not show any evidence of renal vein opacification, so indicated the complete occlusion of the AVF with aneurysm. So this is last case. This is 33-year male post-PCNL bleed patients. This is the CT angiogram images. It shows irregular outposting in the lower polar branch. It is very nicely seen on the sagittal images. The VRT sometimes fail to give you the finding in the renal angiogram. So we did DSA. DSA show irregular lobulatal lesions here. So this is diagnostic DSA. You can able to see something irregular outposting is coming from the lower pole. If you do microangiogram, so we have taken micro catheter up to the Prograde catheter up to near to the parent artery of that aneurysm. We see that more irregular lobulated appearance of the pseudoaneurysm. So these are the classical images how you can differentiate two from pseudoaneurysms. And this patient underwent coil embolizations. We're putting the coil here. After coil, we have taken that angiogram. It shows complete non-visualization of the aneurysms. So that is the beauty of intervention radiology, that the patients, the symptoms relieve within very short time. It is a life-saving also in patients of heavy gross hematuria. So coming to the algorithm, basically for the resident, it is very important to suspect renal artery pseudoaneurysms. So always we have to think for routine B mode ultrasound followed by Doppler. And if you suspected in ultrasound, then you have to go for CT or MR angiography. And the patient with identifiable feeder, usually we have to do interventions with proper selection of the materials, whether you are going for coil embolization, PVA particle, or glue. So nowadays, in most of the literature from the India as well as abroad, the coil is the initial choice for embolizing the renal artery pseudoaneurysms. So coming to the take-home message is that renal artery pseudoaneurysm is also uncommon but potentially life-threatening conditions. So early recognition is very important. Early suspicion is very important in ultrasound, CT angio, or MR angio. So endovascular imaging is the preferred modality of choice for treating such renal artery pseudoaneurysms. And these having very high success and good renal preservations. Lastly, I have emphasis that renal preservation is very important. If you able to embolize more than 50% of renal tissue, that the patient might develop more complication, more pain, and more subsequent infections. So that is very important. And choice of embolic material is very important. And close attention is always needed. After doing the embolization, you have to do follow-up imaging. Either you go for ultrasound or CT angiography. So thank you.
Thank you, sir. Now we come to the final talk of this session. I would like to invite Dr. Tanya Yadav ma'am, who is an assistant professor in Department of Radio Diagnosis, SGPGIMS, Lucknow. She is one who has a keen interest in intervention radiology.
Good afternoon, everyone. I'm very grateful to Dr. Tara sir and Dr. Ranjan sir for giving me this opportunity to come here and present about the atherectomy devices. So, what is the challenge that we face currently in peripheral artery disease is that the traditional devices that we have, that is the balloon and stents, they were able to solve a lot of problems, but they come with their own problems. Like while ballooning, there is high chances of recoil, there is high chances of dissection, and after stenting, there are chances of stent block, stent fracture in the leg because of the heavy muscular movement. So we need to come up with better solutions to tackle these problems of angioplasty and stenting a metal inside the body. And what do the surgeons do for this? They do end arterectomy. And what is end arterectomy? They cut open the artery and remove the plaque. So we need to do something like that. Instead of just pasting the plaque on the side of the wall of vessels, we can also remove the plaque endovascularly. So the need of the hour is an endovascular solution which can remove plaque, prepare the vessel, and minimize the need for a permanent implant, that is stent. To tackle this, atherectomy devices have come up. What are these atherectomy devices? They help in endovascular removal of the plaque. It is a special catheter with a special tip. It could be laser or rotating blade, and it removes the plaque and takes it out of the vessel. There are different types of atherectomy devices. Directional atherectomy, it is used for eccentric plaques, And many examples are there like Hawk 1, Silver Hawk. They are used in calcific eccentric lesions. This is a video of how the device works and how it cuts the plaque from within the vessel. Eccentric plaques are getting shaved off and they will be removed from the vessel. So another one is rotational atherectomy. So directional ones are good for eccentric plaques. However, when there is heavy plaque burden, long segment, complete occlusions are there, we need something more. So rotational atherectomy devices, they have high speed rotating burr or cutter. And one of the example is Jetstream by Boston Scientific. And one of the biggest advantages is that they also continuously aspirate. Instead of just cutting the plaque, they are also aspirating it out of the body. So what does Jetstream atherectomy consist of? It consists of front cutting blades for smooth entry into the calcified occluded vessel. Then they have expandable blades for achieving more and more luminal gain. And it has aspiration ports. So the plaque, whatever is cut, is simultaneously aspirated out from the vessel. So it has rotational cutting, active aspiration, and vessel preparation. And depending on the user's choice, we can use it without the blades up or with the blades up. It's a small video which shows how the Jetstream device works, and then we'll look into some cases. So this is the Jetstream catheter with the blades down currently, and the front cutting blades are cutting the plaque, and simultaneously everything is getting aspirated out from the vessel without any risk of distal emboli, with very little risk of distal emboli. So that's how it's done. Next, we can do it with blades up also to remove more of the plaques. And the long-term patency results have been quite good, with 12 months patency of 91% and 3 years patency of 70%. The usage of metal, that is stent, has been brought down to 6.3% rates, which is quite good. So now we'll look into some cases where this Jetstream has created wonders. So here is a 63-year-old male patient with type 2 diabetes mellitus and tobacco chewer. He had history of left leg amputation, so only right leg was remaining, and it was very precious. So right leg developed rest pain with fourth toe tip gangrene and heel gangrene. This time the patient was very vigilant since he had already lost one leg. He also had history of AKI in November 24. So CT angiography was not done because of the risk of contrast nephropathy. Doppler showed multifocal dense calcific stenosis in the proximal SFA, and distal SFA showed monophasic flow. ATA and DPA showed power stardust flow. PTA was posterior tibial artery was not visualized. So this is the DSA angiogram. We took a antegrade axis into the femoral artery, and we can see that these are areas of complete occlusion. Two focal areas of complete occlusion are seen in the SFA, and this is the branches of profunda. So with careful negotiation, the wire was passed into the occluded femoral artery, and the wire was parked distally. Since it was he had only one limb left, so we used a filter in the superficial femoral artery to trap any emboli which we can send to the tibials. Next, atherectomy device was placed, and here you can see, like we saw in the animated video, this is the Jetstream catheter, and it is advancing into the stenosed areas. So post atherectomy, we can see that some luminal gain has been established, and next we did it with blades up. So again, after opening the blades, we did the atherectomy to achieve more luminal gain. And post atherectomy with blades up, good luminal gain was established, and there was near complete resolution of the stenosis. Next, we did a balloon angioplasty with drug-eluting balloon. Here is the balloon inflation and we inflated the balloon across these stenosis segments. And next, when we took out the filter, we could see that there was some debris which we had collected in the filter, so it was a good choice to use the filter in this case. Next, the final angiogram showed complete resolution of the SFA stenosis. Now there is no stenosis remaining, and this is the tibial distal leg angiogram. And it was around 3 to 4 months later, this was the toe gangrene, and now it has healed almost completely, and the heel gangrene also has recovered completely. So another case, 35-year-old male, avid tobacco chewer, and he was a rickshaw puller by profession. His profession was very important, as we will come to know later. He was hypertensive, non-diabetic. He had a history of thrombotic acute limb ischemia in July 25, which was managed conservatively. Symptoms improved on best medical management. However, he had developed claudication at 500 meters, and it was affecting his job. That was his only means of livelihood. So we had to resolve his claudications. On Doppler, there was thrombotic occlusion of the popliteal artery. There was reformation at the tibials with monophasic flow in the ATA and PTA. So this is the angiogram. We could see that this SFA is visualized still here, and in this segment, the distal SFA and popliteal is blocked and replaced by collaterals, and lower down, there is reformation of the anterior tibial artery. So we negotiated the wire across the stenosed popliteal artery, and after the wire was negotiated, this is the jet stream catheter in action, and jet stream is removing the chronic thrombus. We extended the jet stream into the tibial arteries also, because the caliber of tibial arteries was quite good, so we extended jet stream even into the proximal ATA. And after atherectomy, we can see that the popliteal artery has very well opened, and the ATA and PTAs are now seen, and the flow has become triphasic in the multiphasic in the DPA also. So this is his foot angiogram. There was some chronic thrombus in the distal PTA, however, we left it as it is, as one artery, one runoff is sufficient to solve the problem of his claudications. Now, this is third case. She's a 78-year-old female, tobacco chewer, hypertensive, non-diabetic. She had a non-healing wound on lateral aspect of the foot. It was not healing for last 8 months from what she said. Doppler revealed complete occlusion of the SFA long segment. There was prominent profunda and collateralization was good. However, since the wound was not healing, we decided to intervene. The ATA, anterior tibial artery, showed monophasic flow on Doppler. So we took an retrograde axis for her, and this is the wire from the right-sided SFA into iliac and then into contralateral femoral, and we can see that SFA is only seen in this part, proximal part. This is the profunda, and below that SFA is not seen. And on angiogram, we can see that some formation of the distal SFA was visualized at this part, in the distal SFA part. And popliteal and tibials were reforming through collaterals. So again, we negotiated the wire through the obstruction, occluded part of the SFA. And after crossing the wire, we did jet stream atherectomy. However, we were expecting very good results after the atherectomy. However, the results were like this. There was active contrast extravasation from the SFA. So what we had done is, while crossing the wire, it went subintimal, that is within the wall. So this is what had happened. Sometimes instead of going through the plaque, the wire can go subintimal through the walls of the vessel, and if this has happened and we do jet stream from within the subintimal space, then it is very likely that the wall will perforate, and this is what had happened in our case. So ideally, after negotiating the wire in the occluded vessel, you should always check whether the wire has passed intraluminally or subintimally. This was our very first cases, and it was a mistake on our part that we didn't check that whether the wire had gone subintimal or intraluminal. So immediately, and also while doing the atherectomy, the wire got stuck in the jet stream, and we lost access also in the vessel. So now when we were trying to negotiate wire through this perforated vessel, we were not able to cross it. So we came from below, we took puncture in the dorsalis pedis artery and cannulated the perforated vessel from retrograde axis, and we successfully cannulated it from retrograde axis. Then we deployed a stent graft across the rent that we had created iatrogenically, and after deploying the stent, there was decent flow in the SFA and lower down into the anterior tibial artery. So we should always be vigilant while using these devices. While they give very good results, but if not used carefully, they can be catastrophic also. But with careful measures, good results can be obtained. And this is the Doppler for her on the next day of procedure, day 2 of post-procedure. And her wound has also healed now. The lady has recovered well. So the take-home messages are, while atherectomy devices are very good to use, they can give you results just like surgical endarterectomy, and the usage of metals stents can be reduced. However, they should be carefully used, and there's a learning curve to it, and it should be used carefully in each and every case. Every case is a learning for it. Thank you.
Thank you, ma'am. That was very insightful on atherectomy devices. So finally, we come to the end of the session on vascular interventions. I would like to thank all the chairpersons and speakers. I would next like to call upon Dr. Supra, ma'am, our HOD, Radiodiagnosis, AIIMS Bhubaneswar, to felicitate the chairpersons and speakers. The chairpersons for today were Dr. Savitri Bhagat, ma'am, and Dr. Sangram Pada, sir. I would request you to come towards us. I would like to also call upon all the speakers of this section, starting with Dr. Bappi Burman, sir. Dr. Ujjwal Gorse. I'll just I request the chairperson to join the speakers for a photograph. Thank you, everyone. So before we start the final session of the day, we would like to The next session would be the general body meeting of ORIA. Simultaneously, tea would be served. The session by Dr. Manju Rumani ma'am would be after this. Thank you.
Okay. So I would like to thank you all, especially the organizers, to have me here to speak to you in gynae imaging. And actually it has been interventional since morning. I've really enjoyed my talks and I feel we don't know anything. So thank you so much for inviting me and making me feel, as a radiologist, I feel that I'm a radiologist first than anything else. And I really am honored actually to come to a radiology association, even though I'm a radiologist myself. But now in India, they've started differentiating between ultrasound and radiology. Why they do that, I don't understand. Anyway, I'm going to be speaking on enhanced myometrial vascularity and retained products of conception. Now, color Doppler plays a very important role when we are trying to diagnose and also in the management of these lesions. For an EMV as well as RPOC. Now, this is non-invasive analysis of visualizing and quantifying blood flow to the uterus, ovaries, and adnexa. It gives the anatomical, physiological, and functional aspects of vascularity, and then those changes which get reflected as pathological changes in these organs. The Doppler ultrasound techniques which we use to visualize blood flow is color Doppler, power Doppler, slow flow visualization, slow flow Doppler. And then spectral Doppler, which is velocity and resistance of blood flow. Now, we talked of all these terms. What is the difference between them? Color Doppler gives us the speed and direction of blood flow and evaluates basically the large vessels. It's less sensitive for small vessels and areas of slow blood flow. Whereas power Doppler is very sensitive to low flow velocity and small vessels, but it does not give us the direction of or the velocity. The slow flow visualization, slow flow Doppler, these are different terms which are used for same thing. Now what it does is it detects blood flow which has very, very low velocities and very small blood vessels. It's very good for microvascular imaging. Color Doppler settings also have to be very important because they have to be standardized so that we get consistent and accurate measurements of the blood flow. Now here what we do is we identify the region of interest using the transvaginal ultrasound, which should be anywhere between 9 to 12 megahertz, and we use 6.5 to give us better resolution. So after identifying the region, we have a color box, put it over the region of interest, and smaller the color box, better the frame rate. Now here the color box is very large, so it's not good. You should have a smaller box so the smaller frame rate and PRF improves. Adjust the Doppler gain so that there is no artifacts. Then we take the velocity scales at 3 to 6 centimeter, wall filter adjustment to 30 to 50. And the other thing which is very important when we are taking a spectrum is to have the angle of insinuation which is less than 60 degrees or as close as possible to 0 degrees. When we have that, the Doppler spectrum comes out much better. And PSV is angle dependent, whereas PI and RI are angle independent. Now coming to EMV, enhanced myometrial vascularity and uterine AVMs describe the sonographic appearance of a hypervascular lesion in the myometrium. Here we have a uterus which shows a very, very hypervascular myometrium and also with turbulent blood flow. Both these terms are used interchangeably, but the pathophysiology and management of these two conditions is completely different. Now, EMV is the presence of transiently increased blood flow within the myometrium and generally associated with complications of pregnancy. Whereas uterine AVM is a vascular structural abnormality in which there's an abnormal anastomosis between an artery and vein bypassing the capillaries. And this may be congenital or may be acquired. Now, ISWOG in 2015 recommended that EMEV is a better term or a preferred term over acquired AVM. Now, if I show you all these three different patients with enhanced myometrial vascularity, the first is a physiological and transient. This is seen in almost 50% of the patients on the third postpartum day. And this resolves spontaneously, nothing to be done, just need a follow-up. Whereas this patient had retained products of conception, so we see a lot of rich tortuous vascular network in the myometrium, and here one needs to do surgical removal under ultrasound guidance. And the AVMs, true AVMs are extremely rare and they cannot be treated, they have to be treated by embolization. EMV is almost exclusively seen in association with recent pregnancy. The prevalence is anywhere between 1 and 6%. They present with profuse vaginal bleed, and the pathology is that the abnormal vessels are thin walls and they get disrupted after miscarriage or uterine instrumentation. And this particular paper, they said that EMV represents a delay in involution of the vessels at the placental implantation site in the absence of RPOCs after cessation of pregnancy. Now, enhanced myometrial vascular is secondary to RPOC, which may be from early pregnancy loss or termination of pregnancy. It may be from retained placenta, which may follow vaginal delivery or C-section. Now, or in cases of cesarean scar pregnancies, and is also seen in gestational trophoblastic disease. Now, on the ultrasound, what we see is we see these long, elongated, tortuous, spiral vessels which are going within the myometrium, and there can be a heterogeneous collection within the endometrium, and 3D is useful because it shows you that there is endometrial involvement and there's loss of myometrial endometrial junction, which is irregular. But color Doppler is the answer to all this. It just picks up color. It becomes extremely vascular. We have these tortuous vessels with turbulent flow, and the important thing is we trace these vessels which go all the way from the endometrium into the myometrium, all the way up to serosa. Now, sometimes they also present as these ill-defined hypoechoic or cystic areas and endometrial fluid collection, and there may be asymmetric myometrial thickness. Color flow, again, diagnostic, dilated myometrial vessels, chaotic architecture, color mosaic, and flow reversals. When we see all these things, these changes are pretty much consistent with the uterine EMV. Color Doppler gives high flow velocities at the implantation site. But the vessel, spiral and radial vessel, which is away from the implantation site, do not get enhanced. So there the Doppler spectrum will not give high velocity flows. PSV more than 60 centimeter per second indicates a higher hemorrhagic risk. Now, spectral evaluation for a PSV is again very important because otherwise we don't get correct values. We identify the region of interest, we increase the PRF, so only the dominant vessel which we can see gets highlighted, and that's the vessel which we need to take a spectrum. We narrow the sample volume, we do the angle correction, like I said, it's very important, and then we take the spectrum. Now, this is important because it differentiates the women with high velocity flow for increased risk of bleeding and other complications. Now, this particular group gave an importance of spectral Doppler. They said if the velocity scales are 60 to 70 centimeters per second, they need uterine artery embolization. When it's 40 to 60, expectant management. Clinically, there's no prolonged or severe bleeding, provided there's no prolonged or severe bleeding, whenever we are having an expectant management in these patients. When it's less than 40, it has a lower risk and we can follow them up and just leave them conservative management. Now, coming to RPOC, these are persistence of placental or trophoblastic tissue and of fetal tissue in the uterine cavity following delivery or miscarriage. It's almost like 2% of all full-term vaginal deliveries, 15% of medical abortions. It occurs with higher frequency when there's a placenta accreta and with second trimester miscarriages. Clinically, they present with profuse, abnormal, persistent bleeding, and they can have abdominal or pelvic pain. Beta HCG is a very important factor. It may be mild to moderately increased. And if it's not treated properly, it leads to intrauterine additions, and that can affect the fertility. Now, they present as echogenic masses. 3D is not very helpful, but it does tell us that it's an endometrial lesion and there is a involvement of the myometrial interface which becomes irregular. And then when we put in color, there is increased endometrial vascularity and there is increased myometrial vascularity. They can also present as a very heterogeneous endometrium or as a heterogeneous cystic collection in the endometrium extending into the myometrium. And when we put in color flow, we find this patient had a diffusely increased hypervascular myometrium, whereas this patient had a focally increased vascularity in the anterior myometrium. And both these patients had this thing, EMV, and the sensitivity and specificity, when we use all these parameters, is almost like 100%. Now, thickened endometrial complex is another sensitive finding, but it's not specific. 15 millimeters is the cutoff which they give, but they also say that it's not very specific. It may be sensitive. But clinically significant RPOC is when the endometrial thickness is more than 10 millimeters, and it's 2 weeks post treatment for whether it's spontaneous abortion, whether it's MTP, or on a patient who's had a recent DNC. And less than 10 millimeters, the possibility of the clinically significant RPOCs is low. Vascular patterns which are described is, one is minimal. Basically, there's no endometrial flow, but there is myometrial flow. So this endometrial flow is less than the myometrium. This moderate is when there's an equal endometrial flow, as well as the intensity in the myometrium is also of equal intensity. Type 3, there is marked increased endometrial flow, which is the myometrial vascularity is less than the endometrial vascularity. And when we do a Doppler spectrum, they have a high velocity, low impedance waveform. Now, why this happens, it's a transient phenomena. They don't know the etiology of this, and they may think that it may be because of arteriovenous shunting from residual vessels, which divert the arterial flow directly into the veins, or from the secretion of these vasoactive substances which inhibit the normal myometrial contraction and remodeling of the placental zone. This is actually a very interesting classification, and what they say is that when the endometrium has an echogenic endometrial mass or a heterogeneous complex, and this patient had very low vascularity and this one had minimal vascularity, these patients can be managed conservatively with monitoring. And whenever there is a marked increased endometrial vascularity, or when there is both myometrial and endometrial vascularity, these patients are prone to have high risk of heavy bleeding, and they cannot be managed conservatively. They have to have hysteroscopic resection. And that's what we just heard in the morning. They said that the radiologist actually now has to have clinical they have to be clinically talking to the patient, and also so many times at OBGYN, how should I manage this? Now I have some examples. This was a 27-year-old woman who had this echogenic focus. Sorry, the video is not playing. So she had this echogenic focus within the endometrium. There was a corpus luteum cyst, but I had to persistently ask. The history is one of the most important things when we are doing a gynae ultrasound. And then finally she told me that she had taken MTP pills to avoid not to continue the pregnancy. So she had this hyperechoic focus. When we do a color flow, there's marked increased vascularity, which is going from the endometrium into the myometrium. PSV was more than 94, and 3D actually showed us that yes, there's an irregularity in the myometrial interface, plus it's an endometrial lesion. She had uterine artery embolization. She did very well. She came 2 weeks later with just fluid and much better vascularity as compared to this way before this embolization. And 4 weeks later, the vascularity has gone down and the endometrium is pretty much normal. There's another patient, she had DNC done or MTP done in US, and she was told that she can travel, she has no problems, everything was clear. She came to India, within 24 or 48 hours she started bleeding. So she was sent to us for this thing, and she has this echogenic focus in the endometrium. Again, 3D shows us that it is localized in the endometrium, but when we do color flow with 3D power Doppler, we see that the vascularity is tortuous, chaotic, going from the endometrium into the myometrium, and these were retained products of conception. And so I asked her, can you show me the films which were done in US? And the sad part was they were transabdominal imaging. Please always do a TVS. We cannot comment on a gynae ultrasound if we don't do a good TVS scan. And that was the problem in her. So she had ultrasound guided surgical removal, and 2 weeks later her vascularity had gone down and endometrium just showed a little fluid. And just see, 8 weeks later the endometrium is beautiful. There's a very nice trilaminar endometrium, and the vascularity in the myometrium has gone down. In fact, her parents came yesterday and they told me she's had a baby now. So this was a patient who had abnormal bleed following failed attempt of embryo transfer, and she had endometrial thickness of 15 millimeters. She had been diagnosed as polyp. Again, I mean, only color flow can help us. We can see this echogenic focus, but when we put in color flow, polyps generally do not give vascularity like tortuous vessels extending into the myometrium. There's a pretty distended, very vascular focus. And so here the PSV was low, she was treated conservatively and she did very well. This was a patient who had bleeding post C-section. There's a large placental retained tissue, color flow shows increased vascularity, 3D showing a loss of myometrial endometrial interface, and there was an ovarian cyst. She was, and 3D actually was very spectacular. See the way the vessels are tortuous and increased vascularity is absolutely abnormal with a very, very abnormal vascular tree. PSV was very high. Now, they wanted to treat her conservatively because she had a very, very thin myometrium, and they said that if they do anything, she may rupture. So to avoid that, they treated her conservatively. She came back 2 weeks later and she was actually showing a better looking myometrium as compared to when she came for the first scan. So they still decided to treat her conservatively, but I think I was told that she bled so profusely. She came in suddenly in the ER with the heavy profuse bleeding, almost collapsing. So they did have to treat her surgically, and this is what her endometrium looks like immediately after the surgery. Absolutely normal endometrium, no myometrial vascularity, and a normal interface. Now, when this is nice, actually, a chart which tells us how to treat these patients. Those patients who are hemodynamically stable, or those who, and they don't have any heavy or persistent bleeding, can have expectant management and follow up every 2 weeks. Those who are unstable or heavy and persistent bleeding need to have a surgical removal, whether done under ultrasound guidance or whether they are under hysteroscopic management, but they need a follow-up every 2 weeks for the post-procedure to ensure the resolution. And then, or they can be treated with embolization. AVM are characterized by abnormal communication between arteries and veins bypassing the capillaries, and here what happens is they get these very enlarged, focally enlarged, tortuous tangle of vessels with very high velocity turbulent flow pattern. They are primarily in the myometrium and may be congenital or acquired. Now, on the ultrasound, what we see is this heterogeneous, tortuous, cystic areas. When we put in color flow, they start showing this meshwork of vessels in the myometrium. There's a color mosaic, there's multidirectional turbulent flow, there's color aliasing, and so this is for change of an AVM. And velocity scales were in this patient were about 50 centimeter. They do show a high velocity, low impedance waveform. And 3D actually shows us there's an involvement of the endometrium as well as the myometrium, because we are losing the myometrial endometrial interface, and also there is asymmetric thickening of the myometrium. Now, these AVMs occur after damage to uterine tissue. They can be associated with pregnancy, whether missed abortion, termination, or gestational trophoblastic disease, or after pelvic surgery, or endometrial CA. And clinically, they present with excessive uterine bleed. Now, here's one such patient who had a DNC just 24 hours before for missed abortion. And she came to us with severe pain. She was completely doubled up and she was bleeding. So there was a large heterogeneous complex which showed a lot of cystic areas, and color flow was obviously staring at you. It's very extremely chaotic vascular architecture. But she also, during the real-time evaluation, there was a leakage of fluid from this area out into the pouch of Douglas. So there was a tear, and that's what we reported, that there's a tear, and she was taken immediately for surgery, and that's what they said. She had RPOC with tear in the lower uterine segment and a large hematoma. She did very well for 4 weeks. Now, the thing to do is one has to tell these patients that any time, any pain, any excessive bleeding, please report to the doctors. So she was not told. So she had a massive bleed 4 weeks post-surgery. Her beta HCG was negative, and there was a large heterogeneous complex mass in the myometrium with increased vascularity, and this was an acquired AVM, and she had uterine artery embolization, and she did very well after that. This patient recently came to us with a fibroid removal. Her path report is there, which says that she had a subserous fibroid, which was removed. So here she has this complex focus with increased vascularity, and 3D reconstruction, when I talk about microvascular imaging, this is what it is. It shows you marked increased vascularity, high velocity, low impedance waveform. And we called it an acquired AVM. She had MR, and this is what she had. It was confirmed that she had an acquired AVM. Congenital AVMs are extremely rare. Generally there's a central nidus which has both arteries and veins. They are large, numerous draining veins and multiple feeding arteries. Now, gestational trophoblastic disease, which can present as a benign spectrum, we have a hydatidiform, which is partial or complete, and then it can be a malignant spectrum, which may be invasive mole, choriocarcinoma, or trophoblastic neoplasm. This is more common in women more than 45 and less than 16 years of age. Clinically, they present with vaginal bleed. The uterus is larger than the gestational period. Beta HCG is extremely high. Radiology again plays a very important role for diagnosing, for local extent, for systemic involvement, in staging and follow-up and management. MR in unequivocal cases, and in complicated cases, chest X-ray should be done to screen for metastasis, and early diagnosis is essential for successful management and fertility. Now, they on ultrasound presents as a heterogeneous myometrium and endometrium, which shows these multiple cystic areas. Color flow may show peripheral vessels, or there's like here, they're showing a lot of color mosaic and extremely dilated myometrial vessels. And there's asymmetric wall thickness. This was a complete mole, but they have to be differentiated from a partial mole where you see large placentas with multiple cystic areas involving the placenta, and there is a growth restricted fetus. Coming to malignant spectrum, we cannot actually differentiate between an invasive mole or a choriocarcinoma on an ultrasound. They both present at focal myometrial and endometrial masses with heterogeneous texture, with echogenic areas, cystic components, and extremely vascular color flow, which is chaotic pattern neovascularization. And this is due to arteriovenous communication. Now, here's one example which I put, because she was 27 years old, primary. She came for a confirmation for missed abortion, as typically you can see there's a sac and there was a embryonic pole, no cardiac activity, and this was missed abortion treated surgically. 9 weeks, post 9 weeks later, she came with massive bleed. And there was an echogenic multicystic vascular myometrial and an endometrial mass. We asked her to get a beta HCG right away, which was extremely high, and this was a patient who had a choriocarcinoma, which is abnormal proliferation of trophoblastic cells following molar pregnancy or missed abortion. And she came at 12 weeks, where it was a large lobulated uterus. Actually, you cannot differentiate. It was just a large mass of tissue with extreme marked increased vascularity. Can't differentiate into a myometrium or an endometrium. And actually, I lost her after that. I don't know what really happened to her. The other places where we can have EMVs, when a complicated cesarean scar pregnancy, they present with severe pain and bleeding, potential complication, hemorrhage, and uterine rupture. Now, here there are 2 patients again treated for missed abortion. They had DNC, and then they came with severe bleeding, and this particular, both of them showed this higher collection, which was in the lower endometrial cavity, thinning of the scar, and fluid extending into the endometrial cavity. And the color flow, this was marked increased hypervascular myometrium. This patient was bleeding so profusely that I think the doctor lost her, because she was told that she'll need to get a uterus removed, and she didn't get it done, and so we lost track of this lady. Whereas this lady had a uterine artery embolization, and she did actually very well. We followed her up, and she's delivered a second child now. This was another patient. I didn't put the earlier films. She was told that she had an abnormal looking pregnancy in the lower uterine segment in the region of the scar, and because there was heartbeat, she didn't want to do anything. When she comes back at 8 or 10 weeks of pregnancy, look at this hypervascular focus in the lower uterine segment myometrium, and it's almost, there's hardly any myometrial tissue which you're seeing, and very high low impedance waveform, high velocity low impedance waveform. She was treated with uterine artery embolization, and she did well. Now, when we have to differentiate RPOC, molar gestation, and an AVM. RPOC generally has an endometrial focus, and they have generally no myometrial involvement. Beta HCG is low, and they can be treated conservatively or with curettage. As compared to molar gestation, they have increased, like molar and AVM, they both have increased myometrial vascularity. They both show heterogeneous multicystic myometrium, a mass which is in the myometrium. Now, molar gestation will show you endometrial involvement. Beta HCG is extremely high, and they may need treatment with chemotherapy. As compared to this AVM, they are primarily in the myometrium. They don't have endometrial involvement, and beta HCG is negative, and they need treatment to be embolized. The other thing RPOC has to be distinguished from hematometra. Now, again, RPOC will show you increased vascularity extending into the myometrium. Whereas hematometra, they may show fluid debris level, they may show heterogeneous collection, but when we put in color, they just show a peripheral vessel. There is no central vessels, and this just means that the blood flow does suggest that there are no blood clots. Now, placental polyp is again a well circumcised polypoidal mass, extremely vascular, and vascularity depends on the presence of active trophoblastic tissue. These tend to be stable over time, and persistent bleeding may require hysteroscopy or targeted treatment. They say asymptomatic polyp can be monitored on ultrasound. Then we don't see this anymore, but the other thing which they can do is this missed aborted tissue can become calcified, and these are old patients with multiple calcified missed aborted tissue. When we are trying to differentiate from a polyp, I just showed you earlier, polyps generally have one single dominant feeding vessel, or they may have a branching pattern. So history is very important. There we'll give a history of missed abortion. Here we don't have any history like that. And then prolapsed cervical polyp. Again, we can see a thick prolapsed polyp, but again, history plays a very important role. And low risk endometrial cancer, which may show increased endometrial vascularity. We have to differentiate the vascularity in this myomas. The myomas generally have a circumferential blood flow, sometimes may show central vessels. But adenomyoma will show translesional vascularity, adenomyosis show diffuse vascularity in the myometrium, and we have to have the 2D findings for diagnosing adenomyoma and adenomyosis. So just to conclude, these hypervascular lesions with the myometrium with turbulent blood flow, color Doppler and ultrasound with PSV plays a very important role. It's a non-invasive analysis in diagnosing, differentiating, and management. And ISWOC said to use the term EMV and expectant management. Ultrasound tells us where we can do an expectant management and where we need to go interfere. And thank you so much for your attention. And we invite you to this WOFOM, which is in Bombay, in October of 2029. Thank you. So now I think I'll do Mullerian anomalies first, because I was told not to do the breast. So if there's time, we'll do the breast, and we can just go ahead with the Mullerian anomalies. What Mullerian anomalies? अभी 5 बजे हैं, वैसे हो जाएगा. Yeah. Okay, so in Mullerian anomalies, classification, diagnosis, and challenges, and is 3D necessary? Now, if I show the Mullerian anomalies are defined as deviation from normal anatomy resulting from embryological maldevelopment of Mullerian or paramesonephric duct. This is a normal uterus. Now, if I show you all these malformed uterus, these are all Mullerian anomalies. Hopefully by the end of it, one can diagnose them, one can classify them, and obviously as a radiologist, we these days need to give a thing of management as well. Now we need to know a little bit of embryology, which is that at 6 weeks of gestation, there are these paired paramesonephric ducts which form lateral to the ovaries. The inferior portion extends medially and fuses to form this uterovaginal septum, which at 9 to 11 weeks gets reabsorbed, and then the cranial portion forms the uterus, cervix, and the caudal portion forms the upper third of vagina. The ovaries and fallopian tubes are not a part of the MDA. Now, depending on what time the developmental problem comes up, when there's a complete failure to develop bilaterally or unilaterally, there could be an agenesis or aplasia or a hemiuterus. When there are fusion defects, they can result in bicorporal or bicornuate uterus. When there's a failure of resorption of the septum, that results in septate uterus or an arcuate variety of uterus. Now, these are very important to diagnose. clinically because they have a very high associated risk with recurrent pregnancy losses, infertility and subfertility, and implantation failure. Now here there's a normal uterus, and all these RPL and infertility may be because there's a defective structure of the endometrium. We can compare these, we know this is abnormal endometrium, and there can be abnormal vascularization. The prevalence in these groups is much higher as compared to a normal population. It may go as high as 25%. Now, MDAs are closely associated with urinary tract abnormalities. Here there's a hemiuterus. We do a pelvic ultrasound we do abdominal ultrasound to look for kidneys, and she had a single pelvic kidney. This was another patient who came to me recently, showed a partial septate uterus and gestational sac on both sides of the cavity. And when we looked at the renal she had a low pelvic kidney, right low kidney, left kidney was in normal position, but there was a tissue which was going across the midline. So she had horseshoe kidney, but we cannot prove it because she's pregnant and she's doing well. We just scanned her for 12 weeks. She's doing well, so we can't actually prove right now. We have to wait for her to deliver. And so it is actually mandatory whenever there's a requisition to look for Müllerian anomalies to do a urinary system at the same time. Classification so far we have been using ASRM, and they have modified it in 2021, which is based on anatomical and development similarities in appearance and presentation, and in management and prognosis. Eschri classification uses uterine anatomical deviations derived from the same embryological origin, and they are classified according to increasing severity of the anatomical abnormalities. CUME, or the congenital uterine malformation, by experts, they came up with an objective criteria. Eschri has a subjective evaluation, and these people came up with an objective criteria. Now, importance of ASRM includes the recent one, which is in 2002 one. The cervical and vaginal abnormalities are part of this. They have included that in their classification. There's a standardized terminology to simplify communication and facilitate scientific research. It's an educational tool that includes information regarding presentation, diagnosis, and treatment. And actually, there's a WhatsApp. You can go on that and feed your data, and they give you an answer to that. Eschri classification, the importance is that normal uterus is a part of their classification. Cervical and vaginal abnormalities are classified as supplementary subclasses. And they also say, you see, all uterine in women, different women are different size and different wall thickness. So they recommend to use this indentation to wall thickness ratio as a subjective measurement to diagnose their lesions. Absolute numbers are also completely avoided, but when we are using Eschri classification, we have to be careful because we may be overestimating the prevalence of the septate uterus. Gynecological examination may not be that helpful, but when we do a per speculum, it may be helpful because sometimes we may see a vaginal septum or a vaginal aplasia. Now here was this woman who actually on the per speculum showed 2 cervical openings, and when we do a 3D we find there are 2 cavities, but the fundal contour looks normal, and we'll decide later what it was, but this is a complete septate uterus. This patient was a very old study of mine. She had a vaginal septum, a transverse septum, and they wanted to know, is there a septum extending into the endometrium? Now here I had to do short segments, this thing, and we did get a good looking 3D showing a normal triangular cavity. Now it's very simple. It's just with the press of button. You don't have to do all this. Just press a button and you will have a 3D coronal view of the uterus. We always start off with the hysterosalpingogram because the patients who come to us are basically infertility and recurrent pregnancy losses, where they would like always to look for the patency of the fallopian tubes. Now here 4 different images. This was a normal uterus. A normal uterus on 3D has a convex fundal contour, triangular endometrial cavity, flat anterior margin, and a normal myometrial endometrial interface. Now this we can see that besides the HSC telling you there's a good tubal patency, it also shows you distortion of the endometrial cavities. Now here we see this angle is acute. So at this point, despite the fact there are 2 cannulas inserted, I would still think in terms of a complete septate, and that's what it was on a 3D. She had been sent to rule out a complete septate uterus. Now this patient, looking at these 2, you will call it hemiuterus, but don't this thing. We did a 3D on her, And there this was a bicorporal septate uterus, there was a fundal dip, and there were two separate uterine cavities which are far apart. And this patient had a hemiuterus. Now, whenever we do transabdominal, transvaginal imaging, it just gives a single cut section of anatomy, whether it's long axis or transverse view. 3D, when we do, it gives us a multiplanar format where the transverse, longitudinal, and the coronal views are visualized simultaneously, and this is the reconstituted coronal plane, which is what is going to give us maximum information. So we can render this image, and there we have a nice fundal contour and a single endometrial cavity and a single interstitial segment. Unicornuate or a hemiuterus is one uterine cavity which you cannot diagnose on a 2D ultrasound at all. Now here this patient had, if you look at his long axis thin endometrium, but it's not showing us anything else. But on a transverse view, there looks as if there's a break. We do a 3D, we find that this is a partial septate uterus, but she also, renal abnormality showed was a large AVM. Now, there was a study which was done, and where they had different authors who said that the coronal images is very good to pick up these lesions, or BCIC plane, which is nothing but we trace the region of interest in the long axis or transverse, and we have a coronal visualization simultaneously. So this is easier, and it also improves the quality, contrast resolution. Volume, using the vocal software, volume calculations are more accurate, which are useful when we are dealing with hemiuterus, and also when we are valuing the endometrial volumes. 3D measurements are useful when we are trying to differentiate the septate, arcuate, and bicorporal, and there the 3D coronal images are useful for that. We can do magic cut, which just shows you that this is the area of interest, and it shows you the complete two separate uterine cavities. TUI may be useful because it gives you the entire extent, and OBGYNs will be happy when we show images like this. And vascular, when we also do a color flow to look for the vascularity of the septum. Now, timing is another thing which I always say is very important. If we do it in 4th day, when the endometrium is thin, we may not be that sure. So here we can see one cavity, but we are not actually seeing that well. Here, 7th day, and there's one cavity here. There's something going on here. I'm not very sure at this time what it is. We call them back 14th day, classic unicornuate. There's no way you can miss that this is hemiuterus. And this patient had a normal fundal contour and two separate uterine cavities. So this was a complete septate uterus. When the endometrium becomes thin and echogenic, we get much better visualization in the coronal view. Then there are certain definitions which play a very important role when we are trying to differentiate MDA. We start off with this interosteal line, which is the highest point of the endometrial cavity. Then we drop up perpendicular from there to the lowest point of the endometrial cavity, that is the indentation depth. And we can measure the angle, which is by tracing these two lines at the indentation apex. And then we can measure the external fundal cleft. We draw the interosteal line, we draw a line going through the fundal cleft, fundal contour, and we measure this distance. That's the external fundal indentation. Uterine wall thickness can be measured on a sagittal plane, where we take the maximum thickness of the myometrium in the sagittal plane, and we take a mean of the two. Or on a coronal wave plane, we draw an interosteal line, we draw a line through the fundal contour, and we measure this distance. That gives us the wall thickness. Now, external fundal contour is one of a very important diagnostic criteria when we are looking for MDAs. Now, when there is, if I show you these two images, now here there's a convex fundal contour, and here we can see there is an abnormal fundal contour which is dipping below the two endometrial cavities. So we know that this is an abnormal fundal contour, but whenever we have a doubt, we can use this classification to evaluate the external contour. So what they say is draw the interosteal line and measure this distance from the fundal contour to the interosteal line. If distance is more than 5 millimeters, the fundal contour is normal. But when we have this fundal contour which is measuring less than 5 millimeters, that's abnormal. Or when it's dipping below the endometrial cavity, that fundal contour is abnormal. Now here this is normal uterus. I just told you what the normal uterus looks like. Normal fundal contour, triangular endometrial cavity, two interstitial segments of the fallopian tubes, and Escherichia classification calls this normal. And there is nothing of normal uterus in the ASRM. And this mild fundal contour dip is considered to be normal variant. T-shaped uterus or dysmorphic uterus. Now here what happens is there's marked increased lateral myometrial wall thickness, which is causing the narrowing of the endometrial cavity, which becomes narrow and long and tubular. And the ratio of the uterine body to cervix is normal, which is uterus corpus 2/3 as to cervix 1/3. Now these patients this is a T-shape which is associated with the fibroid uterus, and has a T-shape which is because of the adenomyosis, and then again tuberculosis, which cause so much scarring that we get these elongated endometrial cavities. Earlier, the way it was diagnosed was when this drug was given in pregnant women, which is not given anymore, so we don't see to this exposure to this DES T-shaped. So there's an increased risk of complications, which will be impaired fertility, miscarriages, or preterm labor. But it is said that a hysteroscopy metroplasty has not proved beneficial. Now, all this, what I described right now, was a subjective criteria to pick up T-shaped uterus, and which is what the Eschri classification talks about. Now, if there's an objective criteria which was given by this congenital uterine malformation group. Now here, this is only in cases where there's a doubt for T-shaped. You're not sure whether you're dealing with a T-shaped uterus. That's when this objective criteria we use. Here what we do is we draw a line from the outermost point of the endometrial cavity to the internal os, and we measure this wall thickness. Then we can measure this angle. We can draw a line, interostitial line, and we can measure this angle, which is the T angle. Measurements, I keep them with me. If it's needed, I do that. Then the other line which recently they have described is to draw an interostitial line and draw a line through the isthmus and take a ratio of this versus to isthmus. If it's more than 5, it's abnormal. And then we can also, they have said, to from the interostitial line, drop a 10 millimeter distance and measure this distance. And if that distance is less than 10 millimeter, it is for T-shaped uterus. And the importance is that if if out of these all these criteria, if 2 of the criteria are met, then it's a borderline T-shape. And if it's only 1, that's called a normal uterus. Then infantilis uterus is when there's narrowing of the uterine cavity, but this is not associated with the lateral wall thickness. Now here the ratio of the uterine body to cervix is reversed. It's 1/3 to 2/3. Now, arcuate uterus, here we have persistent anterior depression along the anterior margin. We have a normal fundal contour and 2 interstitial segments of the fallopian tubes. When we take this Eschri classification and we see that the indentation is less than 50%, these are normal uterus according to the Eschri classification. And ASRM classifies them into arcuate, and CUME recommendation gives the objective criteria, which uses indentation depth, indentation angle, and surgical correction only if there is a history of multiple recurrent missed abortions. Now, if I show you this patient who had 2 missed abortions, and we can see 2 endometrial cavities, 3D shows us 2 endometrial cavities and 2 cervices. Another patient who came with massive bleed in the 10 weeks of pregnancy showed a normal looking pregnancy here and a lot of collection on the other side. And because there was so much collection, I never thought the pregnancy would be so good. But then she told me, look at your previous images. So she knew, we had already told her that she had a partial septate and there was a sac inside the left horn, which was growing. This patient had 3 MTPs, or 2 MTPs, sorry, and she comes back persistent bleeding, and there she was, she had this collection on one horn and a lot of increased vascularity, so she had EMB, and the other side was absent. Now, if I show you all 3 patients have a similar pathology, which is a septate uterus. Now, in septate uterus, there's failure of abnormal absorption of the uterovaginal septum. These account for 55% of the uterine anomalies. In the septum is this internal indentation which divides the endometrium into 2 cavities, and it exceeds 50% of the uterine wall thickness. When the septum ends above the internal os, it's called a partial septate. When the septum goes all the way into the cervix or divides the cervix also, then it's a complete septate uterus. The fundal contour is generally normal. There's a convex contour. Minimal depression is taken to be as a normal variant. It's taken normal. But because we always start with 2D, we should start suspecting when we see these 2 endometrial cavities. Now here I'm showing you the VCI where we trace a region of interest and we have a complete partial septate uterus. And here we do a 3D and we can see that long axis axis doesn't give us too much impression. 2D transfers used 22 cavities, and this was a complete septate uterus. Now, Esri classification, when we are using, it uses the indentation depth and the wall thickness ratio. Whereas the CUME, they also add to this indentation depth and the indentation septal angle. And ASRM, which came out in 2021, uses these two criteria, indentation depth and angle, to diagnose the septate uterus. We know that the septate uterus does not prevent conception. They can go through normal pregnancies without any problem. It does not prevent them to conceive. But they can have cornal pregnancy. Smaller the cavity, the poorer the reproductive outcome. Now here's a young patient who came with persistent pain. She used to come every menstrual cycle, every 3 to 4 months. And she had a vaginal septum, and she had this fluid collection every time during menstrual cycle. We look for the vascularity of the septum, because the septal vascularity gives more problems with the obstetric complications. It's important to distinguish between partial septate and arcuate, and again, just to re-revise it, we look for the septal length, that is internal midline indentation, and for the which thickness less than 10, depth more than 10 millimeters or less than 10 millimeters, and the septal angle more than 90 degrees in an arcuate, whereas less than 90 degrees in a partial septate. If I show you these two images, and if you tell me these are normal, yes, I'll buy that. There's no way you can be wrong. Here, if I show you these, you agree these are partial septate uterus. We have a septum here and a normal fundal contour. But if I show you all these 4 images and I ask you, what will you say? Well, if I was to say, I would say all of them are partial septate if I use the Esri classification, because they have a fundal contour, they have a pretty decent dip, and they are, according to Esri, they are partial septate. But if we use the ASRM classification, these two, according to their indentation depth and angle, these two are arcuate uterus, whereas these two are in the gray zone. We don't have an answer with using the arcuate ASRM classification. But when we use the CUME modification, both these are in the partial septate. So just to emphasize that whenever we have partial uterus using Esri classification, we are over-diagnosing them. And when we are using ASRM, we are under-diagnosing them. And also what I have started doing is, whenever in a doubt where I feel in a patient like this, I add on in the brackets using Esri classification. Personally, I prefer Esri classification over ASRM because Esri is much easier to use. Now, this was a patient who had spontaneous midterm abortion at 18 weeks. So she had cervical incompetence, short cervix, and herniating membranes. And she was sent before trying to conceive for the second child. And here we can see that there are 2 uterine cavities and there is an abnormal fundal contour. Here was another girl who came with persistent pain. These are transabdominal imaging, and this is a transrectal ultrasound. So she came with pelvic pain, and there were 2 uterine cavities, and one of the cavities you can see the fluid going all the way up into the cavity, hematometra. And this was, if both these are bicornuate or uterine diadelphys, which is the name given by ASRM, or a bicorporal Esri according to Esri classification. And this is because of the abnormal fusion. There's failure of fusion of Mullerian ducts, which results into these lesions. Now, what happens here is there are 2 uterine cavities. Each has its own myometrium and endometrium. There are 2 cervices. They may have a vaginal septum, and they have an external indentation, they have an internal indentation, and they divide the uterine cavity into 2. We can see them much better on a transabdominal imaging when they are so far apart that it may be difficult to pick them up on an endovaginal scan. But here we have an endovaginal scan, and there you have to trace both these cavities separately. So one was left, one was right, and this was a patient with uterine diadelphys. Now, the other thing, the uterine volume in these is reduced as compared to a normal uterus. Now, according to ASRM, they also have a bicornuate uterus. There's an external fundal indentation, and the fundal indentation below the interosteal line. There's an internal fundal indentation. There may be a single common cavity, or there may be an internal indentation which divides into 2 cavities in the lower segment as well. And if we can measure this angle, this is greater than 105 degrees. Esri classifies them differently. They use external midline indentation, which is more than 50% of the uterine wall thickness. Now they have a sub-classification of partial bicorporal, where there are two uterine cavities and this internal indentation does not reach all the way to the cervix. It ends above the internal os. And they do not have an association with the vaginal septum. As compared to complete bicorporal, here you have an internal indentation which reaches all the way into the cervix, and 75% of the time they have a vaginal septum. And bicorporal septal, here the indentation does not reach the cervix, but the two cavities are far apart. There's a fundal indentation, and this is bicorporal septate, and the septum is more than 50% of the uterine wall thickness, and they have a vaginal septum only about 25% of the patient. Now this is a syndrome which is seen in younger age group when they start their periods, and this was a 14-year-old who presented with pain, and she had this hydrocolpus, which was fluid collection in the cervical canal, and she had uterine diadelphus. There was an obstructed hemivagina, which resulted in the unilateral hematocolpus, and they can also get hematometrocolpus. They can get vaginal cyst, and they get ipsilateral renal agenesis, and these are the patients, which is this syndrome, HWW syndrome, which we see in these young girls. Now differentiating, I've already talked about how to differentiate between partial septate and arcuate. So, and when we have bicorporal uterus, we have to look for the external fundal contour. When you have an external fundal contour abnormal, two endometrial cavities, start thinking in terms of bicorporal or a biconvex uterus. Septate uterus or the arcuate will show you a normal fundal contour. Then obviously we look for the other thing, internal midline indentation, etc. Now this was a patient who came sent for the first time. She had a history of inability to conceive, and she came for the first time for endometrial assessment, which we do with color flow, and there was very good vascularity, but she also showed a single cavity. And but she did conceive that very cycle. This was another uterus, which is small uterine cavity, and she had a smaller uterus on the other side, and she had pain, and this was an ectopic pregnancy on the other horn. This I recently did, and there was again a similar sort of uterine cavity, single cavity along the same, but there was this collection which had a fluid debris level and completely separate. It was not communicating to this uterine cavity at all. And this, another patient who had a single cavity, and this patient was persistently in pain, had a large fluid collection, and this turned out to be hydrosalpinx. So all these four patients have something which is common, which is hemiuterus or a unicornuate uterus. Now hemiuterus is a formation defect. There's normal development of one Mullerian duct and complete arrested development of the contralateral duct. They have a fully developed functional hemiuterine cavity. They are associated with, they account for almost 20% of uterine anomalies, and they have a single endometrial cavity, single interstitial segment of the fallopian tubes, and a single cervix. And I already told you this is one condition you cannot diagnose on just a transabdominal imaging. Now, when they have no absent contralateral horn, these patients may be completely asymptomatic. But whenever we have a hemiuterus, we have to look for a rudimentary horn which may be communicating, or a non-communicating horn. When there is a non-communicating horn, we look for the endometrial cavity, because if it's a non-functioning cavity versus a functional cavity, if there's a functional cavity, that's the type of patient which I just showed you earlier had an ectopic pregnancy on the rudimentary horn. Then there are these formation defects, which is uterine aplasia. This is associated with MRKH syndrome. Here there's a hypoplastic uterus or a hemiuterus. They have a normal karyotype and they have a normal ovaries. As compared to Turner syndrome, they can also have a hypoplastic uterus. They have an abnormal karyotype, but here the ovaries are streak ovaries. Now this was actually a very interesting woman. She knew at the age of 20 that she had something, she had an absent uterus. When she came to us, when she was 10 years later, she was about 26, 27, she has a large mass which is in the region in the pelvis, which has classic 2D features or the TVS features of a fibroid. And this was a fibroid, which is very rare. It's a very, very rare complication in these particular patients. She refused to get any surgery done. So we don't have an answer, but it has been reported in literature. Then there's this accessory cavitated uterine malformation or ACUM. Here what happens is there is a spherical or a well circumscribed mass along the lateral wall of the uterine wall. This does not communicate with the uterine cavity. This may show cystic component or a ground glass appearance or an echogenic component. Now both these are internet images, and here there was the same thing as spherical mass on the other side. And what happened, but the uterine cavity is normal. There's a normal uterine cavity, normal fallopian tubes and ovaries. Cervical, we also look for cervical anomalies. There may be a normal cervical, single cervix, there may be septate cervix, or there may be double cervix, when the two cervices which are far apart and they're thick and this thing. So, and in case of aplasia, there may be an absent cervix. Now we've done all this, if I ask you, but I think, I don't know if we can this thing, but if we use H3 classification, this is normal, this is T-shaped, this is unicornuate or hemiuterus, this is partial septate, complete septate, and a bicorporal or a bicornuate uterus. So we've got the answer, and by using the 2D, 3D, the sensitivity and specificity is almost 100%. And MR also gives the same sensitivity and specificity, so why do an MR? We just need to do this ultrasound. And 3D, we've already said we look for the fundal contour, which is one of the first diagnostic features to differentiate, and then we can look at the CUME criteria for looking at the indentation there to further subclassify them. And MR imaging is a problem-solving modality. And I always say, as a radiologist, if we frequently recommend additional imaging studies, it's unlikely that all the information from ultrasound examination is being considered. Thank you so much for your attention. That's it. So I would like to thank you all, and I would like to thank you all, especially you and Dr. Pearl, for having me here to be in this radiology forum. Thank you so much.
Thank you, ma'am, for your talk on enhanced myometric vascularity and Mullerian anomalies. I would like to call Dr. M.V.K. Rao sir to felicitate ma'am and the chairperson. The chairpersons for this lecture were Dr. Savitri Bhagat ma'am, Dr. Sangram Biswal sir, Dr. Sangram Panda sir, and Dr. Niranjan sir. I would like all of you to come towards the stage for I would like to thank you, ma'am. Thank you, sir.
Gimbal support করছে না gimbal support করবে
সেই ভিতরে রুমটা সাইড যাওয়া পড়ে পুরো সাইড যাইতো তো হ্যাঁ পুরো সাইড
प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च पतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो